Now I see your face.
I hear you through the speakers.
Good morning, everybody. So we're going to start in a minute, and I would just like to remind you, if you're interested in sharing a taxi or just want a taxi on your own, if you would let Kelly and Haley at the front desk know, they have a sign-up form there, so that those can be booked for you for later on. Also, we're going to do a group photograph in the break immediately after the session that ends at 10:30 today. We've also been asked if people are interested in sharing their contact details, like their emails. I think if you would prefer that your name or your email address not be shared with everybody, can you come and find me and let me know. I think it's probably going to be too complicated to send a sheet of paper around and ask everybody to sign up. But if you would prefer that your email address not be circulated to others, please come and find me during the day. And then one other thing is that we really need to keep on schedule today because we've got the lunchtime session is tied in with the university initiative on research ethics, and so we need to start that at 12. So in the question and answer time, if you could please keep your questions to kind of a short and succinct question or a very short comment as well, so that we're able to keep things on schedule throughout the day, that would be really appreciated. So welcome. I'm looking forward to another great day, and Ivan is going to introduce our first speaker.
Yeah. Good morning. Before I introduce Dr. Elise Nouvet, I also introduce myself because I did not talk with everyone here. I'm Ivan Comprou. Sorry? I'm Ivan Comprou, Director of Research and Development of Health and TPO. And Health and TPO was the organization that collected the interview data from Afghanistan, Sudan, and Nepal. I'm also, for that reason, a member of the PREA team. I've also a chair at Utrecht University in the Netherlands on mental health in post-conflict and post-disaster settings. But that's me. I want to introduce Dr. Elise Nouvet. Elise is a cultural and medical anthropologist, an assistant professor global health at Western University, London, Ontario. And she's also an assistant professor on health research methods at McMaster University, Hamilton, Ontario. And in addition to that, she is since 2012 a core member of the Canada-based Humanitarian Health Ethics Research Group. And with that background, Elisa led several research projects on affected community experiences of doing good in research and care in Nepal, Nicaragua, West Africa, Madagascar, and Canada. Her global perspective on all those research projects was on the when, why, and how suffering of marginalized populations are either ignored or recognized by organizations and the public. So, two ends of a sort of dichotomous. When it comes to the suffering of marginalized populations, her keynote presentation today is based on highlights of the R2HC funded project, perceptions and moral experiences of research conducted during public health emergencies. I give you now the floor.
Whoa, standing ovation already. This is easy. Yeah, exactly. Friendly, friendly. Thank you so much for the introduction. And I'm really happy that a spot was made for a talk by an anthropologist. We're not ethicists, but I do feel really passionately, and thanks to my experience working with the Canadian Humanitarian Healthcare Ethics Group over the last years, that ethics of research in public health emergencies really benefits from and does regularly develop in that space between lived experiences and really charged moments that can feel raw and difficult to reduce to straight narratives, as well as lessons to be learned and guiding principles based on, as we know often, what has gone wrong in the past in research, but also theories and observations of what is most likely in research to support principles like human dignity. My goal today is to present you with a number of fragments of moral experiences of individuals who participated in research during the Ebola outbreak of 2014, 2016, so affecting Guinea, Liberia, and Sierra Leone, with a particular focus on West African researcher and study participants' perspectives. And my hope is to bounce those kind of fragments that have been gathered through this research off your knowledge and diverse experiences. And maybe in dialogue with you, you can help myself and the team, Humanitarian Healthcare Ethics, as well as our partners in West Africa who are thinking through these issues, clarify what exactly is the fine line between collaboration and exploitation in research conducted during public health emergencies. So first of all, I should say that this presentation is based on discussions over several years, which will be written up very soon. But there's a lot of people behind what I'm saying today. So there's the name of the co-investigators in the top paragraph. There's also a lot of colleagues, some of whom are in the room. Catherine. Who have also helped develop some ideas around this. And of course, the study participants who shared their narratives and experiences and perspectives. And thank you to Research for Health and Humanitarian Crises for their funding, which has, and also Canadian Institutes for Health Research. I have a grant on consent complexities in global health, and that's also feeding into this analysis now. So I'm going to be, this is the structure of the talk. First of all, I'll orient you to the study on which the reflections are drawn, the rationales, the methods, some key findings specifically centered around consent complexities. And these are from narrated lived experiences. And then in accordance with the theme of the meeting, I want to tug at this notion of consent to research in public health emergencies. So I want to, woven through all aspects of our key findings, one of the things our team has found is that at the macro level, at the micro level, at the transnational level, at the level of like the very intimate interactions between research participants or even participants with one another, are explicit and implicit references to consent and different notions of what that means, expectations and norms of what consent processes can and should do, as well as concerns about the possibilities or impossibilities of voluntariness in an emergency context, such as the Ebola epidemic. We also, and then you'll see that understandings of and engagements with voluntary research participation, the more our team is thinking about these, challenge us as researchers who sit on research ethics boards and write about best practices in the conduct of research, to really question what consent does and does not do in its actual form in research processes. So there are three parts. I'll focus in specifically on participants' social rationales for participation in research, which is where I think there's something going on there that goes beyond, that forces us to think beyond normative understandings of the challenges of consent, and then propose that there's an important connection between the power of consent being limited due to processes of misrecognition that are happening in the dialogue or mismatch between how research participants sometimes enter a transaction and researchers are conceptualizing consent. Okay, so part one, this particular project. So the 10th Ebola outbreak in the Democratic Republic of Congo started last August, as you all know, in that country. And it's approximately the 28th outbreak of the Ebola virus disease since 1976, when Ebola was first documented near the river by that name, mostly known by that name in DRC. The series of outbreaks that shook West Africa beginning in late 2013, early 2014, were really a very different animal. The rapid spread and impact of the epidemic was the worst to date at that point. And the point of departure for this talk are the narratives gathered in a qualitative study I co-led with Lisa Schwartz on perceptions and moral experiences of Ebola. So the Humanitarian Healthcare Ethics Group has been working since 2009 on troubling, questioning, deepening reflection, and as well as helping to support the development of tools and policies for ethical action in humanitarian healthcare. And when our groups, when Ebola kind of came on everyone's radar in 2014, we were very aware and thought of the complexity, the ethical complexity of that particular research context, which is an area that this group also works in, research policy and emergencies, was really striking as it was to many of us, of course. While they all have their own histories, all three of the affected countries, Liberia, Sierra Leone, and Guinea, have been affected by colonialism and the long, often violent aftermath of the transatlantic slave trade. Entering the 21st century, each has struggled with civil wars, extreme poverty, and heavy international debt burdens. So there's a very high poverty rate, up to 85% living under $1 a day in Liberia, for example. Now we know that, of course, that doesn't take into account informal economies or subsistence economies, but there is visible, limited access to public services, to education in many sectors of these countries. There's a very weak healthcare system in all three countries. And as a result, many people have minimal contact with healthcare on a regular basis. So unfortunately, this interactive WHO diagram I couldn't find it again, so I have the Canadian statistic up there. But density of physicians per thousand is, in Canada, to give you an idea of the difference we're talking about, per thousand, 2.539 in 2015. In the US, that was 2.59 per thousand density of physicians. And in the countries that were affected by Ebola, we're looking at 100 times less, right? So Guinea, or rather Sierra Leone, 0.024, Guinea a little bit more, but this is a very limited number of healthcare professionals, and though there are a lot of midwives and nurses, there's still really a concentration of healthcare in cities that take a really long time to get to for people and are costly to access. So on top of this kind of context, these are also countries where there have not been many clinical trials. And in fact, one of the concerns at the beginning of the Ebola epidemic, as people were talking about bringing research in, was the expectation that a majority of participants might have no concept of what research is. So this idea of limited research literacy was anticipated to maybe be even amongst 100% of participants. On top of that, you have high distrust of governments becoming really evident to the world early on in the epidemic. As there were riots, attacks on healthcare teams, people were running away from public health safety teams in a context where Parts of the countries, when outsiders come, it has been either for political repression or for extractive industry. So there's a history there of not having any reason to trust outsiders. But then as well, there were very strong rumors that the epidemic could be, in all three countries, there were rumors that the government was aiming to inject or kill off through Ebola political opponent or areas of the country that were politically opposed to them, as well as rumors that the expats coming in were there to harvest organs from Ebola people. So you would go into Ebola treatment centers, your body would disappear, and your organs and blood were being used to feed economies, kind of vampire economies in the global north. So these debates were, there were lots of this, people were very, it was very tense. So lots of debates on ethics of research and emergencies with which many of you are no doubt familiar. In the literature emerged hundreds of articles starting in 2014, 2015, talking about adapted trial designs, controversy around who ethically should get first access to experimental treatment. But what was not clear from the media or from the scholarly literature, from the perspective of the Humanitarian Healthcare Ethics Group, was whether or not there was really attention and dialogue going on with people on the ground. And certainly, we applied for research knowing that we would go in after the epidemic. But we did really wonder if the WHO guidelines that were developed for the particularity of Ebola to try to put forth some experimental treatments with some extra guidelines on how to avoid coerciveness, how to try to protect voluntariness, how to protect the rights of research participants. It was not clear whether that would be possible, and it was not clear how research was being lived on the ground by West Africans supporting as researchers, but also participating in research. So we proposed this study and got the funding. Our research objectives: to deepen understanding of challenges and strategies for the ethical conduct of research during public health emergencies, to learn how Ebola quarantine and isolation disease control measures, such as voluntary consent, interacted with ethical standards, and to add evidence to existing recommendations for the ethical conduct of research in public health emergencies. So like a lot of work of this Humanitarian Healthcare Ethics Group, this is a project that straddles, that kind of operates in the realm of practical ethics. So we're looking for actionable solutions for real problems. But it's also informed by moral anthropology, moral philosophy. But moral anthropology is a field of knowledge that emphasizes the empirical importance of understanding social actors' moral logics in analyzing and designing best, however that's defined, healthcare, and in this case, health research practices. So moral logics here encompass rationales, ideas, and feelings about what ethically should be done on what bases, what Sung-Jun Park and colleagues call the oughtness of care. These feel natural and existentially essential in their context of emergence. And it's their tendency to be articulated as self-affirming truth that makes attending to moral logics within humanitarian healthcare particularly important. If the moral logics of those responsible for enacting humanitarian healthcare policies are not taken into account when developing or revising those policies, they won't be realistically applicable, is what Sung-Jun Park and his colleagues are saying. They can be ignored, rejected, or adopted, but lived as ethically wrong. So strong feelings about what should or must happen ethically in humanitarian healthcare may resonate with some, but not with others, is another aspect of this anthropological perspective. So clarifying the experiences, practical considerations, understandings of care and responsibility, and potentially culturally specific norms and value underlying these feelings is the work of moral anthropology. And the idea is that if we can at least see them and acknowledge them and unpack them, then we're rendering them at least available for reflection, discussion, and debate, whereas otherwise they can be taken for granted. So our methods for this study across the 3 Ebola-affected countries were semi-structured interviews. They were conducted with local trainees, as well as by myself and John Pringle, a professor at McGill. And we talked to these different categories of participants. As you can see, the vast majority are participants in research, but also researchers, the majority of them being West African researchers, but some international researchers as well. Leaders, so those are leaders in the government that are involved in kind of overseeing or granting decisions on approvals for research projects in country, but also community leaders, so survivor organization leaders, and ethics board reviewers. And as you can see, we have we were very intentional because of the gap in the literature in terms of West African perspectives to really focus on our interviews on West Africans with direct experience. We were opportunistic, but also trying to find a mix of experiences of research on the ground. So here you have the setup of the types of studies that people talked about. It did happen that people had participated in or been a researcher in one, or they were able to speak to more than one study. So we have vaccine trials, convalescent blood plasma trials, drug trials, survivor studies, which started during the epidemic, but also continued, usually for 2 years afterwards, doing the follow-up to figure out the sequela and provide support to survivors. So the general category are people who spoke more like a bird's eye view on research. So we had different interview guides for our different participants categories, like REB member versus limited literacy adult. Slightly, they were different as well, lived experience of being a participant versus lived experience of being on an REB or a researcher. But all three interview guides had these key questions. What motivated you to support, participate in, or decline participation in this research? Did anything make you feel uncomfortable or leave you feeling troubled? And what was done well? And pulsing through all of these are all sorts of intricacies of consent. First amongst these was the fact that a lot of people, researchers, REB members, talked about their concerns about the stress and confusion with which people were presenting at ETCs. The possibility of voluntariness was definitely questioned across the board by our participants, and really troubling to researchers and REB members who were going forward and very aware of those research ethics principles. They were more embedded in the narratives of the participants as a reality, not something they were ethically worried about. But the fact is that many of them had lost family members. They were terrified when some had to be brought by force to the ETCs, the Ebola treatment centers, because they were sure that that's where you go to die. So absolutely terrified. So what are the possibilities of listening in a situation where you basically, when you enter an Ebola treatment center, before we even talk to you about research, you're thinking, I'm gonna die. And maybe you care and maybe you don't care, because some people also spoke about how at that point, some were like, leave it up to God, but others were like, I don't care. They've lost so much already. So it's not a frame of mind to make a big decision. I'm actually going to go to the next one. So in this particular quote, says it very well. Doctor, do whatever you want to do as long as I get better. This is a medical professional telling us what they were hearing again and again. They're trying to go through the consent process with people in Ebola treatment centers. People are saying, do what you think is best. So what choice when they're telling you this? And in fact, many people who participated in plasma or drug treatment trials, when those participants described joining the trial, they said that it was an easy decision for them because they wanted to live. So they're really a very strong conception that this was the only possibility, and no doubt in their eyes, a better possibility than what they had heard was a 50, but often 90% mortality rate at the beginning of the epidemic. People were aware of seeing the bodies leave Ebola treatment centers of the cemeteries, so really desperate. We see that this also kind of complicates the consent process and experience for the researchers. Since they're the ones with the responsibility to kind of determine in this kind of situation, do what you think I need to do to get better, places the responsibility, of course, on the people who are obtaining the consent. And we did find that there really did seem to be a lack of equipoise. There did seem to be a strong sense of therapeutic optimism amongst a lot of the people running the trials, in the sense that they had very little hope in the standard of care, which was not, at its very best, was kind of saving 45% of people. And so they were hopeful that these experimental treatments might do better, might fare better. And there's the pressure of time. So this quote, those taking consent should exercise more time, but unfortunately this was not the case in the Ebola business. And it depends on the condition, they say. If it's malaria, you can take a lot of time. But in a situation like Ebola, which is such a rapidly evolving disease, you want to talk less and start the treatment. So that pressure of time is really enormous as well on people. And again, we kind of see implicit, as people are talking about the consent process as educated researchers, that they felt a moral responsibility to convince people to enter the trial, because they had seen observationally, and of course that's not a clinical trial result yet, but in their experience, they had seen that people who were enrolling in the trial were faring better. So we heard somebody saying, you know, you need to cajole them. You need to convince them, in other words. So is that an ethical, how does that, where that's a consideration that's very particular to Ebola, where there is no known treatment, and you're going against a very, very high mortality rate. And that idea that the therapeutic misconception, this idea that you can, if you do enroll in a trial, then you will be cured, which sometimes you have survivors who are still in the Ebola treatment center who are helping, who are saying, hey, I survived, I was in the trial. So that helps as well. They're visibly there as a witness to the success of this intervention. But people were hearing that, for example, with the vaccine, this would shelter them from the disease. So we heard quite a few people, healthcare professionals, as well as limited literacy adults, so different levels of literacy, different levels of understanding of what a trial is. But this quote says it all. They told us that if we got vaccinated, even if Ebola is in the area, we will be sheltered, that we will never again be able to get Ebola. So there's quite a strong sense that this is not only your best chance, but actually some kind of guarantee. Okay. So the context of certainly a lack of available healthcare services further complicates consent. We did hear a context of need when we talk about need or economic vulnerability in global health research ethics. We are talking usually about context of poverty, and there's a lot of discussion around compensation and the ethics of maybe incentivize, what are the politics, what are the ethics of incentivizing participants to research when they, on a day-to-day basis, might not earn any cash because they're working in some kind of subsistence living, like their gardens or providing food or childcare. So is there a compensation that should be provided? Would that be undue inducement? What is fair? What is respectful? We heard those debates. We heard concerns from researchers that some people were like looking for trials, and there is a development of an Ebola business, as it's called in Guinea, where people were actively kind of seeking opportunities to participate in research because they had understood that this is a source of income. But really, the main kind of concern that came out of our interviews amongst participants, who are this bulk of those we were talking about, was that it wasn't about the money, but there were quite a few people who did appreciate being able to get diagnoses, being able to get access to free tests, even HIV tests, as a result of participating in research, able to get follow-up, eye care, which is a major eyesight problems or big sequela of Ebola. So the survivor studies in particular offered good comprehensive health care, psychological care as well, to individuals that was simply not available anywhere else. And in the case of survivor studies, this was also being provided in a way that destigmatized people. So in a context where Ebola was highly feared, people couldn't talk about it, they could be shunned by their community, already a huge pressure on top of the physical distress of the sequela. When they came to survivor centers studies, these were places that were very supportive, and you're meeting other Ebola survivors. So there was a lot of appeal in that sense. But nevertheless, I mean, it does kind of raise this flag, a red flag potentially, of what Patricia Kingori talked about as the empty choice in an article a few years back, where if you're doing research, health research in contexts where the only access to healthcare that is affordable or available is through research, then that's not choice. So, you know, it's the only option, and people want to take care of their care. So we can't talk about voluntariness in that context, is what she's talking about. And what's interesting is that there seemed to be a similar empty choice for clinicians invited to collaborate on or supervise research in Ebola treatment centers in particular. So we asked researchers like participants what felt right, what made them feel uncomfortable, and a recurring lump that was described of discomfort centered on this experience of having no choice, and indeed feeling enormous pressure in the face of invitations to participate in research to say yes. So this is a quote from one clinician researcher setting the scene for me. So during the outbreak, a lot of people came to help. It's like somebody drowning, and you're given a knife to hold. And he looked at me. What do? You just have to hold a knife. He questioned, he wondered about the validity of the particular trial that was being proposed to his Ebola treatment center. He wondered about whether it really had scientific merit. But what choice did he have, given that the country's falling apart, given that it's an epidemic, given the fact that it's the only way that he's going to get better diagnostics, more staff, more resources, even protective gear into the Ebola treatment center. So that idea of having an empty choice as a researcher in an emergency is also another layer to the consent complexities. We always think of consent as something that participants are consenting to, but there's other layers, right? There's the REBs under pressure. There are the researchers under pressure. There's the transnational REBs under pressure. The last kind of complexity I'll talk about here before moving into part two kind of emerges through some of the expressed frustration, maybe even hurt that we heard from both researchers, West African researchers and study participants about limited communications between themselves and those with whom they thought they were collaborating on research. So trials started, when you're co-PI, they're starting without the ethics approval. That doesn't feel quite right. Then people are not sure where the trials are happening, which is feeding into the rumors and creating a lot of lack of clarity, and yet those same organizations that are supposed to be providing, identifying people, potential participants, are also dealing with all these rumors of people saying, hey, we heard this trial started, and they don't have information or a direct line to figure out what's going on in the country, and yet they're supposed to represent survivors. Survivors who are organized in civil society organizations wanted to be, at least in 2016, as they were well established by then, consulted before studies approved, and they were not. As well as the expectation that after a study ended, you would get some kind of follow-up. You would find out what the results are. You would find out what worked, what didn't work, and what's next. And the lack of post-trial communications left people feeling used. So, I mean, I think that this does, we talk a lot about, therapeutic misconception. So the misconception that treatment, experimental treatment, has healing properties. But what we're hearing, what we heard as well in this study, is that there's a different route to the disappointment and loss of trust that can happen in research. When communication ends, when people feel abandoned, and they're reduced to feeling like guinea pigs, That seems to suggest as well that maybe we do need another kind of term for the harm and risk that happens in misconceptions, maybe a consent or collaboration misconception that could kind of capture a serious ethical risk in the process of engaging people in research. So you are getting the idea that there really is a lot of, there really are a lot of complexities to, when you dip into this data, you could say that all the moral complexities of research in this particular emergency, and maybe all emergencies, have this element of consent complexities. And some are inherent limitations to consent in public health emergencies, perhaps the pressure of time, the fact that you will be having to bridge and communicate, which is challenging always, different worldviews, different explanatory models of illness, different literacy levels. It's hard to be skilled in translation of multiple languages. But there seem to be also some consent complexities that are not so inherent and inevitable limitations to consent in public health emergencies. Limitations that have more to do with research participants, researchers, and those officially responsible for defining and enacting the ethical in emergencies. That mismatch. There are many ways that you could tug at consent, but I want to focus on West African participants' description and sometimes insistence on social relations and their importance in decisions being voluntary to participate in research. So part 2. So when I'm talking about social connection rationales, social rationales, this is more than social norms. It's interrogating what counts as problematic versus ethical participant recruitment processes and decision making. And I guess that what really made me want to bring this into this presentation is that I kept thinking back to one of the first people I spoke to, a study participant, who when I asked, we had it in our question guide, did some kind of monetary compensation for traveling into a study incentivize you? Was that a factor in your decision making? And it was absolutely not. And I felt like I had been, I feel like I'm trained to be suspicious of that kind of response. It's like you're completely impoverished, there's a little bit of money to travel, really, like it doesn't mean anything at all. But she insisted, and I feel like I have to come back to that. Because there were a number of other participants that insisted that their participation in research had nothing to do with either the assessment of information provided, first of all. It had nothing to do with faith in God. It had nothing to do with incentives or even need for healthcare sometimes. It had nothing to do with faith in Western medicine, which is something that many of us would expect. All these things, minus the last one actually, were cited by several of those with whom we spoke as factors playing a role in their decision-making to enroll in trials. But alongside these factors, and actually always in those cases superseding such explanations about joining studies, there emerged a consistent recurring emphasis on the centrality of social relations to their decisions to enroll in Ebola research. So I'm going to give you a couple of quotes that kind of bring you more concretely into this idea. So Emmanuel, not his real name, is a taxi driver who arrives at an Ebola treatment center at the peak of the epidemic. A nurse in the ETU recognizes the family name, calls him out by name. Her family is from the same village. She urges him to take the experimental drug treatment. She says, on the outside, I know you people have heard a lot of rumors that the drugs that they offer you are going to kill you, you're going to die. So I beg you, this is the drug that we give. It's an experimental drug that we're giving, but we know it's saving people. It's helping people to regain their strength, to regain their life. So take it in. I'm not here to harm you. I'm not here to kill you. I'm your relative. I'm your sister. So take it in. So Emmanuel is telling the story. I said, okay, and I took it in. So what's going on here? There's comfort and trust in someone from home. This is someone Emmanuel has never met, but they are far from anonymous. The nurse and Emmanuel are deeply connected through shared familial, historic ties and place. They have a robust social connection. And the story highlights the influencing power of being able to situate one's decision within a much broader system of social relations. It's actually on that basis, it seems, rather than on the basis of the nurse being a healthcare provider or someone with experience in Ebola treatment center, that Emmanuel is agreeing to take the experimental drug. At least in his telling, that's how it's coming across. Now, we could hear this story and take it as a red flag. We might wonder and worry that the nurse's cajoling of the patient constrains his ability to choose freely. The nurse seems overly confident in the therapeutic potential of an experimental trial that has no clear results yet. But those things do seem quite secondary in Emmanuel's decision-making. He accepts to participate as an affirmation of his connection to the nurse and to that community. This decision is not based on scientific information, and therefore whether that information is skewed or not kind of misses the point. This is a rational decision within a social context where day-to-day life is precarious, and that which offers the most stability, and there's a lot of Africanist scholars who talk about this, that which offers the most stability and certainty and security is very likely one's place in a web of informal but very robust social supports and relations. So let's take another quote. Since I am an Ebola survivor, I know what is going on in the ETC. I could not just stay there like that, standing idly by with my arms crossed, refusing to give life to other people who were still suffering. There were a lot of quotes along this line for plasma and blood donations that were being used for experimental treatment trials. And there's a connection, a social connection here being affirmed at a different level, feeling for fellow countrymen and global citizens, potentially, that are completely anonymous, but a sense of ethical responsibility to help so long as they are in a position to do so. Another, I had to contribute in my way to researching the disease. I knew that if the treatment worked, the quote continues, everyone would eventually benefit. People said that the virus stayed in the body for 3 months, then they said 6 months, then they said 1 year, so I knew I had to help do the research. So Emmanuel and these would be coded as altruistic participation narratives, and that's how they were coded initially, exhibit commonality in their distinct yet resonant affirmation of a normative and dependable sense and practice of co-responsibility towards one's fellow human beings. Why is this interesting? Well, it's interesting because these social entanglements and moral rationales playing a role in consent processes are really not visible in representations of research ethics and decision-making during Ebola, I would argue. So we have many people in the media, in the scholarship, in the debates about the ethics of research of Ebola, are cast as heroes for their contribution to a collective good. You've seen the articles. Take this Guardian article. I'll read you a quote that you can't read. To their eternal credit, a global partnership of researchers, governments, NGOs, companies, and funders managed to accomplish something that too many have for too long filed in the drawer marked too difficult, conducting a trial in the midst of an epidemic. There are a lot of articles came out like this, really naming specifically, including researchers, including people in labs as well, but never the research participants. It's the researchers working to find effective treatments and vaccines that are doing good. Sometimes the volunteers to Ebola research in the West are also cited as doing good. So this is an article from a vaccine trial that was run first in Halifax, Nova Scotia. The researcher is absolutely floored and touched at the desire of so many students in Nova Scotia to participate in the research. It's got to be altruism, he tells the Globe and Mail. So he's touched by this kind of entreaty, but again, it kind of drives home. We don't hear it's got to be altruism for why West African research participants are signing up for the trials. And then, of course, there's also critiques of the lack of altruism globally from the West or the North, the lack of solidarity that has come across and been, this is one of my favorite articles and critiques of, there's been a moral failure in terms of responding to need, responding to an emergency fast enough. But again, who's being positioned as a moral actor? Who's being positioned as those who are in charge of making a decision and determining what is good, what is not good? Especially so consistent is that, it's so consistent to have this absence of those on the ground who are actually leading in this sense of solidarity being affirmed and important. Okay, so part 3. 5 minutes, perfect. So what are we doing talking about ethics of research and public health emergencies? We know that we're talking about this because there's risk of harm. We know that there's better and less great ways to do research in public health emergencies. In other words, we don't assume fairness and justice will just happen and drive research in transnational partnerships and emergencies. In other words, we care. We care about justice, we care about fairness, if we do care about that, what is produced or reproduced in the act of not hearing local research participants' rationales for participation becomes really important. So I came to organize my thoughts for this presentation around the word recognition, which I take from Nancy Fraser. For Nancy Fraser, recognition, the possibility of equity, justice, social justice, hinges on undoing deeply institutionalized norms of misrecognition. So any redistribution of resources, whether that's authority, political decision-making, legitimacy, economic, institutional resources, any redistribution to marginalized groups will not feel practically or ethically important so long as individuals who are marginalized are positioned in discourses as others, as the recipients, as not our peers. So she speaks about social arrangements that institutionalize deprivation and gross disparities, denying people the opportunity to interact with each other as peers. Often when we talk about recognition, we might think about rights. That's probably the most common way that we use this term, at least in humanitarian healthcare practice. Right to dignity, rights to information, for decision-making, for research. For me, Fraser's writing is really useful in foregrounding that this is about transformational politics, that policies will only make a difference. They'll only go so far if these fail to open up a space for conceptualizing the groups who have for so long not had their rights, expertise, and general importance recognized as equals and peers. It makes me think that the conditions needed for research to be more fair across class and resource divides requires a massive kind of shift in thinking about how we listen to stories gathered in this research. We certainly have had a massive shift in terms of paying attention to community engagement. It's a fundamental goal and good now when we talk about research and public health emergencies. Nothing else can be considered ethical. But if there remains a habit of viewing those who through policies are being insured more or through policies are being actually given more resources, if there remains a failure to see those people as peers, those efforts can only go so far in transforming the inequalities. This is where it gets a little fragmentary, but I'm almost done. So Nunez starts a 2016 article with a reflection on the very name of Ebola as a disease. He reminds us that it is colonialists who gave this now infamous waterway its name, rejecting the indigenous name, Legbala River. What's in an erased name? Asked Nunez. This erasure is not, this is the wrong quote. This erasure is not insignificant. It can be seen as a metaphor for the ways in which the realities of the Global South have been interpreted and addressed, says Nunez, violently suppressed during the colonial era and still misrecognized. Systematic misrecognition has led to forgetting or to the imposition of narratives that do not correspond to actual lived experiences. This, in turn, has had an impact upon how injustices and suffering are dealt with. And we could add, this has had an impact on how injustices and harm will be reproduced if we're not careful. If we go back to the definition of recognition from the internet, Under the first one, identification of someone or something, a person from previous encounters or knowledge, recognition. The example is striking. He stared at her, but there was no sign of recognition on his face. I kept rereading this. I wasn't really sure why. But I'm thinking that the her here could be the historically feminized and silenced poor African individuals, marginalized individuals engaged in research. The he is expertise authority. Maybe all of us here with privilege of having degrees, positions, connections, and therefore some power at least to weigh in publicly on what counts as good and bad research. If we take the time to ask participants to research in public health emergencies why they're participating in research, it seems it would also make sense to take the time to let what we hear change the conversation. Change the conversation about how consent can and cannot be meaningful in public health emergencies. We all have the power as members of the research community to gather stories, listen, but do they register? Do we recognize research participants who share their stories with us? Or do they remain faceless? Additional examples for our pre-existing understandings of inherent limitations to consent in research and in the shadow of death. We are really good in ethics literature these days at acknowledging the limits of informed and voluntary consent in emergencies. And our findings from this study align and support all of those critiques. But if we only see those limitations, we also risk dismissing what at least some research participants are telling us their decision was about, what it represented for them. Decisions that felt voluntary, or that for at least some had nothing to do with financial compensation, with health-seeking needs, with personal need in any sense, except maybe their existential need to affirm their ethical commitment and connection to humanity. If we dismiss this, we are dismissing important understandings of consent as processes that can, and for some do, performatively affirm the value of codependency, co-accountability, co-responsibility. And I do suspect that everywhere where research is conducted, whether it is in Nova Scotia, Ohio, Guinea, Sierra Leone, Kenya, some individuals will view invitations to research through lenses and worlds that have more to do with their sense of connection and reliance on dependable human relations than on other factors. To fail to take as honest and to remain purely suspicious rather than curious about these statements by impoverished, marginalized research participants that they wish to collaborate in research to help reduce potential future suffering, and maybe as a habit of living co-accountability, strikes me as a serious blocking point to research in public health emergencies, walking its talk of commitment to justice and fairness. There is no justice and fairness in conceptualizations of research landscapes as only about differences and inequality. I'm not suggesting that we might be able to, it would be okay to fetishize motives to participate in research based in senses of solidarity and co-responsibility. We do need to keep our gaze well-trained on structures of geopolitical inequality and all too real impacts on lives. But we also do need to not misrecognize significant other considerations underlying consent to research in particular contexts. If we are failing to recognize those rationales, then we're failing to recognize research participants as complex moral actors, or maybe we can simply say as humans. So I'll leave it there. Oh, thank you.
Thank you, Elise, for this impressive and sometimes emotion-evoking presentation. I think there are a lot of questions, but we have only time for 3 questions.
Hi, I'm Sophie from the University of Manchester. Thank you so much for your talk. That was very interesting. I was wondering about part 3, recognition. So there's a lot of theory that's happening within, on recognition within fields that are looking at testimonies,
Yes.
and witnessing. And what usually happens in that conceptualization is that they try to turn it around, right? They don't try to look at getting recognized by somebody else, because then you again put the power with the power holder instead of with the person who wants to be recognized. Instead, they're talking about things like addressability, recognizability, responsibility. So they put it much more towards the people who are the ones who want to express themselves or who want to actively consent and things like that. So I was wondering, to what extent will you be able to kind of like turn that recognition around and make it a more actor agency oriented exercise instead of an exercise in which we as researchers, you know, have to determine who is recognized and who isn't, or that we are kind of the agents in that interaction? Thank you.
Thank you. That's a great question, and I think that there's a couple of things, and one is that it still remains important to kind of flag that there is this power inequality, and so certain people do have the power to recognize and to do the work of recognition, and in order to shift or kind of undo this boundary, this gulf of difference between who's doing the recognizing, who's being recognized, which already is about difference. I do think that, yeah, the recognition that happens is also, it's about being marked and seeing somebody who would be otherwise faceless as having a face. So I do think, while I'm aware of like the work of Judith Butler, and I actually work a lot in testimony, and actually this comes out of another project that's about testimonies of poverty. I think that recognition is still a really powerful word for talking about something that is an interaction. And you know, it even harks back to like Frantz Fanon, you know, where there's the face of the black person that becomes a site for the colonialist disgust and rejection and affirmation of difference. So there's something about recognition, because it's about the face, because it's about the site of personhood, that I find really powerful as a word, but it's not yet figured out. But thank you very much. Yeah, I will think about how to avoid it reiterating the passive active. Thank you.
Thank you. There's a question there.
I felt that your standards for when consent can be valid enough for us to go ahead with testing vaccine candidates and therapy candidates that underwent already safety testing and were indeed, in many cases, observed correctly as people's best hope, were a little too demanding. So I'll give you a caricature of yourself.
Okay.
Suppose there is now actually a vaccine that has more or less been proven safe and efficacious, or maybe in the future we'll have a treatment for Ebola, and in some future outbreak we want to roll out this thing and give it to the people. And then the medical anthropologist comes along and says, no, wait, they said yes. So we think it's helpful, we suspect very strongly that it's helpful medically, and they said yes. But the medical anthropologist says, you're not allowed to do that. There isn't valid enough consent. Why not? Well, they're distraught. You know, they lost dear ones. Surely that's not, you know, it's, people are distraught. You know, a terminal cancer patient who is reaching out for the last hope thing is distraught, and their family is distraught. But that shouldn't count against helping that person if they say yes. They're objectively, you know, it is a kind of, they have no alternative. They're drowning, and it's merely a knife. It's not ideal, you know, there are some side effects. Yes, but precisely because objectively it's good for them, we shouldn't make it impossible for them. We shouldn't let that, I mean, it's philosophically actually a complex point. Why? Because maybe that does undermine somewhat the voluntariness. But still, I think it would be an error to deny that dying cancer patient, or in the future, the person who needs the drug, get that. And I feel that these are elements that were here. Similar arguments in the context of the experimental interventions.
Okay. It is a misunderstanding of my position.
Okay, so tell me in a minute how it is.
Okay.
You might say, you haven't written an anthropology book about the real motivations behind. It's actually a mix of they want to get better, but they also want to be part of a larger network. And I don't want to, I'm not here to write an anthropology book. I'm trying to help them, and they said yes. So why, if in this future circumstances, the anthropologist would be wrong, why, projecting kind of to this context, why in this context weren't the standards that were surely wrong in that future context not too high in your case?
Okay.
Now,
So
let me just add one thing that was clearly a violation of consent standards that you pointed out was when people said incorrect things about the vaccine having been proven or the treatment as the nurse,
Yeah.
when she lied or he lied to the patients.
No, it's not a
that's
lie,
actually,
yeah.
you didn't condemn it, but in fact it is a violation of clear consent standards.
Okay. So first of all, yeah, the first part, I mean, there's the surface findings that of the complexities of consent that align with all these critiques that are there and have been for 30 years in the literature on consent of, you know, the debates about therapeutic optimism. Does that make it unethical, a cancer trial? No. You know, what are we going to, but they're there. They're things that are hard to resolve and that do fly in the face of, we've been troubling in ethics, the concept of voluntariness for a very, very long time, and there's no resolution. So I'm not saying that, you know, you cut the line there. It's more pulling out that, again, these realities were there. What makes something, my main concern actually as an anthropologist is to demonstrate, first of all, that some things are inherent in emergencies, like the pressure of time, for example, the fact that people are going to be desperate. I'm not saying stop trials because they're desperate. I mean, you do the best you can in terms of a consent process. And what I really wanted to draw attention to, though, is that we focus a lot on that little micro interaction between what was said. Did you get a consent form? Did you understand the consent form? Did you understand the information about the trial? And actually, people's decision-making is often not about that at all. And we should take seriously decision-making that does rely on, you know, trusting social networks. I mean, that's something that is more important to people. So to kind of dismiss that as the nurse is lying, well, that, I mean, it's like saying, you know, that in a country where nothing works unless you hire your brother to do the job, that's corruption. I mean, that's too simplistic. I think that that's what I want to interrupt, this kind of assumption that the only thing we can try to improve in the consent process are those little macro things that we've already shown are pretty messy and they're never going to be perfect, like, you know, making sure someone fully understands and is fully in their right state of mind when they're sick to consent to research. We're not going to figure that out. But what we can do at least is listen to their reasons for consenting and let that feed back to what we think consent can be and who is making a complex moral decision. These people are not just passive victims of their illness or of transnational drug companies. These people are actively affirming themselves as, you know, wanting to participate in research, just like the students in Halifax, for reasons of solidarity and connection. And that's not been recognized. And that's what troubles me. I'm on the margins of the policy.
I think we have to stop for the next agenda point. I think there's opportunities enough to discuss personal level. Thank you.
For later on, yeah. So, yeah. I don't know.
There it is. The screen's technically over here. So,
Yeah, we just need to get loaded up.
yeah.
Which PowerPoint? PowerPoint? Kreutzer is the first one. This one. Right here.
Oh, okay, okay.
Okay.
Yes. Got a second. Good morning, everybody. Shall we start? I am Navaras. Yesterday, you heard me, and I was presenting for HealthNet TPO. Now, today, I also want to share my second hat that I am a PhD student at Utrecht University, Netherlands. And this morning, I will be facilitating this session, and we have three very nice presentations. Let me start inviting the first presenter, Tino Kreutzer from York University, Canada. Tino, please. Tino is an expert in the field of humanitarian response and information management. Currently, he serves as a crisis informatics coordinator at NetHope, and he's also a senior advisor to Harvard Humanitarian Initiative. Tino, please.
Don't stop now. Okay. If anyone wants to get more coffee, I really don't mind people walking around. Everyone's already sitting a long time. Can you hear me okay? Yes? So yesterday when Matt was warning you about people engaging in neophilia and innovating and experimenting in humanitarian emergencies and very, vulnerable circumstances and the types of consequences this may have. He was warning you about people like me. And so I'm here to tell you today a little bit about how someone who's coming from the field and has been deploying and developing technology to help humanitarian response has found himself at an ethics conference. Okay? And so in my presentation, I'm going to talk a little bit about the techniques and technologies that we are currently using for understanding people affected by humanitarian emergencies. I'm going to talk a little bit about our ongoing work to demonstrate the feasibility of deploying natural language processing in order to scale up the use of qualitative data collection. And finally, I'm going to go into the ethical implications of our work and what we're doing to guide our project and other projects like ourselves that are hoping to use artificial intelligence in humanitarian response. Well, why am I interested in this? And particularly, why am I, again, at this ethics conference, as I've been asked several times yesterday? For the last 10 years, as was mentioned, I helped UN organizations and NGOs go from paper-based data collection to mobile electronic data collection. I worked in CER, DR Congo, West Africa throughout during Ebola, and also in Nepal after the earthquake. Over the years, I've also led large population-based surveys with more than 40,000 respondents, so I'm no stranger to the ethics of field data collection and research. Since 2013, I've been managing the creation of a tool called Kobo Toolbox, which is a free and open source data collection technology that's now used very widely in humanitarian emergencies and also for research throughout the world. In my research now at York, I'm addressing some of the many limitations that I've noticed over the years, both human and technological. And those are, there's a long list of limitations that actually prevent us from better understanding the people that we're trying to help in humanitarian emergencies. Usually an effective response to international humanitarian emergencies requires us to understand the preferences and needs of the affected population.
And we do this most of the time through quantitative surveys. That means interviewing a sample of the people affected, usually in face-to-face interviews. Increasingly, we're also doing this through remotely conducted phone surveys, but to a much smaller extent. Now, quantitative surveys, as we use usually for rapid needs assessments, require our survey staff to translate complex responses, such as this long-winded response to a relatively simple question, into categorical or numeric data. They check the box on the questionnaire, whether it's paper or electronic, and they move on. Now, time pressure to conduct and analyze interviews as quickly as possible usually means that our assessments for humanitarian response include very few, if any, qualitative or open-ended questions. And that means that while people might give our enumerators or interviewers a lot of valuable information for a particular question, we just don't have space and time for it in our questionnaires. So a long response ends up just resulting in one little variable in our data set. Everything else is lost. And so for more profound insights, we continue to require the use of qualitative methods. But qualitative methods require a lot of time and resources before we actually have analysis at our hands to plan based on the data. And so these types of methods, focus group discussions, qualitative interviews, or even more recent innovations like using feedback hotlines, are not used all that widely because of these enormous costs and delays in actually operationalizing them. For example, if you conduct 10 unstructured interviews of 30 minutes each, that may take 40 hours to transcribe. And manual coding, even if you use software like NVivo, as we heard a few times yesterday, may still require another 20 hours to go through these interviews. That is a huge amount of time and expense. And so as a result, while we can all agree that qualitative methods are extremely important to understand affected populations, they are usually considered a luxury, especially during the initial response phase. And so, as a result, we just don't do them very much. We either don't do them at all, especially at the very beginning, or we do them to a small extent. Now, natural language processing, or NLP. NLP provides some radical new opportunities, and which is why we're looking at this technology, to help us bridge this divide between qualitative and quantitative data collection in humanitarian response and in research in general. NLP refers to a group of artificial intelligence tasks for processing and analyzing spoken or written language. Such capabilities are advancing through a lot of commercial applications. Does anyone have a smartphone in this room? Close to 100%, I think. You have an AI machine in your pocket right now. You can talk to it, you can ask it questions. When you type in things to translate or search on Google, all of these things use NLP to understand what you are trying to tell the machine, and for the machine to translate back what it thinks you're trying to find, whether that's through voice processing or text processing. Now, a lot of these are actually available also to business and to individuals, because these companies make the same technologies available for all of us to use. And there are also a lot of open source options that are not proprietary. For example, the technology to transcribe human speech into English text and other languages is already extremely advanced. Google now offers this service for 64 languages and another 56 variants of those languages, such as Brazilian or Portuguese. Now, a lot of this sounds great until you realize that the world has thousands of languages, and a lot of the languages that we are focusing on are not necessarily in this list of 56. But before I get there, I'll quickly describe how we're planning to use NLP for the use of qualitative response analysis. So Our goal is to systematically transcribe, translate, and categorize interview responses to improve the efficiency and effectiveness of humanitarian response. We're currently planning a pilot in Yemen, which requires actually creating an entirely new transcription model for Yemeni Arabic, since Yemeni Arabic is not part of any commercial tool. And it also requires identifying the best NLP methods to analyze different kinds of responses. Humanitarian organizations we're working with have already shown great interest in our approach and the idea, and in fact, a lot of the ideas came from them. The greatest benefit, if we're talking about beneficence, is that we can better understand the people affected, and then we can integrate more qualitative questions in our many existing types of assessments to gain more profound insights. It also means that humanitarian organizations can become more accountable to the people they're trying to serve, as feedback and complaints are able to be collected and processed at a much larger scale. For example, the question that I showed you earlier in the long response can be processed through existing NLP methods to contain various bits of information. And what we pull out of the text of what people give us really depends on our own research questions. What is it we're looking for? And then NLP can help us derive the data from a normal human response, whether that's a short 20-second response or a 5-minute response. As I mentioned, a lot of the languages spoken by people affected in humanitarian emergencies have very few commercial incentives. So Google, Amazon, IBM, Microsoft don't offer Somali or Kanuri or Rohingya or, for that matter, Yemeni Arabic. They do offer Arabic, but standard Arabic, which is a form not spoken by by most people, in fact, in everyday language. And what's even worse is that the vast majority of these languages don't even have large-scale electronic, audio, or text databases that we could use to start training these speech-to-text or transcription models through existing technologies. Now, it's always worth mentioning that the languages we're talking about are not necessarily small. For example, Yemeni Arabic is spoken by 28 million people. Kanuri in northern Nigeria and neighboring countries is spoken by 6 million people. By comparison, Danish, which is very well advanced in natural language processing, only has 5 million speakers. But I'm also here to talk to you today about the risks of this new technology, not just what we're working on, but artificial intelligence and natural language processing in general. Here's a quote from the Montreal Declaration. Intelligent machines can restrict the choices of individuals and groups, lower living standards, disrupt the organization of labor in the job market, influence politics, clash with fundamental rights, exacerbate social and economic inequalities, and affect ecosystems, the climate, and environment. This statement was co-written by AI engineers. So people are aware of the consequences. Sometimes, some would say the engineers are more aware of the potential downsides of what they're working on or what future generations are working on than the wider public, actually. So what could go wrong? Now, one of the biggest challenges with developing AI is to minimize biases. A system that has biases can have grave long-term consequences. Those biases may stem from engineers' own internal prejudices, but most of the time it is the training data used to create the AI systems that is responsible for biases in these automated systems. It's very hard to measure and control bias. The mitigation, once it's there, is also extremely difficult, which is why it's most important to try to prevent bias at the very beginning of creating a new system. Now, we've already seen in some examples the consequences of having biased systems deployed in real life. For example, biased algorithms were found to exacerbate racial inequalities when deployed in the justice sector in the United States. And facial recognition which is now used widely by security services, commercial companies, airports, now is actually extremely good, extremely precise if you happen to be a white man. If you're a woman, the quality drops significantly. If you happen to be a dark-skinned woman, the quality goes down very, very much. For example, in this graph, we see the facial recognition for images of women with darker skin was only 65% accurate in determining gender, whereas for white male, it reached 100%. And that's because of the training data being extremely biased that went into this. Now, such concerns for the ethical implications of AI tools have only recently been recognized as new research priorities. However, in a humanitarian response, we already have a lot of guiding principles on ethics, on our behavior of what is right and good, and what kinds of rights the people that we're trying to help have, and what our obligations are as humanitarian responders. So we rely on this tapestry of ethical codes and principles, which are always reanalyzed and expanded whenever new challenges arrive. So, you know, we base ourselves on international humanitarian law, human rights law, and then the code of conduct and the humanitarian principles that guide basically every humanitarian organization these days. But up until 1998, none of these principles in any way mentioned the risks of information or data going into the wrong hands. With the SPHERE guidelines and the humanitarian charter and the protection principles that were first created in 98, 99, that was the first time that the risks from recording and sharing information were mentioned. In 2014, the Core Humanitarian Standards, or CHS, went into more details and then expressed this as a right, and it makes organizations responsible for safeguarding personal information. The last line should read 2018 SPHERE standards actually now have a even more specific requirement. They say organizations should have clear and comprehensive policies on data protection, which should be aligned with international standards and local data protection laws. Now that begs the question, which humanitarian emergency has data protection laws, and what international standards are we talking about here? And that is precisely the problem. They do not exist most of the time. So we're still reeling to find exactly what are those good standards that we should adhere to. One of the best examples that I would recommend to anyone who is concerned, I think that's come up a number of times yesterday about data protection, data privacy, and data security, is to look at the ICRC professional standards in protection work, which in its 180 pages, actually 1/3 of it is dedicated to those issues alone. Now, some would argue that is for protection, that's not for humanitarian assistance, that's not even for research. But in fact, I would argue that those very stringent standards are applicable to everyone. Now, over the years, the many gaps that people have realized that exist in terms of how do we keep our data safe, what do we share, what do we say, and our researcher trying to find exactly which guideline or standards should I adhere to, it can be quite challenging. So my recommendation from a practical point of view to you today, if you're new to this, would be start with the professional standards and protection work, and then go into the handbook on data protection, humanitarian action. Both of them published by ICRC, both of them very recent. And they're extremely detailed, and they give concrete advice on exactly what should be done. And using the principles gives us guidance on why we should do certain things. Now, when we talk about similar principles for AI, they don't exist in the humanitarian sphere. They don't even really exist yet for the rest of the world. We're only recently starting to create them through various initiatives. For example, one of the things on this list was only published yesterday. And so as engineers and as policymakers are starting to wake up to this, we're scrambling to get good principles. There are several general principles that sort of act as a constitution, if you will, and then much more detailed guidance, not just for engineers, but also for practitioners and humanitarian organizations trying to use technology. And I would really encourage you to start engaging with this. This is not something that is for the next generation or for your students or your children. This is something that we need to face and deal with now, and which also means, yes, you know, pick up one of those documents and read them. The good news is that some of these, this is actually the document that was published just yesterday by the IEEE, which is, you know, the biggest engineering organization in the world, has a large section on ethics, not just ethics, but classical ethics. So I would say, even though this is meant for both engineers and non-engineers, this is very good literature to start with, because this is the types of things that we need to train people on. There are a lot of very specific principles also in the Montreal Declaration that I mentioned earlier, some of which I think are directly applicable to humanitarian response, and I would encourage you to look at them. So finally, we need to say that AI is different from other experimental technologies. Yes, we should be concerned about deploying drones in contexts like the Nepal earthquake, but AI is different. We need to imagine things that can go wrong, because there are many more ways that things can break and hurt people. Algorithmic decision-making should require new ethical assessment frameworks. But then also, we have enough principles. Humanitarian response is awash with principles on what to do ethically. It's time to apply them rather than starting to reinterpret and create new ones over and over. And with that, I'm done. Thank you very much.
Thank you, Tino, for this very interesting presentation, and we'll have a question later on. Now, let me invite Tom Jacobson for his presentation. Tom is a professor in Clay College of Media and Communication at the Temple University in Philadelphia. And also his colleague, Nicole Lamary, a lawyer, interest in justice and ethics. She is also currently a PhD student at Temple University. So, over to you.
Thank you.
Thank you.
Boy, our inviter yesterday sure got us doing something nice, creating new habits. Good morning, everybody. This is going to be a little change in gears. I don't work in humanitarian or relief efforts, but I am undertaking an ethics-related project, and so I will trust in the organizers to have chosen a suitable presentation for you today, and I'll just launch into it. I work with a community of researchers, including psychologists and sociologists and political scientists, who are interested in the role of communication in serving human welfare. Sometimes it's traditionally referred to as development communication. It involves democratization efforts, public information campaigns, and social mobilization efforts, and other kinds of uses of communication that are often, maybe usually, in service of other kinds of development efforts, whether it's land use management efforts, health communication efforts, improving government's service delivery, and other of the myriad kinds of practices that are undertaken in development. Historically, this work goes back to the 1950s and 60s, when development was studied under the rubric of modernization theory, and the effort then was to make all of the third world like the first world. And technology transfer was very naive, not at all like it is today, and we have heard Matthew and Tino both talk in much more sensitive ways about the complexities of technology transfer. But the field of communication has gone along with this, and in general, the trend has been away from the exclusive use of Western-style journalism and away from mass media campaigns towards efforts to support self-reliance and dialogical efforts in whatever setting we happen to be working. There is a kind of an interesting bifurcation in the field. Some of the significant number of efforts are undertaken with short-term behavior change goals, increasing visits to health clinics to improve child and maternal health. Other efforts are more oriented towards facilitating self-reliance, capacity for local decision-making, and the, as I say before, the responsiveness of democratic governments or in other kinds of governments. So the field is increasingly lately referred to as the field of social and behavior change communication. And these groups exist in a friendly tension, I guess I could put it that way, with some of these social change people thinking that the underlying issues for so much of the suffering needs to be addressed, not just the symptoms. And the people doing this short-term behavior change are thinking, yeah, well, all that's well and good, but we need to save lives now. So, but communication is used in a wide range of efforts. This is a list of a number of lead organizations who have significant communication for development or SBCC efforts in them. You'll see a number of UN agencies, UNICEF, the FAO, the World Health Organization, all have large teams that pay attention to the techniques of message design and assessing the impact of message design, facilitating social mobilization projects, and so on and so forth. There's the unilaterals, USAID and DFID, the UK's organization, some large foundations, Open Society, Omidyar Network, and Johns Hopkins Center for Communications program is very good at this kind of work, particularly in health, but also in other areas. And then there are NGOs who do it. There's a Global Forum for Media Development that helps journalists and others, often in small communities, develop the capacity for reporting. International Social Marketing Association, Civicus, a global network of civil society organizations, Breakthrough India, which I'm sure some of you will know is the large development-related organization. Soul City Institute for Social Justice in South Africa uses entertainment techniques in order to communicate pro-social messages about designed to reduce HIV/AIDS risk. So this is it's a fairly large community of organizations that use communication in service of a lot of work that, some of the work of which you do, and including disaster mitigation and humanitarian support, but definitely not limited to that. The project I'm doing is in concert with a coalition of these organizations, actually most of the ones I just listed, not all of them, called the Global Alliance for Social and Behavior Change. And the alliance is just now gearing up. It doesn't even formally exist, and I don't represent it. I'm involved in it. And the aim of the alliance is to create a community for sharing best practices and also to gather an evidence base in order to promote better understanding of the uses and efficacy of communication in development operations. One of the things that they wish to do is develop a code of ethics in order to facilitate ethical reflection and ethical practices in communication-related work. So specifically, it's to just encourage ethical practice. We're not thinking of anything like a code of conduct that will have ethical review boards and enforcement or anything like that. It's just a code and some background thinking in order to try and help or encourage organizations to be more reflective. This can be helpful in identifying what SBCC is about to various stakeholders, and then we will aim to promote ethical reflection and ethical sensitivity beyond the alliance itself. One of the things we've done at the outset is convened a group of interested individuals who work in communication-related areas around the world, interested in ethics, to identify ethical challenges. And we are polling the members of the organizations I just showed you for their senses of what are the pressing ethical challenges that we face. Some of them are common to humanitarian work. Some of them are not. One of the challenges that communication work faces is manipulation in media campaigns. There originally, significant, large, massive media campaigns to recommend behaviors or innovations that whose real possible impact or utility in the environment wasn't well understood, and naive audiences might often take it seriously. There's ethics involved with fear appeals that some of you will be aware of. Increasingly lately, there's a lot of interest in nudge theory and behavioral economics in order to encourage people to cooperate in achieving targeted program goals, but which don't necessarily involve the conscious reflection of the intended beneficiaries, and which therefore undermine, potentially, what would be called autonomy in the sense of Kantian ethics. This is a pressing set of issues facing people who do communication work. There's intercultural issues that are very common, and many of us here are aware of it. We had a discussion yesterday by Chitu, and I don't see her here, talking about, about the complexities of cultural bias in gender relations, and when you're doing communication campaigns, messaging, cultural context is often everything, and so we have to be aware of not only the complexities of semantics in communicating specific messages, but also the ethical or the moral or the cultural context in which we're working, and the fact that our ethical instincts from the West may not be suitable in every setting. And we, Alice was addressing this with moral anthropology a little while ago, and so I'm glad to see that. But so there's other issues, lack of resources and training necessary to get good data all the time. There's a whole host of issues having to do with journalistic ethics that Western reporting practices don't transfer that well to development settings a lot of times. Standard problems involving access to information and transparency. And so this is a list of them, and we're trying to catalog them now. And as you may be able to tell from my remarks, it's a wide range of kinds of behaviors and situations, and it's kind of unwieldy in terms of developing a code of ethics, but this is what we're faced with. We can draw on a lot of different codes of ethics to sort of work this problem. There's journalism codes in various codes. They overlap in substantial part, but they are different amongst themselves. Broadcasting codes, international social marketing codes. There's the International Development Evaluators Association, which has a code of ethics. So we're consulting all these in order to make sure that we don't miss anything obvious. And of course, we get help from ideas on how to develop codes and what they're for from international organizations that work broadly with NGOs. So we need to develop our own code. None of the related codes I just mentioned covers the full range of what we need in the SBCC field. Some specific issues need to be addressed. One I mentioned is manipulation. Of course, it's, you'll find common expressions of the interest to use communication and pay attention to communication issues in our code. And we need to be sensitive to culture. And it's kind of interesting looking at the codes that as I have done, I've found less attention to specific ethical principles embodied in codes that signify sensitivity to the vulnerability of populations. And there's a lot of sensitivity to it, but not built explicitly into the codes. So we want to pay attention to that. So these are the selected principles or topics that I wanted to, that I'm exploring, or that Nikki Lemire Garlick and I and a team in the Alliance are exploring. So on one hand, there's the Code of Practical Ethics or Professional Ethics, which can explicitly guide or recommend behaviors and sensitivities. There's also an issue of principles underlying those. And in this part of the development sector, there's been long-standing sensitivities to the imposition of Western-style individualistic ethics, Kantianism or utilitarianism, and efforts to get beyond those. In some instances, those work very well, and I don't think any one-size-fits-all, but in our conversations, we're looking towards other sources or additional sources. Communitarianism is one, which is more community-oriented and sensitive to local culture. Communitarian ethics are a touchstone for much of the work in media ethics in this field. Development ethics is actually, it occurs to me, a fairly new area. And let me ask a question. Who here has read any of the work by Amartya Sen? Okay. So development ethics started out as attempts to think through the problems of any moral obligations people in high-income countries might have to those in low-income countries to try and help. And it broadened out over time to include analysis of the development context as a whole, with work by people like Des Gaspard and others, David Crocker, and increasingly development ethics is paying attention to the work of Amartya Sen, whose definition of development tries to get away from Western categories. And it focuses on the importance of public dialogue in determining the choices that are made on behalf of beneficiaries or by beneficiaries on what ought to be the source of investments, be the targets for investment in development. So we are exploring that. Discourse ethics recommends itself because it eschews the idea of completely universal a priori principles and replaces it with principles that might be universalizing globally, but it's by adoption. And the idea there is that ethical principles come from people, not from God or natural law or simple-minded utilitarian calculations. I'll add two principles to go along with this, actually philosophical principles, just to make it clear that why it works for the field of SBCC, at least in some extent. These are two principles from a German philosopher who does discourse ethics. The U principle says that essentially that those ethical principles will be valid and just to, if everyone would agree to them. If everyone, it's kind of like a golden rule. Do unto others as you would have them do unto you. and this comes essentially from Immanuel Kant. The D principle says only those norms can claim to be valid that meet with approval of all affected in their capacity as participants in a practical discourse. That means that in order to act ethically, it is necessary to involve the people that are going to be affected by any decision or action. And it's not an in the head, you know, I respect them. Now, recognition ethics and dignity ethics, I think we see as an important add-on to this. But in terms of communication, there's no substitution for actually engaging people in conversation or people like those that will be affected. So this is the SBCC approach to participation, is that participation is not showing up at meetings or counting hands in consultations, but it's engaging people in conversation. And the trick there is to engage all the complexities of actual discourse, given that power differentials and everything play an important role. So that's the project. We're as I say, consulting a group of interested individuals, sharing some of our results with the members of the Alliance, and looking for resources on ways to move forward, given that I'm not an expert in practical ethics myself, which means that looking for resources is a little bit of a cry for help. Thank you.
Thank you, Tom. Now, I would like to invite Anna Simonto from University of Liverpool. She is a postdoc at the university, and she has 10 years of experience in global mental health, research ethics. Anna, please.
It is quite overwhelming having everybody stand up like that, isn't it? Okay, thanks very much. I'm very conscious that I stand between us and coffee, so I'm going to dive straight in. So I'm here to shift gears again, actually, and talk to you today a little bit about training and supervision of researchers. And this is drawn from my doctoral research, which was a qualitative study across 3 countries in South Asia, considered post-conflict settings that had also experienced other disasters such as floods, tsunamis, earthquakes, and so on. And I was particularly interested in exploring researchers' understanding and application of research ethics, both from a procedural perspective in terms of ethical approvals and informed consent processes, as well as very much that kind of fine-grained practice that we've been hearing a lot about. The types of organizations I spoke to were research NGOs and government institutions. They were all in receipt of kind of international as well as national funding, and they were conducting specifically mental health research. This included some epidemiology, but largely was focused around the development and testing of mental health interventions. It was community-based and looking at addressing common mental health problems such as depression, anxiety, as well as traumatic reactions to experiences. As you can see, I spoke to primary investigators, sort of your field coordinators, as well as the research assistants, and in particular, kind of capturing the experiences of those on the ground field data collectors was very important in this study. So what I want to kind of talk about is the approach to training research assistants. And this is kind of quite broadly, but I'm going to try and focus in on the ethical component of that training. Research assistants were often local hires on short-term project-based contracts. And the type of organization, all of the organizations prioritized recruitment of research assistants from the local sites. And this was itself conceptualized as an ethical responsibility to aid access to a community, to aid understanding of how communities viewed research, as well as to meet the responsibility of capacity building and delivering sustainable benefit to a community. It's interesting to note how senior researchers viewed the ethical training of research assistants, and often the focus was on the skills necessary for the research assistant role, very much looking at the implementation of procedures to practice. And this generally led to ethics being quite narrowly conceptualized in terms of standardized procedures such as informed consent and the documenting in particular of informed consent, as well as protocols for responding to participant distress and things like that. So I've tried to sort of typify the approach to training that was described across all three countries. And there were some consistent features. Initially, the classroom-based training, which was very theoretical-based, involved some sort of didactic knowledge building alongside some practical application through role play, and in particular that focused on communication skills and that kind of interpersonal interaction with participants. There was then a phase of pilot testing of research procedures and tools, and finally, the kind of ongoing routine implementation with some monitoring and supervision alongside that throughout the duration of research conduct. Generally, training was between 1 and 4 weeks long, depending on the type of study and the depth of pilot testing. And over the next few slides, I'm going to try and kind of unpack this sort of on-the-job apprenticeship training model that was used consistently in all organizations that I spoke to. So the initial phase of knowledge sort of building was very focused on a grounding in core ethical principles that were clearly reflected back to me by everybody I spoke to. So you heard do no harm, you heard informed consent, you heard confidentiality. These were all being repeated again and again. And the emphasis at this stage of training was very much on universal ethical guidelines, references to the Belmont Report, Declaration of Helsinki, etc., things that everybody will be very familiar with. And this training, therefore, kind of offered quite an abstracted view of research ethics, seen very much through these universal principles, often without necessarily much in the way of contextual consideration. It's interesting to note that when I spoke to researchers, the term ethics, particularly when it comes to speaking with research assistants, was not actually well understood. So this was not how it was conceptualized at the research assistant level. It was understood instead as codes of conduct or good research practice. As you can see from this quotation here, the training materials that were used were considered to be systematic, and organizations, that was something they were often quite concerned about. Systematizing things across a number of research projects that were being conducted, and only sort of minor amendments where potentially the population was, for some reason, considered more vulnerable, for example, with children. And the training was repeated to all research assistants, regardless of prior exposure to ethical trainings or research training elsewhere, and regardless of their involvement potentially in other projects within the same organization. In one country, they included at the end of this theoretical training this ethical exam, which consisted of 8 questions of which you needed to get 6 right. And this was very focused on core principles and procedures, and is essentially making sure that people had a understanding of these basic principles. And where that was found to be lacking, the training was repeated, the test was repeated, until somebody was considered to have sufficient knowledge. And I had a few discussions about the kind of why this approach had been adopted. And a lot of senior researchers within the organization, whilst they recognized that it was limited in what it would assess, it was felt to provide a kind of objective assessment that accompanied that kind of informal assessment of the extent to which they felt that somebody had understood the material that had been delivered. Alongside the theoretical training, there was this grounding was then complemented with the application of these skills to practice through role plays, again in a classroom-based setting. And this is where a real emphasis was placed by everybody on the importance of applying ethics to practice as a way to kind of embed knowledge and skills rather than kind of a theoretical-based understanding. It also provided an opportunity for supervisors to obviously observe research assistants, to provide feedback, particularly focusing on things like communication skills and body language, as well as being an opportunity for the research assistants to become a little bit more familiar with research information sheets, consent forms, standardized questionnaires, which, if you've ever had to apply them, often can be a little bit difficult to manage in the first instance. So actually a little bit of rehearsing of that was felt to be beneficial. And the focus of this, as you can see there, was on developing an empathetic stance towards the position of participants. And the quote here kind of emphasizes the relationship there that was drawn between needing to be empathetic and the position of participants, particularly when conducting mental health research, which in all of these settings, the mental health topic was quite sensitive and culturally sensitive, as well as in settings where participants have experienced conflict or disaster and the impact that may well have on their psychosocial well-being more broadly. During the third phase, this pilot implementation of procedures to practice, this often was undertaken in what was described as the near field, i.e. not too far from the main research offices. It was often, you conducted sort of a few interviews in a day, and there was very intensive supervisor presence. So particularly research assistants potentially going and conducting informed consent for the first time. Maybe a participant would have a question that the research assistant didn't feel equipped to answer. The supervisor was on hand to immediately help them address that and build their capacity in responding to those sorts of things. In addition, in one of the countries, this pilot phase was used to test and adapt the mental health instruments, for example, removing items that weren't working well, and that led to a deeper exposure within that country to research methods. And actually, in that setting, overall, there was a lot more reflected back the importance of the scientific validity and the kind of ethical responsibility to ensure that the methods we're using are appropriate and the data that we're collecting is reliable to guide evidence-informed practice. At the end of each day, there was nice intensive supervision, which often included additional training where common problems had arisen, and potentially also revision of things like informed consent forms if they'd have found that some of the language in it was being consistently misunderstood, for example. Amendments to the way in which something was being described would be agreed between everybody in the room. So the research assistants really contributing their experience back there and informing the way that certain research information was being presented. In terms of ongoing monitoring and kind of the routine monitoring and supervision that happened, this was really stressed by organizations as it being particularly important to monitor research practice. And this was done in a number of ways, but the reason for this was highlighted as through examples that were given of unethical practice that have been discovered. So, for example, telephoning a participant and finding out that whilst they had consented to the research and whilst they'd gone through everything that was asked of them, they had not been compensated for their time as they should have been, and the research assistant had kept that money for themselves. So actually examples of this monitoring leading to catching people out, or certainly to being able to rectify abuse of participants' rights was highlighted as why organizations engaged in this. And also the importance of avoiding a cooked data set, i.e. where research assistants falsify data, which is something I've heard reflected in a number of settings when it comes to humanitarian settings where potentially research assistants are under pressure to complete things and they sit and do that themselves underneath a tree rather than speaking to anybody. I think this quotation is particularly interesting from a primary investigator as to why they engage in this. And they talk about it being a responsibility to defend. And just to kind of unpack that a little bit, this language could suggest a number of things. It could suggest, as I've already identified, potentially the defense of participants' rights to things such as compensation. It could also suggest a defense of organizational reputation, which potentially could be harmed by the exploitation of participants. And I think the examples earlier where sort of rumors start up and things like that, potentially where an organization isn't behaving as well as they could be. and also defense of the research enterprise overall. Another aspect of monitoring was research assistant safety, which was emphasized in settings with ongoing conflict or where remote travel was required to remote sites, and the responsibility of organizations to engage in monitoring both of the safety for researchers to be out there doing research. For example, in one setting where there was terrorist activity and community suspicions, they engaged in a practice of pausing the research when there was other contentious activity that was going on that potentially could be conflated with research. For example, vaccination campaigns and things like that. The research was halted during that period because those people were targeted and potentially the researchers could be conflated with vaccinators and therefore be targeted. In terms of supervision, overall across all 3 countries, there was no real clear description of what exactly the supervision structure was, and there was no clear kind of use of tools or approaches to support the routine supervision of research assistants at the end of each day. It was described as a way to give an impression of field conduct by research assistants, but that was kind of largely focused around auditable things, such as the documenting of informed consent, or whether you'd plugged in your tablet to make sure that it was charging for tomorrow's research data collection. There was some scope for other issues. So, for example, if somebody came back quite distressed, maybe they'd had to deal with a participant who had got very upset in an interview, that would arise and would be discussed and explored within supervision, but it wasn't explicitly kind of being looked for. So what exactly does this approach to research assistant training kind of promote, and what does it constrain? So some ideas around what it promotes. Ethics very much in this context was construed as verifiable procedures, as we saw kind of epitomized in that ethics exam. And I think that this is a product actually of research ethics more broadly. It's not isolated to the organizations that I spoke to. And when you think about it more theoretically, kind of the work of Stratton around audit cultures, really people looking to measure what can be measured, potentially without even really thinking about the utility of those measurements. And this again is reflected, I'm sure a number of people in this room are familiar with the NIH, for example, online training that PIs have to complete to certify that they are ethically competent to then go into the field. It's purely symptomatic of the same sort of approach. Again, ethics as being very standardized. So this training model does suggest ethics as being a stable and standardized process, and kind of presents a bit of a facade, really, of organizations having some level of control over what happens in the field and over the sort of decision making. However, it also demonstrates an approach to ethics where ethics is integral to research, addressing that critique that potentially ethics is seen as a bit of an add-on or a one-step process. Very much the approaches were integrating ethics, or procedures at least, into research training. The risk of that is, of course, that by turning ethics into procedures, it can encourage rote application of those procedures without necessarily thinking through the decisions that underpin those. There was a strong emphasis on soft interpersonal skills, such as communication skills and how you present yourself within a community, and that was very much linked to trust, which was something that was mentioned earlier as well. So organizations were seeking to develop just enough ethical competencies so that they can have trust in their research assistants' behavior in the field, and that obviously being monitored through monitoring practices. So what this kind of constrains is an approach to ethics that is about judgment, without any deeper grounding in sort of bioethical frameworks, or even just ways of balancing decision-making and balancing competing priorities. Ethics was viewed as the procedures, and that was reflected repeatedly in research assistants' description of what ethics was. It also it prioritizes what's been termed kind of a view from nowhere, so training that promotes the view of ethics as universal principles without necessarily thinking about how they interact with culture, with perceptions of research, with ongoing contextual factors. And then finally, this monitoring of research assistants actually could be seen to be promoting distrust in the way your researchers will behave in the field, and can lead to an abdication of responsibility over ethical conduct to procedures rather than as a personal responsibility. So just some kind of concluding thoughts. There's a few quotations I thought it would be useful to share. The first one there from Dunn really reflects the challenge of the training model that I've presented, which obscures the potential ethical challenges that could arise in the field in favor of an approach that really reaches for those standardized procedures and protocols. And the second and third quotes just try to highlight the challenge of actually how do you go about training somebody to be to behave with integrity. And that's a big challenge. You know, how do you train somebody who's had no prior exposure whatsoever to ethical decision-making frameworks in using those and applying those in the field, particularly in humanitarian contexts where you have got, as we heard earlier, time pressures. So some concluding kind of ideas, and I'm not sure how applicable these are, but for everybody to consider is kind of whether it is possible to train research assistants in a framework rather than in procedures and protocols, to train them in ways to think through and to balance different competing ethical priorities. Also within supervision, potentially using that as a space to explicitly recognize ethical moments and potentially having reflective prompts and that sort of thing to help encourage discussion that explores the ethical considerations. And this was something that was reflected back to me after I'd done my interviews with participants, asking them about ethics. They kind of sat there and went, it would be really useful if we did this a bit more often within our own teams. And we sat here and we reflected from a specifically ethical lens. And then kind of the importance of ongoing mentorship and this opportunity to really deepen ethical knowledge and skills, and recognizing that a lot of the development of kind of being an ethical or behaving ethically is a product of experience, of application, and then of reflection. And that's everything I've got to say. Thank you very much.
Thank you, Anna, for this interesting presentation. I'm sorry that there will be no time for question and answer. We took quite a long time in the presentation, so I invite you to actually reach out to the presenter during the coffee break and then ask your questions. I'm sorry for that, but we really have to start the next session on time at 11. So I invite you for a coffee, and then
first.
Yes, is there,
yeah, we'd like to do the photograph now before you go for coffee. So just kind of just hold on to your decaffeinated status for another minute. Patrick, wondering if, can you put the PREA logo up and we do the photograph here? And also if we take a minute and have everybody wave to the people who are watching us online so that they know there really are people in the room, and that we know that they're out there watching us too. Will that work, Patrick? Great, thanks. So if you could come all up here, and let's face towards the big camera, and Haley has the little camera. Oh yeah, that would work. Well, hiding. So for any of you who are here on the travel scholarships that Mark McCann has been emailing you about, Mark is due to be here during this coffee break if you have any questions that you want to ask him. Okay, so
okay, so you're all ready to go. Okay, so there's your audio is doing its thing.
Okay. So we ask people to connect in 15 minutes ahead of time. But you've already tested somebody coming in from elsewhere?
I had a computer back in my office, and we tested, and they could hear me over the house sound.
Okay.
And I could hear you all once this was up and running, so...
Okay. Should be going then.
We should be good, so I have the info. I'm going to patch in again just to be sure that we didn't change anything with this.
Okay.
Still connected, so yeah.
And I guess I think we've got a PowerPoint to go up as well. Yeah. Oh, okay.
Okay. I thought Ryan was going to call back in, but I guess we'll wait. I think people are supposed to call in actually now. So we'll wait and see.
Hey there. Hello? Hello?
started. We've got connections with our online people, so let's get through before we lose those.
Talks on different sort of humanitarian settings and ethical challenges and case studies. Is that helpful?
Okay. It is. I'm wondering, could we face the audience, maybe instead of facing the wall? It's helpful for us. So for you, you're not able to see us anyway. For us, if you could turn that computer on, we could see the audience.
Okay. Yeah. Can we?
I don't know.
Can we? Oh, I see. Can they see the audience?
Yeah, Patrick, because you guys aren't seeing us anyway, you know?
Yeah, 1 second.
All right.
But I'm going to have my back to people, aren't I?
When you click through, yeah.
Yeah.
Last time we had a separate computer for this, which would have been helpful.
It's a bit tricky, Joe, for initially, because I'm going to have my back to the audience as I go through the slides, but we can do it when we do the Q&A. We can switch it around then, do you think? Okay, hold on, we're trying something.
Okay. Maybe there's a front and back camera as well. You can toggle back and forth.
There is not.
Patrick's on it. If it doesn't work, let's just go for it.
Yeah.
I don't know what's just
Yeah. There we go.
Yeah. All
right.
Okay, we need to start, I think.
Yep.
So, will you help me switch it around, maybe?
Absolutely.
Thank you, Patrick.
Come on. Get out of here.
And then in terms of finding them, it's this one, isn't
Yeah,
it?
it's that one there.
Okay.
So what we'll do is go ahead and do this. And then this is your presentation, correct?
Yeah. Great. Okay, everyone, we're going to get started because time is of the essence. So if you want to grab your coffees and sit down or move around with your coffees, that's great. Okay, so my name's Anna Skeels. I work for ELRA, and you've probably heard reference to ELRA and seen our logo throughout yesterday and partly today. But for those of you that don't know, we're a global charity that finds solutions to complex humanitarian problems through research and innovation. And we've got two programs. One of them I think will be quite familiar to you because a lot of people have already been funded by it, which is R2HC, which is Research for Health and Humanitarian Crises. And then our other program is the Humanitarian Innovation Fund, which I manage. So ELRA is the organization, and then we have these two programs. So this conference, as you know, the focus has been on humanitarian research and ethics, and then increasingly at the end of yesterday and today, also humanitarian innovation and ethics. And for us as ELRA, this is extremely relevant and important. We are and we strive to increasingly be a responsible and ethical actor in the humanitarian sector and take a very values-based approach. And Laura Walker-MacDonald, who might be someone that you're familiar with, says that, you know, ELRA doesn't move fast and break things, and we're really proud of that, a very kind of considered, evidence-based and careful approach, which is appropriate for the sector within which we work and the populations who we serve. So initially, a thanks to Donal for enabling us to participate in this event and to attend, which is great. Matthew Hunt yesterday was talking about humanitarian innovation and the humanitarian setting as a living laboratory and all the kind of risks and challenges that that involves. And he talked about how we've shifted in the sector from innovation with a small I to innovation with a big I. And as the sort of program manager of the Humanitarian Innovation Fund, I was sitting there thinking, I really feel the responsibility of the big I, you know, and I think that is absolutely right, that we need to be thinking about innovation very carefully, and we need to be thinking about the sort of checks and balances and mechanisms that we want to put in place to really operationalize an ethical and responsible form of humanitarian innovation. So this session is an opportunity for us to explore that a bit more with you. And
And we've got a panel of 3 Humanitarian Innovation Fund grantees who are going to share some of their experiences with you of how they have navigated, I guess, the challenges of humanitarian innovation in relation to ethical issues. Ooh. Sorry, not getting my next slide. Great. Okay, so 2 of these are joining remotely, and we can't see them, unfortunately, but we can hear them. So we've got Joseph Gay from Do No Digital Harm Initiative and Laura Hitti from WOMENA, who are going to introduce themselves in a minute. And then we've got Siobhan Harlow from the International Centre for Advanced Research and Training. Before we get started, just because we've got people joining remotely and because time is tight, just to say that when we get to the Q&A section, please try and keep your questions as questions rather than really long comments, and also make them quite succinct so that people joining can give you quite a clear response. And that I may need to kind of repeat your questions for people who are joining remotely so that they can really actively participate in the discussion. And just to say to the people who are joining us remotely, we've had this practice of having standing ovations before people speak and after they speak. So if you hear a lot of clapping, that's, that's what's happening in the room. Okay. So just quickly, just to say that humanitarian innovation, as we've heard yesterday and already, is a challenging ethical terrain. And there's an absence of... okay, my slide just switched. There's an absence of formal sort of established frameworks or mechanisms to actually kind of regulate this, I guess, or to set parameters around this. And so humanitarian innovators are left to kind of navigate this territory in multiple different ways. And what we want to do is share with you some examples of how some humanitarian innovators have done that. And then we want to explore with you what we might learn from humanitarian research ethics, and to really think about how we might kind of apply some of those lessons to the field of humanitarian innovation. So we'll now start with Laura, who's going to share her screen and talk to you about WOMENA. Thanks, Laura.
Hello, everyone. I hope you can hear me.
Yep, we can hear you.
Great, fantastic. So good morning, everyone, and good evening from here in Kampala. My name is Laura Hitti. I'm the Research and Projects Coordinator for WOMENA Uganda. We are an NGO working with bridging the gap between innovative sexual reproductive health solutions and implementation. And we currently concentrate on menstrual health, both in terms of menstrual health, innovative menstrual health education solutions, as well as reusable products, mainly reusable pads and menstrual cups. For those of you who are not aware of what a menstrual cup is, it's a medical grade silicone cup that is worn inside the vagina to collect menstrual fluids rather than absorb them, and is reusable from anything between 5 to 10 years and is essentially a one-stop solution for women's and girls' menstrual health needs, and thus hypothetically potentially very suited to humanitarian contexts. So in 2018, we received funding through the Humanitarian Innovation Fund from ECO and UK Aid to test the integration of innovative menstrual health solutions, both menstrual cups and reusable pads, combined with menstrual health education into existing humanitarian programming. And the cluster randomized control trial, sorry, just having some problems switching my, my slide there. The cluster randomized control trial was meant to be carried out in 2 refugee settlements in West Nile, northern Uganda, primarily with a South Sudanese refugee population, but also including a minimum of 30% host populations in line with Uganda's refugee policy. And the study aimed to test the feasibility of integrating these innovative menstrual health solutions into WASH, livelihoods, and educational programming, and to reach about 2,000 girls and women. As far as there hasn't really been any rigorous scientific evidence on integrating menstrual cups in a humanitarian context, and this, to our knowledge, would have been the first study of its kind. Menstrual cups have been used in programming in Uganda since 2012, when Womena conducted its first pilot intervention in northern Uganda. And since then, numerous actors, both kind of developmental and humanitarian, have piloted menstrual cups as a part of their programming. Last year, when working with a school-based research project, we actually failed to get ethical approval to include menstrual cups in that study, mainly because we were working with girls under the age of 18. And as a result, we decided to change the HIF project to include only adult women and to implement only in Bidi, which is one of the world's largest refugee settlements. And throughout 2018, we've been working on getting approvals for the study at various levels with the UNHCR, the Office of the Prime Minister, which is the government office responsible for refugees in Uganda, the Ministry of Health, and finally ethical approval from an institutional ethics body, as well as the national ethics body. Unfortunately, having received support from both the UNHCR and the Ministry of Health, in January this year, our ethical approval was denied by the Institutional Research Committee on the grounds that we had not provided sufficient justification for the study taking place within a refugee population rather than a general population, and the perception that the sanitation conditions within the refugee context or the settlement were not sufficient to ensure safe use of the menstrual cup. And so we're currently in the process of bringing the project to a close, and obviously not proceeding without the ethical approval. So along this process, we've kind of identified three core challenges related to ethical approval for innovation in humanitarian contexts. The first of these really is the nature of the innovation itself and misconceptions about that innovation. The menstrual cup is a fairly foreign and new product. It's not widely known within Uganda. And there's a lot of misconceptions in terms of the safety of its use, particularly in relation to lack of rigorous evidence elsewhere, as well as community acceptability of the product. And the second kind of misconception, I feel, is related to the nature of the humanitarian complex itself. One is in relation to where within the humanitarian cycle we are. So in Uganda, where the kind of South Sudanese refugee situation at least is moving to a more developmental stage. And there really is a need to investigate more sustainable solutions. So for menstrual products, for example, women that we spoke to in our exploratory phase had only received 3 packs of disposable products about a year and a half ago when they first arrived. And the logistics related to continuous distribution of these products is quite significant. And there is maybe a lack of recognition that some more sustainable solutions are required. And the second is reflective of the reason why we did not get our ethical approval, which was the perception that the sanitation conditions are kind of subpar or not adequate for safe use. But visiting Bidi, I think it's fairly clear that, the sanitation structures that are available are actually often better than they are within general populations. The second area is navigating approval mechanisms. So understanding kind of which humanitarian gatekeepers you need to approach and in which order. Do you get approvals first from the Ministry of Health, then from the Office of the Prime Minister, or do you get ethical approval first? And who requires what in order for you to be able to proceed in that process? There are actors who are not so familiar with the humanitarian complex, and it can be difficult to judge whether their decisions are based on ethical principles or at times based on political reasoning. And the third challenge is extended timelines. In the initial phases, there is a need to consult with communities, and realistically, that increases expectations. So as the time has gone by for us in this process, the expectations have grown, and people have been waiting for this intervention, essentially, and rumors spread about an intervention coming. And we're now basically in a situation where we have to mitigate some of the negative consequences that have been caused by that extended duration of trying to get ethics. So in terms of kind of encouraging research for innovation in humanitarian contexts, we've noted that there really is a thin line between research towards innovation and programmatic implementation. And a lot of implementing organizations don't want to go anywhere near ethics because of the timelines involved and some of the complexities involved. So what do we really need to do to encourage research for innovations to happen in humanitarian contexts? Firstly, I'd say openness to innovation and really advocating for research in humanitarian contexts. And also supporting researchers and implementers in building their justification for why an innovation could be useful in a humanitarian context and should be tested in a humanitarian context rather than within the general population. Secondly is ensuring participant protection. So ethical decisions should be made on the basis of participant safety. But this can be particularly difficult in humanitarian context. And when working with innovative concepts, there is a kind of communication gap that needs to be bridged. Working in Bidi refugee settlement, we were in 13 communities, and we had anything between 5 to 10 different languages spoken in those contexts. And we had to invest significant amounts of time and resource into translating terms, simplifying our tools to ensure that we were really able to express the information that our participants needed to be able to make an informed choice. This also related to kind of guidelines for expressing complex medical concepts. For menstrual cups, there is a very negligible risk of toxic shock syndrome, and that in itself is a very complex medical concept. And we actually ended up developing kind of visual graphs to explain some of those risks. But there really isn't a lot of guidance in terms of how to work with these kind of concepts in multilinguistic and low literacy contexts. And then third really is balancing the dynamics of shifting social contexts and this perception of kind of who gets to be a part of an innovation, a research project, and who has to be a part of it. So really understanding how participants are really able to make choice in the context that we're working in. And I would say that all that builds to ensuring that we're building researcher and implementer capacity to navigate these kind of shifting approval processes and really understanding how we express the concepts of research to participants in a way that is understandable so that we can actually prove participant protection as a part of our process. And then finally also building kind of stakeholder decision maker capacity when there generally is, for menstrual cups, for example, there is a lack of rigorous evidence in terms of the safety and acceptability of the cup. And decision makers need to make a decision without that information to encourage research for innovation. There we go. That's me. Thank you very much.
Thanks so much, Laura. You're getting a standing ovation. Great. Thank you. Okay, so now I'm going to introduce Siobhan Harlow from ICART, who's going to present her case study. And I'll do some reminders in terms of timing. Sorry, I know it's a bit rude, but it helps to keep us to time. Great, thanks a lot.
Thank you very much. So, as I've mentioned, I am an epidemiologist at the University of Michigan. I'm here today in my role as a consultant to ICART, which is a research unit that was established as a collaboration between the Ponzi Foundations and Hospitals and the University Evangelical in Bukavu. and with a lot of support from the University of Michigan. The goal is capacity building to build local research capacity to address local needs. Okay, so there we go. So Pansy Foundation and Hospital, for those of you who do not know, is run by Denis Mukwege, who is the recent recipient of the Nobel Peace Prize. He started the hospital to address the needs of women in childbirth, and then during the conflict began to address the issue of women with who are suffering from conflict-associated sexual violence. The Pansy model is a 4-pillar holistic healing model where they address physical care, psychological support, community reintegration, primarily in the area of developing economic autonomy for the women, as well as legal assistance, with a commitment to both innovation and evidence-based care. So I was asked to provide some support and consulting in the innovation project Healing in Harmony, which is one of the models that or the innovations they've used to provide psychological support. It's a collaboration with Make Music Matter, where women work with a psychologist and a professional music producer to write and record songs that they subsequently perform and distribute through radio and social media in an effort to provide more community engagement and to break down stigma. Now, I'm not a psychologist, so I can't fully explain the program, but it is a combination of psychological cognitive behavioral therapy while also developing women as artists and their artistic expression in group settings. And here I have some pictures of both the intervention, medical, and music producing team, as well as the researchers in training. And I'm not presenting any pictures of the clients because, again, the ethical issue of presenting pictures of clients that are receiving medical care is problematic both from a medical perspective, but also they were our research participants, and so we had promised them confidentiality and lack of exposure of their identity. So we had a number of research issues that came into play. My timing, I just want to make sure my time was working. A number of research issues that came into play when we conducted both a pilot that was originally done at the hospital. They used a comparison group of women who were in the therapy program and another group who was in a literacy program where they assessed them for mental health distress before and after the 3-month program. And then we wanted to scale it up with the money from the HIF to a rural clinic where women were continuing to live in a region of conflict and insecurity. So there we used a step wedge design reflecting the capacity of the treatment program, where we could not enroll all the women with an interest in care at the same time. So they're enrolled over the course of 3 rounds. They were enrolled initially, but then got their treatment over the course of 3 rounds so that we could compare their experience prior to treatment as well as when they were in treatment and then post the treatment program. So a number of ethical issues came into play. One was, well, what is the question that we're really asking the research about? So the primary question as I came into the project had to do with, well, are their mental health scores improving? At some level, we know that if you provide psychological care in most settings, people do improve. So really trying to sort of press the issue more in this context of how are we adding to scientific knowledge, and if we were going to do this research project, what are the other kinds of questions that we need to be asking about? So we have incorporated more questions, really trying to understand what are some of the characteristics that would influence greater likelihood or less likelihood of ability to participate, as well as the impact of the program, as well as trying to look at the longer-term impacts over time, not immediately post-treatment, but also continuing to look farther out to try to understand what we may need to add to these programs to ensure sort of ongoing development of psychological strength. In the areas of ethical review, we had a number of challenges. One of the early actions of University of Michigan's engagement was actually to help develop the first ethical review board in Bukavu, with training of the ethical board, their actual certification through the city program. And so this, to provide that opportunity that any work that was being done in the context of the Panzi hospitals was in fact receiving some kind of independent objective review of the risks and benefits of the work. One of the issues that really confronted is trying to understand the importance of local regulatory requirements and local review. And in fact, just as we had completed our work and gotten our approval, the Provincial Ethics Commission came, and which had not operated before, but was establishing their own IRB, and made a big point that any health research conducted in the Democratic Republic of Congo by law requires local ethical approval. So the issue of really trying to understand local law, even when it's not yet implemented, but being aware of the law and trying to ensure that you're building that capacity becomes quite critical. One of the issues we faced was the issue of adolescent consent. The original applications suggested they would be women over the age of 18, while the clientele was not over the age of 18, and the majority of them were between 15 and 18 years old. We did find that some had been enrolled even younger than that, and that we actually do not use their data. But we also had to go back to the Ethic Review Board and really consider this issue of what do we do in the context. So that involved understanding what were the legal situation in terms of who is a minor and considered a minor, who or as a legally independent adult. You're in the context here of early marriage, as well as in a context where a number of young girls have been abandoned by their families. So there is no parent available. And then, also the people don't necessarily know their age. So the whole question of how sure are we of the age of an individual. So it involved a great deal of discussion with the local team, understanding the local environment, as well as reviewing and then providing to the review board, what is the various determination around the issues of adolescent consent and assent that have been discussed and promulgated by various different review bodies. In the area, sort of moving on, sort of the issue of the importance of having rigorous methods, understanding program constraints. One was how do we design the program and the research project so that we're not doing more to promote stigma. So the issue of, although there was an interest in providing care for survivors of sexual violence, that you actually have to provide care to a larger, more diverse body of individuals in need in order to not become identified and stigmatized. So the issue of how to incorporate control groups, both without creating stigma and without withholding treatment was something we struggled with in both the pilot and then the scale-up project. And I can't emphasize how important this is, because as it turns out, simply in the pilot, simply participating in any program was beneficial to mental health, because this is a displaced population, and having some opportunity to reintegrate into a social structure improved mental health. So really understanding the impact of the particular program, you needed to understand the broader context. In the second case, we actually would have underestimated the impact of the program, because this is an area of ongoing conflict and violence. So in fact, what we saw in the group that was not yet in treatment during the first round, there was a lot of conflict in the region at that time. And so their distress actually went up. So we would have misrepresented the amount of decline that occurred. And raises many questions about the importance, I think, of psychological care during periods of conflict and ongoing conflict. And then the issue of having adequate sample size. As the person responsible for the researcher, every time they kept cutting the budget, I kept going, you can't do that, you can't do it. Because in the end, if you don't have a large enough sample size, you shouldn't do the research because you can't answer the question. So we ended up having less than I would have desired. We also had to reorganize where we did the work because one of the groups that was supposed to come on was not going to come on in the time we had the funds for. So we had to increase the work we did at one site and not include the 2 sites. So then sort of the areas of really sort of training the research staff, as has been mentioned many times, to understand consent and to avoid bias. I won't go into that as much because I think we've had a lot of discussion of that. But also understanding some of the operational constraints. So, you know, being a researcher, they're very clear that we have to de-identify the data, that we've told people that we won't have identifiable data. And yet we wanted to contact women repeatedly over time. And so, you know, my initial idea of we'll take their names off actually was quite problematic off the documents that where we had the, you know, connected to their data. Because of the issues of, first of all, age doesn't help tell you whether you have the right person because their age actually changed over time because the age as a concept was not so fixed as it is certainly in our society, as well as sort of just that understanding of tracking individuals and making sure you're finding the right person is part of the issue of capacity development. So it raised many challenges for us. Am I done? Okay, so just lessons learned very quickly to build into your research in as part of program component from the planning stage. Really think about what is that research question that's adding to knowledge, the need to identify a local appropriate independent ethical review body, ensure that you have the adequate funding and appropriate expertise to generate quality evidence. The pilot was sort of iffy in what it could say. I think with our larger, what we've just completed, we really will be able to make scientifically sound statements. And then to be very realistic about what the ethical, financial, infrastructure, and technical capacity constraints are in the area that you're working. But always, the obstacle is there, the challenge is, how do you go around or overcome it? Thank you.
Thanks, Siobhan, that's great. And then I'm just going to hand the screen over to Joe Gay, who's going to talk to us about conflict monitoring, civilian conflict monitoring in Myanmar. And I think Joe's going to share his screen.
Thanks. Let's see.
You're a standing ovation while you're uploading your screen, Joe.
Trying to figure out how to share the screen. Let's see. There it is. Great. So is everyone, can I just get confirmation, Anna, that you can hear me and that my presentation is on there?
Yes, to both.
Great.
Thanks, Joe.
Okay. Hi, everyone. So my name is Joe Gay. I'm going to be another voice in the room, so sorry about that I'm not able to be present with you. I wanted to just briefly say that it's really great to hear from the other panelists, because I think that even though we might come from different disciplines and have some unique experiences, there's a lot of what Siobhan and Laura talked about kind of resonates with us and some of our experiences. So I think it's great that Anna and Elra are able to bring together these kind of sort of snapshots of experience, because I think collectively we're really starting to make progress in the ethics conversation in humanitarian innovation. So super happy to be here. So a little bit about my background. My background is really in sort of conflict studies and security. So I'm a social scientist, and lately have been doing lots of work around humanitarian technologies. So anything from remote sensing and satellite imagery analysis to mobile data management in the contexts that characterize humanitarian emergencies. And while in the last few years I've been really focusing on innovation, the opportunity around innovation, lately at the Do No Digital Harm Initiative, we've been kind of strategically focusing on digital surveillance, electronic exploitation, and the weaponization of information. We think that there needs to be kind of a counterbalance to the innovation discussion, and that it can be better informed by risk management, data protection, digital security, and technology ethics. So that's kind of what we hope to share with you today. So as Anna mentioned, the reason why, or one of the things that we can share with you is that I'm also, along with my colleagues, Lisa Rudnick, Leor Levy, Stephen Gray, and Hubert Oldenhouse, we're grant recipients of the Humanitarian Innovation Fund. And the specific project that I'll be talking about today, before we kind of pull out from a 10,000-foot perspective, is the Myanmar Civilian Monitoring Initiative. And that involved working with the Nonviolent Peace Force and the Civilian Ceasefire Monitoring Network in Kachin State, Myanmar, in the last summer of 2018. They're now known as the Community Peace Support Network, the CPS. And we were given an early stage innovation grant. It was really around sort of problem recognition to basically to build the foundations for an informed innovation process. So the first step in this phase was the diagnostic or the learning phase. And we wanted to learn a little bit about the challenges that local communities and local actors were facing in Kachin State vis-a-vis security, conflict monitoring, and ceasefire monitoring in kind of their peace-building work. So all of this that I'll share with you is basically part of an evidence-based design process, and the first phase of that is what we are calling problem recognition. And so we had some of our team work with the Nonviolent Peace Force and the CPS to explore ways of building capacity around data management, in particular mobile data management, because the network in Kachin State was comprised of ceasefire monitors that were using analog methods to report on instances of ceasefire violations or other kind of conflict and security early warning indicators. And we had a hypothesis that we could introduce some new technologies to address the challenges that the actors were facing in their work, and also to contribute to more timely, verifiable, and context-relevant information. So you can see the project objectives there. Now, I'm going to tell you a little bit about the process that we used and some of the initial insights that we have around kind of challenges that we experienced from an ethical perspective. And then later in the talk, I'll sort of talk about key takeaways. What can we take away from this in terms of broader learning for the humanitarian innovation community? So first is, what did we do? So we spent some time with the network in Kachin State, and we had a research agenda that was kind of based around the 5 questions that you see up there. And it's really about sort of learning about the civilian monitoring network, its purposes and functions and practices, how the work was carried out by particular stakeholders that we were supporting, learning a little bit about challenges and risks that were experienced in this work, and then kind of analyzing whether any of these challenges could be addressed through technological solutions, and which kind of challenges were critical for us to address as a partnership with the Nonviolent Peace Force and the CPS mechanism. Now, that approach allowed us to learn a whole bunch of highly relevant and consequential things for the project. You can see in this photo, we're doing kind of a sort of a mapping exercise, and it really allowed us to spend lots of time with monitors where not a lot of NGOs or international actors were able to kind of understand a little bit about how this network operated. So we did some mapping, some data flow activities. We did a whole bunch of interviews and focus group discussions, and we spent a lot of time with the organizations up there, kind of learning about their data management systems and how they were generating and using information for the purposes of peace building and conflict monitoring. So aside from the substantive things that we learned, we immediately came across some challenges. Now on this slide, I'll tell you a bit about some of the factors that led to us being able to respond to the challenge, but I'm just going to go back here as a placeholder slide to tell you about some of the challenges. I didn't put them on a slide because of the sensitive nature of them. So first was that just simply our being there, an international team, posed direct and consequential challenges to the stakeholders that we were supporting. So in other words, by us kind of carrying out research activities, it had the high potential and did in fact put some of the monitors and the stakeholders at risk. Now, you can imagine in a context of Myanmar, which is a very much a surveillance state, and Kachin state is sort of low-grade active conflict, that people going around asking questions and holding meetings with community monitors could raise some eyebrows. And indeed, that was the case in which the military intelligence would often visit some of the meetings that the mechanism holds in terms of its capacity building and training meetings. And so it could put local actors at risk. The second area is that it posed a significant security risk for our team. Members of our team every day were monitored and surveilled by the Myanmar government, by the military intelligence, and there were a couple of instances of some of the operatives kind of asking questions about us and showing up to some of our meetings as well. So it put the network and it put us at risk. The third area that I want to talk about is just kind of the nature of digital technology solutions in the context of conflict monitoring. So it's not just that we were doing research with people in that context, it's that we were proposing to develop and field test information management solutions that would influence or impact the conflict context there. That's a really sensitive issue. And I think it points to the fact that innovation, sort of the systematic and strategic application of information and findings and insights for the purposes of developing solutions is a little bit more complicated than just doing research. So we were actively identified as a group that was building solutions to kind of change conditions on the ground, and that's I think is a big takeaway. And especially when you add digital data-driven technologies to that, it really can complicate the situation. So those were kind of the three issues that came up, and some takeaways for us to respond to them. Okay, so what did we do? Just quickly, we made sure that our team were taking very seriously matters of human subjects research and data protection. So we worked with ethical guidelines coming out of the Innovation Guide and some of the other more fundamental sources such as the Belmont Report and things like that, to ensure respect for persons, to ensure confidentiality, to make sure that participants knew that this was a voluntary study. And we spent a lot of time making sure that there was really informed consent. And we took great precautions in terms of data protection and information assurance. In this case, just as an example, we didn't record any of our sessions, and normally we do. You can still have anonymization, and you can still, securely manage data that is recorded. But the situation was so sensitive politically and from a security perspective that we didn't record anything. We didn't write down anybody's names, and in terms of anonymization and things like that. And we destroyed all of the data, all of the primary data at the end of the analysis while we were in country before we left the country. So that's kind of some, what's that?
3 minutes.
Okay. Yep, it's all right. And the other thing that we did, just to give you an example before we go into the high-level takeaways, is we had a number of security briefings. We developed security protocols and digital security checklists for our team before we got on the plane. We spent a lot of time with some experts from the Do No Digital Harm Network to build the capacity of the team to make sure that we had secure communications, that we were browsing, accessing the internet in a secure way while in country, and things like this. So we took precautions. And I think that speaks to three factors in this case that led to an ethical approach. First is we were problem driven. So just to speak a little bit about this, we weren't interested in developing and implementing a solution that we thought would work. We really spent the time to understand the challenges and the context for which the stakeholders worked in. And because of that, we had a mandate and we had the space to say no. Well, it turns out, after spending a lot of time learning up there, that it's probably not the case that mobile data solutions with more granular, timely information about conflict-related incidences would improve the situation there. In fact, the story is a little bit more complicated. And because we were problem-driven, we built into the design brief at the end of the problem recognition an approach that addressed some of the security and data protection concerns we had up there and didn't already implement some kind of solution that we thought would work. The second is security focus. We talked about this. We set up a technical advisory group and developed protocols. And the third is being locally informed. So we really had a participatory approach to elevate some values that might be invisible to outsiders in terms of trust and things like that. So I think that's something we can learn from. The other aspect that we work on, that I work on with Anna and others, is sector-wide humanitarian innovation. So we're helping to build an innovation guide, and we're in all sorts of multilateral conversations at the global policy level in terms of how do you do humanitarian innovation. And I just want to pose something to the audience, and maybe we can talk about it later. I think conversations around ethics have almost nothing to do with what the ethics are. In fact, I don't really care so much what the ethics are. We have enough good work on the list of 6 or 7 or 8 principles and standards and things like that. I think what matters is how do you operationalize them? And what we don't see enough are conversations around 3 areas. The first is how important context is. When there's a data breach in the United States and my data is compromised, I have to spend an hour and a half with the credit card company, and that sucks. Calling them, getting a new credit card or something like that. When there's a data breach in Kachin State, Myanmar, people disappear. And so I think that if, as practitioners, we have conversations around ethics, we need to really be highly contextual. There's a difference between, even in Kachin State, if we were doing a water and sanitation project in Kachin State, versus the conflict monitoring project we did that was really highly contextual and it mattered. The second is agency. We need to have sort of better understandings and expectations of who is responsible for innovation ethics. And that's a function of two things: visibility on unanticipated outcomes or sort of what's going on behind the scenes. Do you have visibility to that? And are you able to influence outcomes, either positively or negatively? And that's a good way to identify who ought to be involved in conversations around ethics. And then the final point is just decision points. You know, I'm probably not going to make a lot of friends by saying this, but it's not always about ethics all the time. There are certain phases of an innovation life cycle or steps in a project where ethics become acutely important, and there are other phases and steps where they're probably less important and the dial is a bit dialed down. So we need to figure out what are the decision points and who's involved in those decisions, especially with local actors, on operationalizing ethics. In our case, we had 3 decision points in the learning phase: pre-field preparation, decisions that we made while we were in the field, and decisions that we made during the analysis of the data in terms of building the design brief and choosing to go in one direction versus another. I think in the innovation life cycle, there are a number of key phases and decision points where ethics become really important. And what we're trying to do with the guide and other materials is highlight what those points are for innovators. So I'm going to shut up now, but thanks for listening, and I hope that there are some questions that we can talk about later.
Thanks, Joe. That's great. Thank you. Thanks very much. I'm looking at Donal because I know that time in general is running quite tight. Have we got time for questions, or is it better if people come in 5 minutes? Okay, 5 minutes for questions. Any questions? Or indeed reflections in relation to, can pop up some questions on our side that you might want to respond to. Yep, one at the back there. If you could, yeah, and if you could use the microphone, because obviously the remote participants need to be able to hear.
Thank you. So I'm Dana Howard from the Center for Bioethics here at OSU. I was just wondering about, I mean, this is, I guess, more of a reflection, but just thinking about, it's an ethical question about what our duties are to communities when research, when a research protocol doesn't actually get approval. It is a sort of interesting question that seemed to have come up with the first speaker about, you know, I mean, if you can't actually do the research, do we still have any sort of duty to the potential research participants to provide the cups, because that was sort of the expectation, or, you know, and it's frustrating that we can't get any sort of feasibility data from it, but yeah, so I was just wondering, I mean, it was sort of an interesting problem that seems to come up more now that we think more about consulting communities early on in the development of research questions.
Okay, great. Did you get that, Laura?
Yes, I did. Should I answer that now, or do we want to take
go ahead.
Other questions?
Yeah.
Okay, great. Yeah, so I think that's a very valid question, and that's something that I guess we're still in the process of figuring out. So we also had a study review board on this study, and as kind of the ethical approval or denial of ethical approval came through, we obviously had various conversations with our study review board, and their kind of joint advice was that we should not proceed with any form of implementation specifically because we had, although there's a recognition that there's ongoing programming that is, using menstrual cups and distributing menstrual cups in refugee settlements in northern Uganda, because we had specifically for this study received a rejection of the ethics, we shouldn't go ahead. We are currently actually talking to our implementation partner, and HIF has again been very supportive in terms of kind of what steps we make to close the project in a way that we can mitigate any kind of negative consequences on the ground and deal with some of those expectations. And at the moment, we're looking at still providing some form of kind of menstrual education and potentially reusable pads, which themselves are not that contentious in compared to menstrual cups, to at least a proportion of the communities that we kind of consulted and started working with. So we're really kind of looking at making sure that we can still reach those communities, or our implementing partner can still reach those communities and provide some form of menstrual health education and some form of kind of support in terms of product without going kind of against the decision made by the ethics board. I think we're very conscious of the fact that, we do want to enable research for menstrual cups in the broader Ugandan context, and we don't want to be seen as going against the ethical approvals that we have at the moment. And we're kind of looking at building some advocacy activities to kind of nudge the kind of general opinion about menstrual cups within the kind of ethical approval world. But yeah, we are definitely looking at how we can mitigate some of those by providing some form of intervention without it being a research project itself.
Thanks, Laura. And I guess a broader point that's come up is who's making those decisions, who's doing the review, and what are their kind of capacities and capabilities in terms of kind of providing that approval and making those decisions. And Joe was mentioning about the tag group, so getting really the right people involved at the right stage in terms of decision making in relation to the innovation as well. But of course we haven't always got that option. Yeah, go ahead, Siobhan.
I'd be curious in that situation who the approvers were and what their sex was. Because I think, particularly when it comes, I've done a lot of research on menstruation over my life. And when it comes to that issue, I don't want to touch it, they don't want to talk about it, they don't want to touch it. And so it brings to the question, who is being represented on those boards?
Yeah, very good point in terms of gender and politics. I think maybe one more quick question. Yeah, and then we need to stop.
Unfortunately, it does relate to the first presentation as well. So I'm wondering, with the refusal of the ethics approval, whether the speaker, do you feel that it was a gendered thing, or did you see any kind of valid concerns? I mean, I would be concerned about UTIs, which were not mentioned as a risk, but any bacteria entering the vagina. UTIs are serious in a refugee camp, I would imagine. Super painful as well.
So you happy, Laura, just to come back sort of briefly on that, and then unfortunately we're going to have to close, which I know is frustrating, but people can come to me and sort of raise issues, ask questions, and I'll make sure that I sort of summarise them and share them with the two panel members that are not here today as well. So if Laura, just come back on that, and then unfortunately we'll have to close. Thanks very much.
Yeah, sure. No, I think that's a very valid question. I think definitely the menstrual cup itself is a vaginally inserted device, and hand washing, for example, extremely important in refugee contexts that we are working in. Soap is very scarce. I think the core question, though, is in terms of whether there's a heightened risk specifically within a humanitarian context versus a general population. We do have limited evidence in terms of the safety of menstrual cups. There's a study in Kenya, for example, that's ongoing that shows that there isn't any increased risk. But I guess that's the issue with innovative products, is that you have limited evidence on the ground. So the concerns are very real, and we did actually also have, as a part of the study, have a sub-study on safety with gynecological tests, and also enhanced monitoring on the safety elements. And I guess the question is, this program this programming is ongoing in the field, and actually having rigorous evidence on the safety could actually be protective for participants and for vulnerable populations. And obviously, if the results of the study were that it was not safe, then that could also have a significant impact on a shift in programming. But yeah, very valid concerns.
Thanks, Laura. Thanks very much. Thanks, everybody. And can I just sort of invite people to kind of grab me at different points and just have a chat about operationalization of a sort of ethical approach to humanitarian innovation and your thoughts on that? That would be great. Thanks very much.
Okay, everybody, thank you to Anna and to the panelists. For lunch today, there are box lunches available in the room where the food was for breakfast and some additional drinks as well. So the transition here is kind of short because of the program that is part of the Ohio State University's Research Ethics Initiative for the year. So if you could go to the next room, get your lunch, and then bring it back in here. And then Dana is going to transition over to the care discussion, and that will then go on for a while. And we'll take a break after that so that you don't go straight into the afternoon session without some sort of deep breath. So, okay. So thanks.
We can close them out of limits here.
Oh, thank you.
Hi, Pam.
Yeah, it's been great. It's a really great like cohort of people that are like coming from a lot of different perspectives. A lot of people are researchers that are in the field from a lot of different places. So there's a lot of people from Ethiopia, South Sudan, Venus from Malaysia, India. So there's like that. There's a lot of people from the UK and Canada that are interested in research. That's sort of like, that's the group here. So it's like, there's a lot of expertise on like humanitarian aid. I was sitting in the back. You could see my felt computer bag is right there. It's like right in the back, like right before, near lab. For those that are watching on campus elsewhere, we are going to start in 7 minutes. So relax. And I'll just go through the questions. So I'm gonna stick to the script. They have gone. I mean, it's like it's basically about pulling. So I'm hoping people are like already thinking about issues that are kind of come up, and we can just like sort of be the vehicle for having this conversation. Does that make sense? But we definitely need to. Alright, so let me put the. I think so.
Just going to put this back into.
Oh, great.
presenter mode for you guys. Always takes a few seconds. And do you have a PowerPoint for this?
Yes. So the Vina is, where is it now? Right there. Okay. And then also shared splash screen. Okay. Great.
And I'm just gonna make sure. Presenter mode for both of these. And then which one are you starting with?
We're starting with this one.
Okay. Presenter mode.
Or actually, I guess we're starting with this one.
That's
and then we're gonna go. That's her presentation. Cool. This is just gonna be the one. So how do I shift from one to the other?
If you just go down here.
Mm-hmm.
So what I would do is just hit escape. Go down here, click on the other one.
Okay.
And then beginning a slideshow there.
Sounds good. Yeah, I have it. I have it. Let's see if they need any additional. I do. Mm-hmm. So I'm learning a lot. Yeah, this is the third one. Yeah, I mean, the hope is to have this sort of cross-discipline conversation, and so far I think it's been pretty neat. Like, the worry is always like, you know, it's like because it's cross-discipline, you don't get to like the real like details. It's like stays at the superficial, but I think that maybe it's because the conversations have been an hour and a half. Like people really, I mean, people have just sort of talked to their own experience, and you end up really getting interesting insights.
I just think that making this everyone's issue is right. Like working in NGOs, it's often the medical doctor that's like protecting everything, and everyone's like really like super eager, they're very anxious to do things, and doctors are like protecting, and then they look at us as like they say like you're not letting us, you're being territorial, and you're like, oh no, this is just like what we have to do as part of like our obligation. Like we really don't care about territory, and it gets really confusing by like sharing that. Because I think ethics and research has really made really came from clinical research, clinical, and so then when you go into social sciences and other research with human subjects, people tend to forget about what's the cost of clinical research. Like everyone knows that. It just gets blurry when it goes into other disciplines because that's not where it started.
Right.
So it might have to change, but it still has to be followed. I think that's really interesting.
And as like the bioethicists, we're usually protect.
Yeah.
So it's nice to see that like
exactly. That's what I mean. Like people like understand bioethics and like get that it's like everything.
Yeah.
But,
they're
depends where the pregnant women are, but yeah. They are pregnant women in
they're containers of
society. Yeah, that's true. Then women become
Then women are very vulnerable. And then we don't include them in every program. When you are in clinic and you have research, we always see there is no data on pregnant women. There is no data on nobody is including them.
All right. So We're going to start. Welcome people across OSU campus and welcome people at the Fawcett Center. Thank you so much for participating. We're really excited about this panel, and it really has been a treat to be here for the past day and a half to just like by osmosis take all of this collective wisdom of the ethical challenges that people have been facing on the field and thinking about research ethics and humanitarian crises. So my name is Dana Howard. I'm from the Center for Bioethics at Ohio State, and I'm going to be moderating the CARE panel. So CARE is a program through the Center for Ethics and Human Values that was created to provide opportunities for researchers across OSU to have these sorts of conversations about research ethics that go beyond regulatory oversight and research integrity, basically beyond checking boxes. And this is our third session. We've had one on the ethics of reproducibility and one on conflicts of interest in research. And so we're really excited to have Vina, Aaron, and Marcel here to discuss today the ethics of research in humanitarian crises. So disasters and conflicts, and I should say that this is funded by the Office of Research and it's supported by the Center for Bioethics and the College of Public Health at Ohio State. So disasters and conflicts lead to crises that call for humanitarian responses. How can we know that the type of response being provided is actually effective, is timely, and is the best use of available resources? To answer these questions, there really has been this recent drive to try and get more evidence-based practices. But with that come the ethical challenges of dealing and working with research participants, human subjects that are in very vulnerable and precarious situations. And so today we're going to be talking not only about sort of the ethics of engaging in humanitarian research, but the ethics of engaging in research more broadly in humanitarian crises. But I think many of the lessons in the cases are going to be able to be translated across questions. So we have as our external expert, Vina Pillai. Vina combines her medical license, research and interest in humanitarian work with refugees in Kuala Lumpur and Penang, Malaysia. She's the director of DHI, which is a consultancy focused on humanitarian research. She's really consulted across the globe when it comes to humanitarian research, and she currently also works with Medicine Sans Frontiers in providing basic health care to refugees in the Rohingya crisis. Her current research is in the areas of refugee health and disaster response. So Vina is going to speak for 10 to 15 minutes to just sort of present some of the important ethical challenges that come up in this context. And then we're going to have two of our guests from OSU respond from their own experience and their own ethical challenges working in the field and working at OSU. So we have Erin Lin, who's an assistant professor of political science and global food politics at Ohio State University. Her research focuses on the legacy of war on development. She studies how unexploded ordnance disturb daily economic activities and have long-term consequences on post-conflict recovery. For example, she's worked in Cambodia to explore how bombing in high-fertility land can result in an increase of likelihood of subsistence farming. She's a team member in the Initiative for Food and Agricultural Transformation, in fact, at OSU, which is a university-wide effort to encourage cross-disciplinary research. And her collaborative research projects include the use of machine learning models to identify bomb craters and the location of unexploded ordnances. And then Marcel Yotabieng is associate professor in the College of Public Health. Over the past 2 decades, he's worked in multiple countries in sub-Saharan Africa as a clinician, as a public health practitioner, and as a researcher. He's also the co-investigator on large cooperative agreements from the NIH and the CDC that have basically funded, they've provided him and collaborators an opportunity to build strong research infrastructures in the Democratic Republic of Congo. So what we're going to be doing today is we're going to first, I'm going to give Vina an opportunity to come up, give sort of a 15-minute presentation, and then I'm going to give Aaron and Marcel an opportunity to present their own perspectives and some of the ethical challenges that they've met. We've come up with a set of questions that we think are really interesting, and we would love to hear across discipline how people have been thinking about them. And then the doors are open for you. And so what some of you at the Fawcett Center, some of you at University Hall, and other people on campus, if you have a question, it's going to magically appear on my computer. I don't know how this happens, but what you need to do to ask the question is to go to go.osu.edu/ask and start writing the questions. You could actually see what other questions people are asking and upvote them. And basically, you could ask those questions throughout the presentation, so don't wait until the end when something is really interesting and you want to write it down. Do it whenever it comes up. All right, so to no further ado, thanks so much for coming, and let's get Vina.
Thank you, Dana, and thank you to the university for bringing me here to be on this panel. I know I've met most of you already, but for everyone else who was not here yesterday and has not been at this conference, I'll just explain a little bit about why I'm here and what I've done in terms of research ethics. I'm a medical doctor and a researcher, and I have a independent ethics, a research consultancy that does research with humanitarian research, or in the humanitarian sector. And we basically are part of an independent ethics working group in Kuala Lumpur, and which provides, well, our aim is to increase capacity in existing IRBs in the universities there, but our ethics infrastructure in the humanitarian sector is quite poor, so we're trying to build that capacity within NGOs and within these IRBs. And in the meantime, we are offering ethics review for projects that don't have access to a university IRB. So projects like within NGOs or projects from the United Nations or other international bodies that may not have an IRB for them to access, we actually have a group of experts that are in the process of being trained to be reviewers, but are doing the reviews of proposals where otherwise there would be no IRB review. Sometimes we have researchers coming from overseas who the university, the international university, has waived the need for a local IRB. But we, in that area, we don't believe that international IRB can understand the context and understand the risks and the benefits when it applies to the vulnerable population in question. So that's what we do. So I'm just being asked to do an overview of, it's not coming down here, sorry. Just need to, okay. So I just want to talk a little bit, because the topic is humanitarian crisis, and what does this exactly mean? Like in this conference, we've heard from everything from the Ebola virus to protracted crisis to so many different things. And what does this actually mean? And even in terms of humanitarian health or humanitarian research, it is really difficult to define. So we've got acute versus protracted humanitarian crisis. Acute meaning earthquakes happened yesterday, how do we respond, what kind of research is needed, or the earthquake happened a year ago, and there are still consequences. It still is disaster or humanitarian research, and what is the difference there? The first one, we have time. Time is of the essence. If you need to react, we need to react now. We need our ERB review now, and things are very different, whereas with protracted humanitarian crises, we can think a little bit more about what we need to know, how we're going to do it, how we're going to do it safely. And it's a little bit, but maybe we can't get the right information that would help us if this emergency struck again. What about humanitarian situations outside the crisis, like prisoner conditions or people who are discriminated against? These are still considered humanitarian, but we don't really think about this when we are talking about a topic like this. Survivors of emergency situations are vulnerable populations which wherever on the timeline that might need special protection from exploitation, in which this topic, ethics, in the research that we are doing is especially important. So when you talk about evidence-based practice in humanitarian crisis, there's really a challenge of like developing guidelines in such a dynamic, diverse field. I've just talked about how these things range, how these crises range. How are we going to have one set of guidelines to talk about, you know, a multitude of different situations that could arise? It is a real, I mean, it's really a challenge. And I think we should do it. I just think that we need so many people involved to have a really good, and it will have to be quite broad, and people will have to be trained in them to do them. So, yeah. There's also a paucity of evidence to guide response in disaster settings already. These numbers are coming from 2005, and I really do hope in the last 14 years more information has come out. But 1% of published disaster research articles are about lower and middle income countries, and of that 1%, 80% are authored by researchers from high resource countries. I know there are a lot of efforts to change this and increase the capacity from people in LMIC, and the fact that I'm standing here is I hope that's a good symbol of that, and I hope this increases, and I hope it has changed, but these are the latest numbers I could find. So when we start thinking about challenges in ethics, we start from not just, I think a lot of, again, not everyone in the room, but a lot of people start thinking about ethics when they submit their ethics review proposal. And actually, it should start from choosing your question. The question in itself should in some way benefit the victims of the crisis, and the topic should be relevant and appropriate. It may really seem obvious, but I constantly get surprised at what topics come up and get presented to me in terms of like trying to support survivors who are in a protracted crisis. These 3 points that are up here have been taken from the Nursing Code of Emergency Response, but are really relevant to what we are talking about. Research should always be responsive to the needs of the victims of the emergency. Only research that does not hinder or obstruct effective and appropriate interventions should be carried out, and research should improve interventions and/or local capacity to respond to this emergency or future emergency. When we think about methods, we think about how are we going to access this population. Can we access this population safely, safe for us, safe for them? Who are our key persons and authorities? Are there any risks of choosing these people as our key persons and authorities? Do these key persons really represent the community and all the sub-communities within that, all the possible marginalized communities? How are we going to sample? How are we going to make sure the sample is good? How are we going to make sure we're not oversampling if research has been done in this community before? How are we making sure we're not sampling the same section of the community again and again if the same key persons are being used? And how are we going to ensure, especially in acute crisis situations, that we can maintain scientific rigor in our research? And at what point do we stop the study when we think it's not going to maintain that scientific rigor anymore? Ethics Review Board, there's a lot of discussion about pre-approval, which maybe Amit can talk about a little more after. Oh, it's not. Oh, no. Thank you. What's happening? No. Is it because I moved to this one? Oh, sorry. I don't have so. So many slides went by. Okay. All right. So there's been discussions about pre-approval of ERB, so that if you you want to study this and you know it's going to happen, or it's in a place that has happened before and you think it might happen again, or the disaster response has been prepared for that, then this is a good one to do a pre-approval of an ERB, so it's a lot swifter and smoother when disaster does strike and you need to go in. There are, of course, exemptions, especially if you are doing operational research and you're using, it's not research with human subjects, but of course that still needs to go to the ERB. I mean, the researcher can't decide that that's exempted. It needs to go to the ERB to exempt that. I think that's how it works here. It definitely works like that in Malaysia. In terms of respect for persons, we need to think about informed consent. Are the people who are subject to this crisis ready to be able to provide informed consent? Are they in the right state of mind? How can we do this? How do we want to do the process? What are the cultural and language barriers? How are we going to overcome it? What is the literacy level in the population? These are all potential challenges. There's also a power dynamic for foreigners that are going into a response thing where people feel there might be some authority, or especially if you're going in with like medical personnel or stuff like that, they're providing medical care, they may feel an obligation, they may feel that they cannot say no, or maybe you would cut off other services. And of course, trust and relationships are really important in this, and you must not abuse those relationships, and also fostering that trust is a delicate thing. In terms of non-maleficence, I think one of the most common things in crisis are triggers and mental health, especially in the work that I do in a protracted crisis. We can really try to minimize this by having a psychologist or a psychiatrist look at the questions to see if there's any way you can make the questions less triggering. We have found that really helps. Having all researchers and everyone on your research team trained in psychological first aid is also useful, or having a mental health pathway if this happens. Of course, if this is a high risk, I would reconsider doing the study at all. Possible consequences of results, for example, in conflict zones or in areas where the results might actually adversely affect the population. This needs to be thought about. Exploitation, if you're giving incentives, or if you are paying a key person to help you do the study, this might lead to exploitation. And of course, you must ensure that relief efforts and other delivery of care that might be going to these to the survivors are not hampered. Okay, so my whole talk yesterday was on beneficence, so I'm sorry for having to repeat myself, but it is something I feel really passionately about, because at the end of the day, while we also don't want to do harm, and that is really an important starting point, we must think that research in humanitarian crisis can only be justifiable if it really concretely contributes to the ending of that suffering. It has to be appropriate for the study population. There are lots of arguments about compensation versus incentive, where the incentive might lead to coercion. So getting the appropriate amount for compensation can be tricky and takes a lot of work that you might have had to do before disaster strikes, and might change once the crisis has happened. So this is stuff to think about. Implementation science is an important thing to think about, and I think it's growing in this sector, so that you can give at the same time services as well as collect data on how to improve those services. I've already mentioned this, but to make this beneficial to this community, you have to make your study have scientifically sound. And of course, have a data dissemination strategy. If your dream is to impact policy, that might take a little bit longer, but the easier way to do it is give the information back to the community or to the NGOs that are serving that area, and then you've already impacted in some way. I think I've mentioned this a little bit, so I won't spend much time, but make sure that participant selection is fair, the form of beneficence that you are providing is fair for everyone and fair for people who are not getting it, and make sure that the community leaders aren't selecting people out of favoritism or anything like that, which I think is one of the major challenges of doing this kind of work. Okay, so to end, start early and think of ethics from the research question to the data dissemination to the thoughts of impact of your study. Ensure that the basic needs of your study population are met before beginning. Submit for ethics review early. Collaborate with key persons from the community and make sure that they're representative of the community. And always assess for an appropriate compensation. Thank you.
So now we're going to have Erin Lynn talk about her experiences on the field in her research and how she's been thinking about some of these questions.
Great, thanks, Dana. So I'm a political scientist, and I study the legacy of war on development. I focus on the role of bombing and the fact that not all bombs detonate when they hit the ground. So I really study the unintentional detonation failures of bombs and how this has long-term unintended consequences for development, particularly in Southeast Asia, and I focus on undetonated bombs following the Vietnam War. So all of the research that I'm going to be talking about right now, it will be based in Cambodia. I rely both on quantitative and qualitative methods to address this topic. So quantitatively, I use declassified US Air Force records of payload drop points, and I merge them with farmer surveys from Cambodian farmers today to basically develop this theory and have this finding that where there's more unexploded ordnance, there tends to be more subsistence farming. But then I also use qualitative data where I basically go back to the field, back to Cambodia each summer, conduct farmer interviews, and do ethnographic observation of demining teams as they're clearing land. So for today's panel, I wanted to bring up two projects with their own ethical issues. The first one is a project that Dana had actually mentioned, which is the TDAI project, where we develop a machine learning model to find bomb craters on very high resolution satellite imagery. And the hope is that by identifying the bomb craters, we pair this with the declassified US Air Force records to get an estimate of where there are areas that are very dense with unexploded ordnance. And this will provide more information for demining teams to use to find, to be able to demine more contaminated areas. The second project is a project that's sponsored by the Food and Agricultural Discovery theme at Ohio State, and that's a soil contamination project. So what I actually did last summer with a team of 2 students from Ohio State is that we went to the field to shadow a couple of demining teams, and we would collect soil from areas where there have been unexploded ordnance, so within a meter, 3 meter, and 5 meters, we would see if the soil in these areas next to a bomb actually had any indicators of more heavy metals, more toxic residuals that could be coming out from these bombs. So this project brought up a few ethical issues, partially because these 2 questions of how are the best ways to locate unexploded ordnance, and then also do unexploded ordnance leach chemicals into the surrounding environment. These are what I consider frontier questions, and the way that a lot of research hasn't really looked at these particular questions. And so it really brings up this issue of what do we do ethically when we just have preliminary findings or we just have pilot data? I like to use the soil contamination project as an example because what our initial findings reveal is that where there are unexploded cluster bombs, within 1 meter of that bomb, you find about double the amount of lead and arsenic than you would 5 meters away where our control soil would be. The other research design that we also implemented was that we wanted to see if detonation practices were actually good for the environment. Because what happens, or the current standard, is that if a professional demining team finds an unexploded bomb, once they locate it and confirm that it is a bomb, they detonate it that day. So what we did is that we also tested soil from the detonation site and the areas surrounding the detonation site to see if there were heavy metals and explosive materials still in these areas. And we found that there's 4 to 5 times the order of magnitude of lead and arsenic in these detonated areas compared to control areas. The issue is that since this is a pilot project, we don't really have a large sample size. This basically motivates a larger, hopefully multi-million-dollar grant proposal in which we can increase the number of N to see if these are like actual conclusive results. We also need to run many more tests to see what the impact of having these heavy metals would be onto soil health and human health. So you need to run things like bioavailability tests and soil organic matter tests to see if the surrounding soil is actually absorbing any of this heavy metal material and the degree to which like plants and humans exposed to this material would actually be negatively harmed. So it's kind of dangerous to run around with these pilot findings, like potentially throwing up all these flags when we're not even sure how conclusive a lot of these results are. And we're working on an academic schedule where I have to wait a couple of years to write the proposals, see if I win the funding before we can actually scale up some of these projects. The other thing to consider is that the more time that we spend trying to work with the deminers to collect these soils, the less time they actually have to demine the areas that they're working in. So we try to be cognizant of taking as little time from them as possible while also trying to maximize the amount of information that we're drawing from the field. So the solution that we've come to right now, and I don't even know if this is the best solution, but we've basically, my co-PI and I have drafted a pilot report saying, like, you know, with these amounts of lead and arsenic in the surrounding soils, we would recommend farmers not to farm within 3 meters of a detonated bomb. But this is still up to many more tests, and we still need to confirm this result. But this is what we would share, this is what we are sharing with the NGO that we're working with that actively demines the area, with the idea that they're going to then use their community liaisons to share this information since they're already out in the community telling them about other safety regulations regarding unexploded ordnance. So that's the anecdote that I'll share, and I'm happy to talk more about the other project, the bomb crater identification project, and the hazards that come with that in the Q&A.
And Marcel?
My name is Marcel. Can you hear me? Yeah. My name is Marcel Yotebian, as you hear from the introduction. I'm originally from Cameroon. I work in a number, I'm a physician and a public health practitioner. I consider myself an implementation scientist. And Can you hear me? Mm-hmm. Okay, is it better now? Yeah. Mm-hmm. So what I will bring into this and bring it is actually the experience of healthcare provider and somebody who do research in those areas. And first of the thing I will ask is that you have to think about the context when we use the word humanitarian. We are already talking about in a context in which the power relationship is disturbed. Those who come in to do research are extremely powerful, have enough resources. Even if it's a small nurse or even if it's a small community health worker, they move from we just have a cyclone hit the southeastern Africa. Even the simple somebody from the neighboring village who is not officially a health, who walk in with potable water, have huge power because you need that water. You need it to survive. And it's very difficult to negotiate anything in this condition, let alone arguing whether you should have it or not. And really the example I want to bring here, I was part, I don't know if some of you have read the report, Crossing the Global Chasm, Improving Healthcare Worldwide, that the National Academy put out last September, October. I was part of that committee that put out that report, and I took actually the committee to travel to Central Africa, to Eastern Congo, and Rwanda to see actually offhand, and there is some ethical issue that we still have. We have referred to the National Academy Ethics Committee that is still have not. But when I bring that report in, I'm encouraging you to read it for one thing. It's unethical the way we practice humanitarian medicine now, because we don't have evidence whether what we do is actually helpful or not. If you read that report, you will see that we need research in this area. So actually, the ethical thing is that we need research in area. And my point would be, I was making this with Dina before, is that for the regulatory people that are on this, in this room, I understand you want to protect. I understand those people are vulnerable. But don't let the fear prevent the research to happen. And I'll give you one example. In DRC, last November, DRC approved the vaccination, the revaccination for those. It's compassionate. We don't have enough evidence if those vaccines are safe against Ebola. And they approved and excluded pregnant women. Pregnant women, from the experience we have in West Africa, is that they will die. If you're a pregnant woman and have breastfeeding, you have just signed your death certificate. You can just go and sign your death certificate. So we exclude them from those things by arguing it's not safe. Tell to me how do somebody come out with this conclusion, right? What is safe? This woman is going to die. It's almost certain. The only chance she may have, even though this may kill her before the Ebola kills her, is this vaccine. But we exclude her from receiving this vaccine because we believe we don't have data from it. And for many regulators, you know in this room more than I do, that it's only recently, only this couple of months, that we have removed pregnant women on the list of vulnerable. They were classified as mentally disabled, on the same list as mentally disabled. So this is to say that when we talk about vulnerability, about the risk, we have to assess the risk based on what actually the need is. The risk is not in a vacuum. The risk for somebody here in this room to be exposed to 5-level arsenic may be intolerable. But in some area, that risk may be actually much more than reasonable, because the opposite is worse than that. And we have to bring all of this. So these are the two things. I will not take a lot of time. I will encourage you to read that report and see that we actually have a full chapter on practicing care on those marginal areas, right? Which you can even classify informal care in multiple of those countries with chronic poverty, because that's also a humanitarian situation, which is what I actually very well used to. With those chronic poverty, we are practicing services there or doing research. We need research in those areas. And how do we do it, and how do we do it in a way that is ethical? And usually when we think about ethical, we only think about it in the way of protecting the patient. Also, the one who is doing research needs some protection as well. Within that committee, I mentioned to you that we went to Goma and that we have something still pending with the ethical committee. What we saw there is that patients are retained hostage after they arrive for receiving care because they don't have the means to pay. They are extremely poor. And you see children that stay in hospital up to 3 months, 6 months, growing in a hospital, which is actually very dangerous, right? This is not the cleanest places to be growing up. This is not even the places to think about growing up in it, or even to think about visiting, right? Hospital is not the cleanest place to go. If you don't have anything to do in hospital, don't go. As a clinician, I will tell you that. So it's not the safest place to be. But you have children that are being retained to grow in this because their mom cannot pay the bill of their delivery. And the question is, if you don't pay, if those people do not retain the patient, the ethical question on the other side, because we think about those patients and say they are being retained, if you don't pay the bill, the hospital will collapse and then not functioning. Whose ethical responsibility it is to maintain this hospital open? So these are just a few questions that I will have to raise. I'll stop there.
Well, thank you. So now we're going to go into this sort of, we have a few questions that we came up as a group, but please, if you have questions, go to go.osu.edu/ask and start typing up questions. So the first one, and it's already been touched upon by some of the speakers, but I just want sort of ground clearing. I think the most fundamental question is, why is research necessary in these humanitarian crises or these humanitarian crises, why not just provide the best possible and evidence-based interventions and aid that we can offer given the resources?
I can start directly from there because that's what I just end on. Because what is the best evidence base? Currently, we say the best evidence because we don't have evidence. Anything I do is best evidence based, right? Everything I show up and do on you there, if I operate you without anesthesia, that's the best possible we can do, right? They did that in the Napoleon army. That's how they developed the surgery and all the amputation. When they amputate soldier in Napoleon army, which saved a lot of life, it was very better than what was previously done. But they just cut your leg in the field, and it was very, it was actually improving the life. If we were in that condition, I would say that's very ethical because this is the best medicine you can have. But is that really ethical today? Is that really what the best we can afford today, even in those conditions? Even in an earthquake, that things are not coming in very quickly. Is that the best we can afford? So I think we need absolutely, there is very little evidence. And actually in your presentation, you were citing things from 2005. We are in 2020 roughly. Because the research that is submitted now will only be published next year. So we are already in 2020. Those research, if you were in the field of HIV that I spend a lot of time, that thing would be like crap, right? You cite something of 2005, it would be like crap, right? So it's just kind of the way we absolutely need research in this thing. I will encourage you to read the report I just mentioned to see how much we need the research in this area. We cannot just, we need to define what is the best we can offer in this area. Is the best contextual? Is the best because they are poor? Is the best because the access is not reachable, right? Is the best, when we look at the WHO definition of potable water, the WHO definition of potable water is the water you usually drink, right? It's a water you usually drink, which doesn't mean it's actually potable, right? If I find myself in the flooded Mississippi with in the flooded Central Eastern U.S. currently with water that we usually drink, that water may not be safe for you, right? The tap water may not be safe for you because it's been contaminated and the government is saying we cannot guarantee that water. So this is where what is best, and without research, we will never be able to develop the evidence, acceptable evidence, even for those locally, to be able to do that.
Thanks. I agree with that. So I think research obviously plays an important role in trying to figure out the best way to distribute aid, in the way that it's always helpful to have a third-party observer and someone who's probably a little bit more objective just tell you what general trends are. So I think of it analogous to like the role of a therapist in trying to help like you navigate your own life. Like we all try to make the best possible decisions that we can given these like environmental circumstances, but it's nice to have someone who can kind of observe what you're doing and tell you where you're kind of screwing things up and you might not recognize it. So I think like research can play the same role, and like the best possible relationship that you can have between a partner organization and a researcher is an honest one. And so one where like the organizations that I partner with basically give me free reign as much as possible to access all of their data, and they trust me that I'm going to try to give them the most kind of objective and thorough analysis of that, and we kind of see that we can help each other out in this very specific way.
I just want to add that, I mean, I obviously agree with the other panelists, but I think it's clear that we need research in humanitarian crises, but I think that publishing a paper does not always lead to action and change in the field, and I really think the researcher's role is changing to ensuring that your results and your evidence, if you've got some really good evidence, like making sure it goes back to the community that you studied or the population or the area that you studied, or something that's similar or that could apply to other similar crises or things. I do think that even if it's not, you don't have to do it yourself, like making sure that it gets done is going to really help in making sure there are evidence-based practices, because from the NGO world, it is really hard to find the time when you are often just reacting to things and you're just reacting to services, and it is so nice to hear people come and say, like, this is how you can do it better. Actually, what you're doing now, sometimes that's not that nice to hear, but it's still important to hear that what you're doing now is not that effective. There's a better way for you to do this. Even if NGOs don't like to hear that, they should hear it. And I really hope that we're going to change how NGOs and service providers and academics communicate the information and improve things in terms of evidence gathering.
So many of the issues that you're bringing up are present challenges in research ethics more broadly, and especially when it comes to research ethics that come from well-funded, high-resource countries in lower-resource countries. So I'm wondering if there is something distinctive about conducting research in humanitarian crises or post-crises, or is there some sort of, what is the qualitatively distinct or you think the most important ethical challenge that makes it a little bit more of a distinctive challenge in these contexts as opposed to the more general challenges that many researchers face?
We have talked already about the issue of imbalance of power. An imbalance of humanitarian setting is by definition a setting with imbalance of power. Those who have and those who do not have. Whatever you have is something somebody don't have. And even as a researcher, coming into it, you have enough more power because you have the time that she's talking about. You have the time on your side. You can be patient. You can be distanced from those things. You are not emotionally involved, which is also a matter of power. But the key ethical issue is the matter of consent. And usually when we talk about consent, it's usually that we have an informed consent. And the informed consent here is not just the patient. The example that I just give you in the Democratic Republic of Congo, where pregnant women were excluded from vaccine, did somebody ask their opinion? Did they consented to be excluded from this vaccine trial for their safety? Did we consulted them? And this could be true on many pregnant, there are many women in this room. This could be true on many, many medicine that we do exclude. If you are a practitioner in this room, you know that most of the things are labeled that we don't have enough. The label on most of the drug is that maybe you shouldn't use it in pregnant women because we don't have a lot of information on it. But we only know maybe about 4 or 5 drugs that are pure, that are really teratogenic. Why are therefore all pregnant women excluded from all the drugs that have no relationship to that? And that's also an issue of consent. The consent is not only when I present in front of you to ask you for a consent. The consent are decisions that were made out to exclude you to even have a chance to consent to this. And now when I present in front of you, I'm the one in position of power. You need to go to that clinic. The NGO is the one distributing water, distributing food ration, distributing all of those things. And they ask you to sign a paper to also give you a name, like we came here, we have to sign a paper to agree to put our whatever is our voice out there. And everything was dependent on that. If we didn't sign it, maybe we wouldn't be sitting here. Did we really, our consent was it really informed? So these are the questions, and in those conditions that the imbalance of power is such that I cannot just turn around and go somewhere else. How do we ensure that? So I think that's the thing I see as critical, because we have an imbalance of power. We have people who make decisions before they arrive to the setting, what they bring to the setting, before consulting us, and it's very difficult to handle all of those.
Yeah, I think one of the things that might distinguish research in humanitarian crises compared to other types of social scientific research is just the timeline. So we usually, when we think of a crisis, there's like this immediate need for something that has to be addressed. And I might fall on like the other end of that spectrum since I study bombs that have been sitting in soil for about 50 or 60 years. And so I think plenty funders just think, well, it's another 5 years. But then I always like to make the argument that like this research is necessary in the way that it also helps us understand unexploded ordnance in like contemporary contexts. So like by us understanding the degree to chemical leaching or how to better locate cluster bombs in Laos, Vietnam, and Cambodia, this will actually help us understand exactly where we might need to bring in aid missions in areas of Yemen that the Saudis have bombed using American weapons, right? So that being said, though, I think there are all of these ethical concerns concerning how you can make sure you conduct research in an ethical way when you're in a crunched time horizon, as it's just people make decisions very quickly and you want to make sure that the aid gets efficiently distributed. And I don't have the answer to those questions since that's, I guess I haven't thought about them as much since I study kind of the long time horizon.
I mean, it's all difficult, but I think it's all difficult because in the humanitarian research area, I mean, whether it's crisis or other reasons, like basically we're working with vulnerable populations, and the difficulty with that is when you're on an ethics review board and you receive training for it, you do your prisoners and your children's and all these other special populations that might need added ethical consideration, but you don't have that for disasters or humanitarian sectors and vulnerable populations that have unique needs. Whereas when you're in a non-humanitarian thing, you think, okay, the ethical principles are quite simple. Autonomy, like I'll just tell this person everything, and then they make that choice, and suddenly I'm a bit more unburdened with my need to make sure this is fair because you and I, we have the same understanding of things, and it's a little different. Whereas you go into a humanitarian sector, the culture is different, the language is different. You have so many things to navigate. The chance of you making a mistake is quite high. I think this is, I mean, it doesn't really answer your question, but it just makes the whole ethical thing not just 4 principles. It's 4 principles that are overlapping and added onto and really, really quite complex. And I think that makes it difficult.
So Marcel's already brought up a case of a population that should be a research subject that is not, but I'm wondering if sort of the reciprocal is the case. So are there conditions or certain populations where research is not appropriate and the priority should be solely on providing aid? You could think about that in more abstract terms, but I'm also very interested if you've ever come across in your research a situation in which your role as researcher felt inappropriate, and what were the risks of providing aid while doing research, and how could we avoid those risks?
I think that if your study is not appropriate or like extra research is not appropriate, you can think about looking at what service delivery is there and assisting whoever is providing that service with a way to do operational research so that you're not taking extra from the community or not adding onto it when it's not appropriate. For example, if basic needs are not met and people don't have, shelter, food, health, access to health, then maybe research is not appropriate. But if you make it operational and you just make sure that people are collecting the right data so that we know how to improve it. I'm not saying like you trick people into doing research, but if you de-anonymize it and it's not actually taking away from human subjects, that will make it much more acceptable than saying, oh, here's some food, can I do a survey and take 15 minutes of your time while you're traumatized and while you're suffering. If you just focus on the operations and think about how to improve that, then I think that works. I do have an example of newly arrived Rohingya refugees coming to Malaysia. They've been on boats for 24 hours, been through possible torture, possible sexual assault, and I think I mentioned the case yesterday, and people wanting to do HIV screening for this population, just focused on HIV and the prevalence of HIV among Rohingya refugees in Malaysia was, their title. And I was saying that we actually stopped the study and said, if you want to do anything, you can do a comprehensive response to, people who are survivors of sexual violence, or you can do that, but you can't just do surveys to see if they've got HIV or not. And so that was quite a difficult study to stop because it was an international study, but we did it, and it was definitely the appropriate thing to do.
Question by say, she used to keyword operational research, which is also what we call implementation science. And from there, I would say there is clearly not a situation that research cannot be done. Are there research that cannot be done in certain situations? Yes, she just gave an example, right? That research was not benefiting directly those people who arrive. It may benefit them on the long term, but their immediate need is not to know whether they are going to die 5 years from now of HIV or something. They just need water and some rest and get mental support. So this is where there is, for me, if you are providing any services, you have the opportunity to evaluate whether that service could be provided in a different way and a better way, or could benefit the population you are servicing in a different way and a better way. And that's what she's calling operational research, or what I'm calling implementation science research, right? It's exactly once you meet those people, even your interaction, even if you are not providing any services, just your interaction with them, you will want to be able to say, is my interaction with you here actually beneficial to you, or is only beneficial to me? Is there a way I can make it more beneficial to you? And when you ask those questions, they are research questions, because if I have those answers to those questions, I don't need any data, right? So this is, my answer to that is that never think that there is a situation that you cannot do research. Every single thing can be improved. And if you can improve it, you need data and evidence to improve it. And that data, you can call it whatever, operational research, implementation science, it's research. Let us not get lost in word. The question is is a research that is more appropriate in certain contexts or in other? Definitely, right? Definitely. Certain research will benefit certain population than other. And even within a given population, if certain research can wait, as you were talking about the bomb, if those people in the area actually, they may be benefiting much more now for that, but maybe in Yemen, you just mentioned, the research going there and see whether the bomb explodes, whether the soil is contaminated may not be much more appropriate now that the bombs are still falling, right? Maybe you should wait a little bit to see whether that is. So.
I have a slightly different, I guess, take on one of the questions, which is how many or how often do I encounter situations in which I felt my role as a researcher was inappropriate? And I feel this way all the time. So when I conduct a lot of interviews, most of my interview subjects will always ask for like money or resources, personal pleas for help. And there's certainly, I think, an understanding that like we're either like very, very closely tied to like the organization that is in charge of making decisions of who should be receiving demining services first, or like, we're just tied to money that we can easily hand out. And as a social scientist, that's really difficult because then you're getting biased results where people might be inflating the degree of need because they think it'll increase their likelihood of getting that service. And what's really interesting was that I was able to kind of compare what my interview findings or my interview responses were like when I did interviews before I had a soil contamination project compared to after a soil contamination project, because when we're out there collecting soils, that looks like, that's like I didn't need to fill out an IRB for the soil collection part. I can just take the soils with permission from these various fields in Cambodia. And so like farmers are typically just like curious after we get permission, and then we'll just like hang out with the farmer, and I have to like do a little bit of a cataloging of how that land is being used and whether or not there's fertilizer associated with that land. And like then like we'll just launch into these very natural conversations of what their like everyday livelihoods are like, the degree to which they feel like poor or like are a subsistence farmer. And that's a very different conversation than these more structured interviews that I also do that are absent the soil testing. Yeah.
So I'm going to ask one more question from the structured conversation. There's a ton of questions from the audience, so I want to get to those as well. So this is just one final question that we haven't touched upon. Well, the timeliness has been brought up as a challenge or as a distinctive challenge. And one issue, especially with humanitarian aid after natural disasters, but you could also think about it with man-made conflicts, is, you know, some of this research is being conducted in a very short period of time after very unpredictable events. So how can you plan and sort of ethically have the foresight to think about engaging in research given the unpredictable nature of some of these crises?
It's crisis by crisis, right? Because some crises, although we cannot predict exactly where it will happen, we know it will happen. Ebola example that I just used is one example. It was in West Africa, 2013, 2016. Now it's back in Congo. It will be tomorrow somewhere, right? So we can, and the trials that are going around that Ebola crisis now in Congo were started in Guinea and Liberia. Those vaccine and treatment that are being used, they started doing it in Guinea and Liberia, and now taking advantage of this opportunity to expand it. So for some crisis or the next flooding, there will be a next flooding somewhere, or the next drought, it will be somewhere, something. There are things that are uniquely rare, and that probably you can really, the bomb, there will be a bomb somewhere tomorrow, right? We don't know where the next war will be, but there will be a war. There will be a war sometime soon. It's in Gaza yesterday. It started in Gaza yesterday. So there is always those humanitarian. It's unpredictable where they will happen, but they are not so unpredictable. And if you look at being a physician and doing infectious disease, if you look at the leaks as the next pandemic, the WHO come out with this X disease that is going to be emerging, which is the X disease we don't know yet, right? Because there are some new disease that always emerge, and you know, we have Zika recently, we have SARS, this is going to emerge very soon. But currently, there is a lot of preparation. The World Bank have a meeting, have a commission in 2016. They issued their report in 2017, and they are preparing. They are investing currently to actually prepare for that X disease that is coming. So we are investing already in research capacity and planning those research for that X disease that is coming, and we know it's going to come somewhere. So all of those things is just to really think about what are similarity, what are we trying to anticipate, what are questions whatever that catastrophe, whatever that humanitarian situation will be, that we will have to answer that we don't have answer now. Or if we have the answer, it will be helpful. So it's just been a good researcher and anticipating what the things will be, what is the limitation on the current policy, what is not working well, and how can we better use the next opportunity we have to optimize on those things.
Yeah, I think about ways to limit risk for my research participants all the time. So since I work in minefields, like I don't want to go and ask a farmer to take me to their minefield and like show me where they think mines are, even though like that's information that I want. And instead, like, you know, approved by the IRB, we then like, you know, we'll have a drone image of their land, and then we'll say like, will you kind of mark out areas that you think are dangerous and areas where you think aren't, and areas that you farmed in various ways. And so that's, I think that's one example a way that we're trying to limit risk to research participants. The other thing is that when I mentioned the soil contamination project before, that's actually always done by shadowing a professional demining team. So it's not like we go out to a farmer where their land is contaminated with unexploded ordnance and then we're like, hey, well, you take this plastic bag and fill it up with dirt next to where you think a bomb is. We only do this where there's been an area that's already being professionally cleared, and whenever a deminer finds a bomb, we'll just take the dirt that's around it and then use it for composite sampling. So I think there are ways to devise strategies to make, to do good research while also creating a maximally safe environment, conditional on the fact that I work on a minefield.
So I'm going to now go to the questions that the audience have asked. So in some ways, this is related to the previous comment that Marcel made about how, it's unpredictable where it's going to be, but it's not unpredictable that these crises are going to happen. And this seems to be put in tension with this push to have community involvement, especially at the outset of research. And if the sort of researcher is poised to go wherever, then you see that it's hard to have community input. So the first question that an audience member has asked is, can you discuss examples of how the local communities, or if the local communities you work with, participate or not in setting the research agendas or priorities for your questions?
Everyone is looking at me, and I will say, it depends. It depends. If we are talking about time, I can give, for example, I can go back to the example of Ebola vaccine and Ebola treatment. One could say, we decide in Liberia and Guinea that we are going to test those vaccines in the next epidemic, and that we are testing it now in Eastern Congo, and that the local Eastern Congo did not give the thing. But I just told you that the government of Congo approved those tests and eliminated the pregnant women. The local government of Congo is the local community, right? So because somebody needs to speak for the community. Obviously, in that area, you can see that we are not controlling because we lack the trust, because the government is also not very well involved locally. But that's another story. So it's important to think about what we call community. Because when we call about local community, people think like if somebody come at OSU and have to do something in this room, they absolutely need to come in this room before and talk to us and get all our permission, which is not true, right? Usually they will go and see Dr. Drake, and Dr. Drake will say yes and maybe send us an email, and we may read it or not read it. And then usually we know how we read those emails, right? And usually when the person show up here and say, yeah, but we were informed 3 months ago I was coming today. You say, really? Say, yes, we send you 3 other emails to remind you about those things and so on. And you say, really? Maybe that's true. And even this morning you responded to one of those emails and you say, really? So that's what I'm just saying to say that community engagement, we are all community, right? And therefore, coming into this room, talking to Dr. Drake, it's relatively talking to this community, because we assume Dr. Drake is looking for what is best interest to us, even though Dr. Drake did not come to this room exactly at the moment he was talking. So I think we need to be really flexible in the way we define community. WHO participating, CDC participating in those definition in Liberia and Guinea of what we were going to test next time, we can say these are community that were participating, because their job in it was to look at what is best for the next community that hit, not what is going to make them money, because they will not make any money, whatever way this go from those things, right? So I think this is where we really need to think about the community more broadly, and rather than just exactly talking to the individual that is involved.
I I'm trying to understand whether I'm local community or the other communities. I'm not really sure how to answer this, but I would probably say no, even if I am local community. I think from being from an LMIC, I find a lot of researchers coming already having decided their topic and already decided their agenda with not much participation from the community, whether it's local Malaysians or whether it's refugees or an HIV-affected community or whatever it is. I do think that participatory action research is getting more interesting and getting more, people are getting more engaged in that, and I think that's great. In our acute disaster response with flood response and things like that, I don't see much engagement in the communities, and it is very government driven. But right now the response is quite good, so I think maybe they aren't so active in their research in that area. But in terms of refugee research, there's a lot more refugee representation, so I can see that that's definitely growing. But I can't speak to other places in the region.
Yeah, I don't know. I mean, from my personal experience, my own research agenda started from a laptop computer. So I was just like running some regressions on various types of data sets, and I like found this trend that I just couldn't explain. And then I like went and read about unexploded ordnance, went to Cambodia, which I had been going to for years already, and then just started talking to people and then realizing there's a topic there. So to me, I think it's very useful if you can float between the worlds of like academia and the hollowed halls and then like go back to the field. It's like, it's the most valuable thing is being able to go back and forth, I think, and just crossing those boundaries. And that's where you're always going to be the most impactful researcher.
So can you give an example of an appropriate research question that was in the midst of a humanitarian crisis, even in situations where some of the basic needs such as water, food, or shelter are limited? And they're like, so when is the appropriate sort of waiting period from providing the aid and sort of the first response and sort of moving towards starting to gather evidence and starting to conduct in explicit research projects?
I mean, I don't think anyone can give a time frame. I do think that when basic needs are met, then we can start thinking about it, but I've never heard of an appropriate research question if it's not within the operational research or implementation thing. When people's basic needs are not met, I don't think there's an appropriate thing. In terms of time, I think you need to be on the ground. You need to be assessing from there, like how are people, are they still traumatized? Have they had access, even if not to basic needs, like to health and mental health and things like that? I really can't answer that question.
My add on it will be just that it depends on the question and how the question benefit at a given time to the local population. Because if the research question is how do I better meet and rapidly meet the need of those people who are rapidly in need, then that question should be quickly executed, right? If it's how do I provide potable water in the new island that was created in Zimbabwe, Mozambique, how do I quickly do that? Then that question should be, you will be doing it on an operational basis, right? You don't need, because there is very difficult to randomize there. You're doing it on the operational basis. You implement those ideas as long as you go and then collect the data and do it. So it really depends on the question. What I say, I will go back to your example and say, as the bombs are falling, you cannot be on the ground picking the land to go test them, even though this may be. So you have to wait at least for everything to settle, for the peace agreement, before you go do that type of research. So everything depends on the research question itself, and how that benefit the present situation, relative to the present situation.
So as a researcher, I mean, there's stuff that you can do while you're in the field, and then there's stuff that you can do when you're not in the field. And so there might be like an ongoing crisis, but you're still somehow able to collect data from like remote sensing sources, or just like work with the partner organization that's like actively distributing the aid to make sure that there is information and like there is a sense of like data being collected about like how much aid is being distributed where, right? And like once it's like safe for you and your participants then to do some like post-op research, like then you can always go in and do interviews and surveys. But I think it's just important. I mean, I think there might be like there's not necessarily for me a distinction in like time periods of like when you're when you're allowed to collect data, especially if you can think of like more I guess creative ways where you don't have to be in field necessarily to do that.
So this next question is about the relevance of the research question. So do you think that research in humanitarian crises should be relevant to other more stable settings? Or is it actually really important for the research findings to have some, like to be specific and focused on the crisis itself?
Yeah, I think definitely needs to be relevant to that specific crisis, because then why don't you go do your research on the more stable settings where people are not so vulnerable, and because that sounds like almost exploitation to me. Like, oh, here's a place where I can easily access because everyone's going there, and I want to go and do this. And if there's a more stable setting, always go to the more stable setting because there's just so much more at risk. So yeah, definitely.
Yeah, I don't know. I don't know if people perceive Cambodia as one of the more stable settings, because I guess I kind of perceive my research area as an area that can kind of be considered as a humanitarian crisis that a lot of people don't think about anymore because it's so far away from war and bombing. And so I think some people might label it as crisis or non-crisis, while I'm trying to provide evidence that there's still a lot of damage going on in the long term that we should be thinking about.
I think those who are in IRB or bioETCs can answer this question better, because I think when you really look at it, if the research can be, this is considered vulnerable population. If you could do this research in a population that is not so vulnerable, who can actually consent freely, why not probably direct the study towards people who can consent freely, even if this is not getting in the way of providing them humanitarian help. It's just the notion of autonomy in this setting where the imbalance of power is so great. It's just that it lends itself to exploitation to very easily. And this is much more a question for people who actually review IRB for the safeguard and so on, to be actually paying attention, because as a researcher, usually we tend to be to dismiss all those relative red flag, you could call them, before on the time. So if they could be, if the vaccine that we are talking about in Eastern Congo could be safely given to other people who could be exposed to something else, to some antigen to get that data, why going in that situation and trying to do it there? Because first of all, it's very expensive to do things in those conditions, and then it doesn't, and you may not necessarily get the best data you could get somewhere else if things were safe, because you are yourself not feeling very safe, so you don't go there and supervise as much as you could have done if you were in other conditions.
So since research relies on evidence gathering and objectivity, how can a researcher also be an advocate for the study participants? Is there an ethical imperative to be a researcher and advocate on their behalf?
This is my favorite topic, so I'll go first. I absolutely think that in humanitarian research you have a duty to advocate, or at least assign someone to advocate. Because I know that not everyone is a natural advocate or activist, but I think it is you do have that duty and obligation to do that. And also, if your data that you've gotten is going to harm, I think you also have an obligation to make sure that doesn't get out and harm your participants. So there's so much responsibility with the data you collect. And I think informing the people that need to be informed so that service can be provided. I mean, that's the whole reason we do research. I really cannot understand why people would want to do research that doesn't have an impact on the population you're studying. I can't even fathom it. So yeah, definitely, I think it is absolutely a responsibility. And I think it should grow to become something that's normal. rather than something that means that you're a really good person or a good activist. It's just part of the responsibility. I don't work in academic institutions, so I don't know how exactly that can be made normal, but I definitely think it should be. And I think more engagement with the non-governmental sector is also really key to that.
So I see my role as a researcher as someone who shines light on a topic that other people might not have thought about before and can provide a little bit more detail and nuance onto some just important phenomenon that impact a lot of people in the world. And so I guess I see my role as an advocate as like someone who almost speaks publicly to many different types of audiences and communicates about just some of my general findings. And kind of just shares the information with other people. So it's interesting because like when I actually do my fieldwork in Cambodia and I have all these one-on-one interviews, I feel like I'm letting people down a lot because they're asking for aid or for help that I cannot personally give them. But then like being able to then like do some hopefully quality research and then talk to various people from all over the place. And so I try to make it a point to present this research anywhere from like DC to demining headquarters in bases in Cambodia to like community colleges. So people just get a sense of what this topic is and get a little bit more engaged with it.
I agree with everything that I was saying, but I will be cautious because as a researcher, if we become advocate, we may promote our result to the expense of the natural doubt that have to come with it. We need to be humble. And as an advocate, there is not a lot of space for being humble. You need to be there, passionate, and saying this is it and it should be this way. And as a researcher, we need to be extremely humble because what people do not take the nuance we write in our discussion. People don't read those sections. Only people like you read those sections and read the nuance on the thing. You say all the long list of limitations you list on your research and say how this needs to be. Nobody read that unless they are in academia like you. So, and therefore we need to be really humble. And my point is that, yes, I agree that people do not get in those settings just because they wanted to make few people may want to make a name. But generally in the health sector, people get into it because they want to make a change. They want to impact other people's lives. So it's natural advocate. But here I will be advocating that we need to be humble because we are in an area where things change fast when we do not always have enough evidence. And we don't want the loudest person to be the one who defines the norm.
I think, sorry, I just want to respond to that. No, I just think that's a really good point because activists in general are extremely passionate and take things, and that's exactly why researchers need to be activists, so they can be nuanced and they can tell the truth and tell things with research backing things up. And not to say that all activists are like that. I'm also an activist. I'm not like that. But this is why I think like we all need to do all the things because we need to make sure people. So even if you're a researcher and you don't want to do all that advocate and you publish a paper, like just make sure somebody's read that paper and has taken the right things from it rather than just the headline. I think even just a data dissemination seminar or anything with key people, even that is really great and will get your research to somewhere. So yeah, I think that. Yeah.
And I just want to answer that, and that my own practice is that when I go somewhere and do research, preliminary result is always presented before I represent at the local community because they have the insight of what is going on better than I do. You show up few days just because you have money and power and recruited few people and they do whatever they do and give it to you and you think like you know what was going on. That's not true, right? I usually have a ceremony in all my budget. I usually prevent that and discuss, and we discuss. And usually it takes a lot of time before I even submit it to anything that goes. It's usually very preliminary data because you have the preliminary data that I know will hold. But they don't need all the detail in because the limitation, they don't really spend a lot of time thinking about it. And then you go and discuss with them. And if you can give to them and say, really, I believe in this thing, I think this thing, they can take over from you and really be, really why you are the voice of the reason and say, let us not change everything just based on this.
So unfortunately, we have time for one more question, but this is a fascinating one. So what is the ethical obligation of researchers who are already on the ground when a crisis occurs within the context of an ongoing study? Must they stop their work and put their and then put their knowledge and resources in understanding the crisis and thinking about an effective intervention?
It's always depend. Because you may stop a research that could have prevented the next crisis, and that will not be wise, right? That will not be wise. Mm-hmm. The question as a researcher, usually I say to, there is I'm coming from the College of Public Health, and this Sunday we were celebrating one of the founder of our college. And everything, what I hear there is that he said to his physician, the emergency department was being created and was under his department. And he told the chair then that if you don't do research, you are just a dispensary, right? The question is that there is a role for a dispensary and there is a role for a researcher in any single situation. As she mentioned, even in that crisis moment, we need to be collecting data. We need to be collecting data. And if you consider collecting data as a research, that means we need to consider research. Could the resources be mobilized from your question you were doing to answer other bases? If you read the report from the World Bank Commission that I just mentioned, their recommendation is to develop clinical capacity in low-income setting. And that World Bank should invest in those clinical, because it can always be mobilized to respond to those crises. Mm-hmm. So, and what I say it depends, therefore it depends on the importance of the crisis and how that will impact going forward. Mm-hmm.
I'm trying to think of how this question might relate to when I conducted fieldwork for my dissertation. And when I was out conducting interviews, I remember I had taken a holiday in Phnom Penh for a water festival, and there's everyone from the countryside comes into the city to observe just like boat races and stuff. And there was like a huge stampede where about a dozen people were injured and a few more died. And I don't know if that qualifies as like a humanitarian crisis, but it was certainly a dangerous event that could be researched. And I think in that case, even though I knew the country well and knew Khmer, like that was not a topic that I researched, because I'm not like a social movement specialist, and that's I can only bring limited skills to that particular setting, even though I like could have written like an ethnographic study, I suppose, of what it was like to be in the city at that time period.
I think that it really depends what your study is and what the crisis is. So if you or your research team are at risk, then yes, stop. If you're getting in the way of service delivery, if you're getting in the way of anything, stop. Just don't get in the way. Also, yes, you could take that time to understand the crisis, but don't try to rush and do a study just because you're there. I think that would not be ideal, but you know, observational stuff is really important, and there's nothing like knowing a crisis than being there. Like, then you will know. Then you could possibly do one for the next time, or do a post, do something, you know, after the crisis. So definitely, but yeah, don't get in the way.
All right. Well, with that, let's thank the panelists. Thank you so much for your excellent questions, and look forward to seeing you next month.
Thank you very much, Dana and the panelists. Let's take 10 minutes to transition over to the next session. Yeah, they have. Great, thanks. Yeah, I did this morning. You donated to do, in what way? Okay. Okay. Okay.
So we're trying to group some people together, so it's not just
right.
Okay.
Okay. What happens with the mouse?
It's on the other screen, which is over here. So if you just go to the left, it'll eventually pop up.
Okay. Thanks. Does this look like yours?
Maybe this guy to the top.
Oh my God.
Sorry. Yeah, that's it.
Okay. I'll just... Okay. You.
Okay.
Okay. Yep. Is this the same as the one you sent, or have you
No,
changed?
the one I sent was.
Okay.
So double click on Ohio.
This.
Ohio.
Oh.
Yeah. So this one.
A lot of them were part of the Khmer Rouge, and I remember one. She gave me a tour because she was like, "Oh, well, I was the one who laid the mine, so I'll know exactly where they are." And then, like in these villages too, like now that you think about like.
Okay. Thank you.
Chapters that but a lot of
That's Mark McCann. That's the guy he was here this morning. I told everybody he was coming for the coffee break. Haley has nothing to do with that.
Okay. Haley was going to do taxis at 5, but she left.
Right. Well, that's.
And I told her, I said, I can't stay past 5 tonight. And
Okay.
she said, well.
She said she was busy with
Yeah, the other person that she works for, I guess, gave her some other stuff that she needed to get done.
They're trying to gather as much taxi times as they can.
Yeah.
But I don't know.
I think what we'll say is that people, well, I said it to them this morning as well, that at the break this afternoon, that's your last chance to get any help with a taxi.
Billy just had them writing their name on a sheet.
Yeah.
And so we added flight time, so we knew what time they needed to depart.
Right.
Some of them have to leave by 4:30 to get their 6:30 flight.
Yeah.
So if you could just let people know if you signed up this morning and you did not put your time that you need to
Right.
depart.
And then say if you're not going to have someone here after the wrap up, we should at least have the taxi phone number so that they can
I'll
confirm
be
if
here.
there's no
I
taxi.
talked to Chad. I'll be here. He's going to get somebody to watch the schedule.
She's just getting a lot of questions about the travel scholarship.
Yeah,
I saw Mark here, but I didn't talk to him because I didn't know him. But Tim's like, oh yeah.
Okay.
It's going well.
No,
Right.
Kim
Okay.
said, no, Mark was here earlier, and I said, oh, okay. I don't know who he is, and so now they're all asking me if they had their travel scholarship.
Yeah, no, Mark was here, and they all knew he was going to be here for 30 minutes. They've actually, they've all completed everything they need to do.
Oh, okay. So they don't
so
get anything from him? They don't need to get any? Because I had this lady here was asking me, and then this gentleman over here that's standing right over here was asking me.
Okay. Okay, Barbara is up here. I can't remember who's the last. There's a third person. I can't remember whether I have one. I guess I don't have it here. I gotta go take it off my laptop.
It's like a modern day version of the trolley.
And which is the next PowerPoint?
It's this one.
All right.
Also, it's the time of year. I was talking to that bartender yesterday saying how he thinks you can walk over there during drag season because there's going to be like a crust of hard earth that'll push you, and you should never walk in this area during drag season. He's like very specific. Fascinating the way that children oftentimes will play actively with like booster bombs, and even though like I'm told that
So that's the third one, day two. The second one is Barbara.
I wonder like
put those in order.
Because like then you talk to kids who are like, oh yeah, my friend exploded like 5 years ago, and I saw the test.
Thank you.
Like, why do you keep playing with bombs then? I should probably move because I am. Yeah, it was really nice to meet you.
I'm sorry,
Hi. Yes, I have gotten emails from you.
Right, but I'll see you tonight.
At the dinner. Yes, I am. All right. Nice to meet
So
you.
not even. So
Oh, no
what time?
worries. We'll do it at dinner.
I need to. So I need to just install my. But maybe
I
afterwards.
didn't want to interrupt you.
I don't have to leave till about 6:30, so we have a little time after. Or what do you, this is my. Do I,
Okay, yeah, let's.
Sorry,
well,
I mean,
I'll
impose
put
on
it
you.
on my laptop first. Is it?
Okay, welcome back, everyone. I hope you had a good stretch of your legs, a nice cup of tea and coffee, and enjoyed your lunch. We have a very fascinating lineup for the next session, which is all tailored around communities in crisis. So I would like to invite Ike Valentin-Yoki from Michigan State University here in the US, and he's going to talk about ethics of conducting research in crisis settings. And this is an example from here, actually. How does Flint measure up? Thank you very much. A warm applause for him. If you want to stand up, please.
Okay, thank you very much. Thank you very much for this opportunity. Just a little bit of background for myself. I have a background in international relations and journalism, communications, health, research, and bioethics. So that tells you that I'm not an expert in humanitarian research, but I work at a location where humanitarian research is happening. So when I got the information about this conference going on, I belong to a mailing list, and the information came by, and I said, oh, I'm not an expert, but I'm seeing something that, that people in this field might be interested in knowing. So I put in an abstract, and luckily they said, okay, come over and then share something with us, and that is why I'm here. So thank you very much for giving me that opportunity. So my mission, actually, in this presentation is to use the water crisis, the poisoning of the water in Flint City, Michigan, and keeping in mind that Flint City is in the U.S. is most world's richest and most powerful nation. I want to use the situation there as an analogous situation to any humanitarian and emergency situation anywhere. So, so if I say things that are repetitive or something that are obvious, just keep in mind that I'm using that to prepare the ground for the argument that I'm making. So I asked myself, what do most crisis environments have in common? These are quite obvious. Excuse me. So fear, loss of life and property and all that, uncertainty, acute insecurity, widespread illness. Examples include cholera and PTSD and all that. So, and a lot of this characterize the life in Flint, believe it or not. So I ask also the question, does it really matter where the crisis is taking place? So, and I have some pictures here that you might recognize. Or maybe if you do not recognize any of these, some labels might help. So, these are just examples. And I throw in here gun violence. I put in the issue of gun violence because in my research, trying to prepare for this, it came up quite a bit. And the purpose of that was that post-traumatic stress disorder, PTSD, which a lot of us know, and associate with soldiers returning from war front. But actually, this kind of condition is far more pervasive in U.S. inner city people, particularly kids. In fact, I raised this issue with, during the poster session yesterday with a couple of people. My colleague from Sweden, when she was talking about emergency responders and their experience coming back and how they felt, really overwhelmed and had all kinds of conditions. I also mentioned this to one other poster presenter, Alana Monson, when she was talking about the effect on crisis, the effect of crisis on children. So there's a lot of research in this area, but more on that for another day. So I come back to Flint, and to make people who are not aware that at the height of the problem in Flint City, Flint actually had 2 locations where they quartered internally displaced people, refugees. And these are just sample pictures of how it looked. I was actually there because that was when I was part of a tour group, recently employed faculty people in the Flint area, and we were taken around the city to see places. So this was one of the places that we were taken to, one of the parks. So the tents that you see here were tents that people owned that they used ordinarily to go on vacations to parks, but it became very handy for them to use in a situation such as this. These people that you see here, other pictures didn't show a lot of faces, but these were only the group that actually allowed us to take their pictures for, yeah. So, but today, the refugee camps no longer exist because the city government felt that it wasn't projecting the image of the city well. So after about a year and a half, they were chased out. So many of them now are homeless under bridges and a number of other places. So back to the question, does it really matter where the crisis is? I don't think it is a question that we need to spend a lot of time on because it's not difficult to answer. So whether we are considering refugees fleeing across the border or internally displaced refugees at any place or migrants from one place to the other, I mean, the basic thing is that people everywhere in the world respond to the same situation in emergencies because we are people. The underlying thing is that we have blood flowing in all of us. So the question, is it really true that it's happening there and not happening here? Of course not, as I've just demonstrated with the little information that I've provided you so far. So it really belies the fact that issues confronting researchers across both low and high-income countries are the same. There's no question about it. So researchers in all conflict-affected areas tell similar stories, just as we have heard from a lot of you. And I'm trying to corroborate that with what I'm presenting now. So Flint, where is Flint? I know this is largely composed of our international audience, but also some American audience or other people who might have been hearing the news in no long distance time might have been hearing about this because it had been an explosive issue. It's a very small city of covering about 34 square miles. And this also has some little facts about Flint. It's made up of a minority-majority city, deeply economically distressed, and it is one of the most violent cities in America today. You can look that up. And it has zip codes with average life expectancy of under 65. There are lots and lots of studies that show that people living in Flint, people who have been living in Flint, suffer all kinds of deficiencies in terms of food supply, all that. But kids actually are at the bottom of it. It is said that kids in the Flint zip code have decreased 15 years or more of life expectancy due to all the kinds of things that they suffer and that they have been suffering way before the water crisis, okay? And now I've been talking about the water crisis. What is the water crisis about? It is important to know that the immediate past governor of Michigan, he was there actually for 2 tenures, but when he was campaigning to become governor, by the way, his background was accountancy, he's a businessman. He campaigned on the ground that he was going to run the state like a business. And actually, when he won, he actually did that. One of the ways that he showed that that he actually meant to run the state like a business was that he appointed emergency managers in a number of cities. So you would go to maybe, of course, Detroit was one of them. Parts of Grand Rapids were one of them, well, part of it. But Flint, for example, was also, so the elected mayors, elected councilors, they were just put outside, and then emergency managers were appointed in their place. So emergency managers were charged with protecting the welfare of citizens with a focus on fiscal belt tightening and with no consideration for health risks to residents, okay? So so drilling down to what this actually meant to the day-to-day lives of people was that they took decisions that resulted in the damage of public health from elevated lead levels and all kinds of diseases, okay? In practical terms, how they did it was, well, how the emergency manager did it was to change the water supply from what it used to be. It used to come from Lake Huron through Detroit water source to Flint. Before that, they used to draw water from Flint River. But Flint River had a lot of problems. It was so polluted, and it was widely known to be so polluted. But because they wanted to cut costs, it didn't matter to them what the consequences were. They just cut the supply and made it come from a closer place, irrespective of the fact that it was very, very polluted. To give you an example, Flint water was so polluted that it caught fire 2 times in the past. It was so bad that General Motors stopped using water from public water supply and drilled their own boreholes and sourced for water elsewhere to work in the industry, not for human consumption, just to give you an example, okay? So that led to all kinds of problems that I don't need to go into because of time. So because of this, virtually everyone in Flint City stopped using public water and lived on bottled water. And this is how it actually looked. So this is public water supply, but this is the type of water that came from the municipal water supply. So people changed plans and got supplies of water from churches, from organizations, from all kinds of places. So at the peak of this, Michigan State University, which has always prided itself as the leading, by the first land grant university, tried to do something. I mean, there were other efforts from all over the place, but one significant way that they did this was to pull the Division of Public Health from East Lansing into Flint so that they can study very closely the situation that was happening. So it's like going right down into the belly of the beast to address the situation. In doing this, it wasn't easy. They encountered all kinds of problems, but they found ways of dealing with it. One of them is what I actually found in the literature that I had, that there were little guidance that was available in mainstream biomedical ethics, which a lot of you have identified, that the 4 principles of research ethics don't really fit well with community-based participatory research, which was actually what people that went there, researchers that went there to do. So it was quite difficult. There were cases where researchers will corroborate with the problem on the ground and made it public, but the government fought tooth and nail, from state government, city government, local government, and did not believe what was happening. I have 2 examples here. If you search the name of Mona Hanna-Attisha, is a pediatrician who was at the forefront of this, and also a group of researchers from Virginia Tech who published their results, but the government did not take kindly to that. So Flint, by the way, had what they called, they actually developed some procedures of, engaging with researchers, engaging with organizations, engaging with any person that could help to find ways of finding some common ground to deal with the situation. So there were steps that were developed, which I refer to here as Flint model. It had a number of things that brought people together and sought for solutions, which I cannot go through again because of time. I went about interviewing people, interviewing researchers from Michigan State University, from U of M, that are also settled, that are also found there, asking them basic questions as to how they were dealing with the situation. This is one example of a response from, and this actually shows, in fact, it confirms my initial hypothesis that what was actually happening there is very similar or analogous to what could happen anywhere in the world. This also was one example of one of the researchers explaining the difficulty of trying to convince, going through the normal IRB and then discussing with the community and then trying to apply all that, the consensus they found to what they were doing, but it wasn't that easy. And this one was a researcher that was concerned about some of the specimens that they were collecting from people and how that might be a problem down the line if it went into the wrong hands. In fact, this responder actually told me a story of how she was shot at, believe it or not, and they went out to collect information from people, because Flint, typically, as it is today, is what I would say is research fatigue, because a lot of people are coming, but in the midst of that, people are very poor, people cannot deal with their daily life needs, so they run away from people they are not sure of, because even utilities, people coming to collect water, delayed water payment or electricity payment, so they can't really make the difference between who is coming for what. At such, researchers have been put on that very serious condition. So overall, in spite of the problem, there is hope. I just have to end with that, because there was just a symposium 2 Fridays ago on the 15th, during which a lot of these researchers came around and then shared, findings that they were getting and how they were looking forward to improving the lives of the people, but we are not there yet, although we hope for the best. So I have some implications here. I also identify some limitations here too, that even as I've projected some solutions, my solutions have some limitations. First of all, The people that I've interviewed are limited, so I look forward to doing more of the interviews and then doing more of the analysis and coming up with more reliable results. Thank you for listening. The problem is not over. We just had May 11th, World Water Day. It was also marked by more distribution of water because people are still living on bottled water, believe it or not. Thank you.
Thank you very much, Ike. That was definitely very thought-provoking and also good to hear an example from here, indeed. I would like to invite Rebecca Barber, who is from the Center for Humanitarian Leadership in Australia, Deakin University, and she is going to talk about research with vulnerable populations in humanitarian crises, ethical challenges and overlooked areas.
Thank you. Hi, everyone. Thank you for having me. I just want to start with a bit of background to me, just to provide some context, because I think I come at this from a bit of a different angle than many of the other presenters have. I'm an academic now, but I'm only a very new academic. I've spent most of my career working with humanitarian NGOs in various different humanitarian crises. And I've had a range of different roles with different NGOs, but in many of those roles, conducting various types of research, from overseeing monitoring and evaluation and assessments to conducting my own sort of policy-focused research. And I did that sort of on and off for the best part of 10 years, and it was only when I started working at Deakin University last year and was tasked with developing a course for students on evidence and decision-making in humanitarian crises that I started looking at the issue of the link between evidence and decision-making, and then the way that we generate evidence and the ethics of that, and then started reflecting on my own practice and realizing the inadequacy of the attention that I and many of my colleagues had paid to ethics. And I just wanted to share that because I think it's quite telling that it was only once I was back in Melbourne at a university, not engaging with vulnerable populations anymore, that I actually really started to learn about ethics. So I actually added this section last night following yesterday's discussion. We've sort of alluded to this question a few times so far, but I just wanted to sort of call it out specifically, this question of what is research. And I just want to start by sharing an anecdote. I wrote a paper on this issue of research in ethical research in humanitarian crises a little while ago, and I submitted it to a journal. And one of the reviewers liked my paper, and the other reviewer said, I have a real problem with this paper because the author is talking about assessments and monitoring evaluation as if that were research, but it's not research, it's fundamentally the practice of humanitarianism. And to me, that really gets at the core of the problem, because I think if we as humanitarian practitioners don't acknowledge this as research, then we're not going to think that principles of ethical research apply to what we do, but we're still talking to communities, we're asking questions, we're taking up people's time, we're collecting evidence, we're analysing it. What about it isn't research? So I've just put up here a few different definitions. I know there's lots of definitions out there. But the first one I've got here is from the Oxford Dictionary, the systematic investigation into and study of materials and sources in order to establish facts and reach new conclusions. And the second two are Australian, because I'm Australian. So the second one is from the Australian Council for International Development's Principles and Guidelines for Ethical Research in Development. And they call research an original investigation undertaken to gain knowledge, understanding and insight. And this last one is from the Australian National Statement on Ethical Conduct in Human Research. And they say that, they talk about how there's lots of different definitions of research, and then they say that for their purposes, what's more important is to define human research, and they define that as research conducted with or about people or their data or tissue, including the involvement of people through surveys, interviews, or focus groups. So if I look at these definitions and I think of all the different types of activities that have involved speaking with people that I've been involved with with NGOs in the field for sort of more or less 10 years, it's research according to those definitions, really. So there's been a few terms thrown around the last couple of days. Veena has spoken about operational research, and I think that's quite a useful term to me, meaning assessments, monitoring, and evaluation. Somebody also used the term yesterday, policy research, and this is actually where most of my experience has been. It's not assessments, monitoring, and evaluation, but it's also not academic research. It's research to investigate a particular policy question. So, for instance, what's been the experience of, did the humanitarian response to the Nepal earthquake adequately consider the needs of the most vulnerable groups, for example? You go to Nepal, you spend 2 or 3 weeks interviewing people, you have a few focus group discussions, you leave, you write it up, you produce your report, done. I've done a lot of that type of research, and that's quite commonly done by NGOs. And then the third category, academic research, which I don't have so much experience with, and I think that's largely what we've been talking about in this conference. So just in the last session, someone raised the question, why do we need operational research in humanitarian crises? Or indeed, why do we need research at all, but particularly operational research? So I just wanted to highlight a few of these. The first thing which we haven't really spoken about thus far is our humanitarian standards require research. Research of some form is an absolute non-negotiable for humanitarian action. The sphere standards in humanitarian response require that humanitarian aid be based on an assessment of needs and capacities. The core humanitarian standards say that programs will be based on an impartial assessment of needs and risks and an understanding of vulnerabilities and capacities of different groups. So these obviously require speaking with people and getting information from people in vulnerable situations. We need research to ensure that our programs are relevant, effective, and efficient. Every humanitarian crisis is different, the needs are always different, and without research into what the needs are in a particular crisis, we can't know that our programs will actually meet those needs or whether they're completely missing the mark. There's no point distributing cash, for example, if there's nothing available in the markets. There's no point conducting vaccinations if no one's going to be willing to be vaccinated. We can only know these types of things through research. And finally, we need research in order to be accountable both to the people that we seek to assist and to our donors. So the core humanitarian standards say that affected people can expect resources to be managed efficiently, effectively, and ethically. And we can't know this without evidence of what worked and what didn't work and why. And we know that essentially through evaluations. And there's also been an increasing emphasis by donors in recent years on value for money, wanting to ensure that they get the most bang for their buck. And increasingly, research is demanded in order to show that, often as part of program proposals. And finally, we need research often in order to influence others. So we may already know exactly what type of program we're going to implement, but we may need research to sort of back up media or advocacy efforts to convince donors or the public of the nature of the crisis. So I also just wanted to touch upon this question of, is research acted upon? So we have this assumption that we conduct research in order to inform decision making, but the link between assessments and evaluations and decision making is in fact extremely tenuous. There has been a lot of research into this issue of the link between evidence and decision making, and some has shown that most assessments are conducted in order to substantiate a case made for funding by a particular agency or to do a particular thing. In other words, the decision has already been made. An agency knows that it wants to implement sexual and reproductive health interventions in Cox's Bazar in Bangladesh, and we need the donor's proposal requires that we have research to back that up, so then we conduct the research. Research also shows that only a minority of evaluations are effective at introducing evident changes or improvements in performance. So this obviously has pretty significant implications for the effectiveness of our interventions, but it also raises really significant ethical questions, because when we conduct research, we're using up valuable time, resources that have been entrusted to us by donors or by the public to spend on humanitarian response. If we know from experience that, in fact, assessments and evaluations don't generally influence decision-making, can we actually justify using up those really valuable resources in order to conduct assessments and evaluations that are probably not going to make any difference? Now, I wouldn't want to suggest no, but I think it's worth having the question in mind. So I want to highlight two considerations, two ethical issues that I think are really key in humanitarian crises, and we've sort of really touched on them, and I think Veena in particular has touched upon this issue. And the first one, I think, is the justificatory threshold for conducting research at all in humanitarian crises. And this is essentially the principle of beneficence, meaning that the burden to participants of participating in the research must be justified by the benefits to them of the research. And I think this is particularly key in humanitarian crises for three reasons. The first is that, as many people have spoken about so far, the participants of our research in humanitarian crises are likely to be extremely vulnerable. They may have experienced or witnessed traumatic events, they may have lost friends and family members, they may be displaced, they may have lost all their material possessions, may be living in very cramped and uncomfortable conditions, and very likely to be focused on meeting their immediate needs. It may well be that sitting down, spending an hour or two speaking to researchers and asking questions about their experiences is the very last thing these people are going to feel like doing. And we heard this morning in the context of the Ebola crisis that there are certainly situations in which participants do want to participate in research for all sorts of reasons, and that is absolutely the case in some situations, but it's also absolutely not the case in others. I think that the second thing is that in humanitarian crises, there is a higher likelihood of participants being negatively impacted by their participation in the research. So we've spoken a little bit about security concerns, the likelihood of participants being at risk for various reasons, particularly in conflict environments, are particularly high. In humanitarian crises, there is often a risk of re-traumatization if you're asking people about their experiences and they've experienced traumatic events. And also the inconvenience. People may otherwise be needing to spend their time queuing up for distributions or taking their kids to school or in childcare or all the various other things that people need to be doing in normal cases, but even more so in humanitarian crises. And finally, the risk of raising expectations, which has also been touched on a few times, but I think there's not many humanitarian practitioners who would not be familiar with the experience of being in a community, asking questions and being told, we're so sick of people coming here and asking questions and no one ever comes in and gives actual assistance. We're not going to answer any more questions. And this happens time and time again. And it's a real risk, and it affects, it undermines the perception of humanitarian organisations. So you've got all that on the burden side, and then on the other side, what do they stand to gain? And this is essentially what Veena was talking about in terms of beneficence. But I have to say, I completely agree, but in my experience with NGOs, I have never actually had any experience where the issue of compensation for for participants in the research was even on the table. It's not something that's very often done by NGOs. I've just put here this the MSF Research Ethics Framework Guidance document, because they have a very useful list of questions to keep in mind in sort of making this equation of cost versus burden to research participants. I better hurry up because I've got the 5-minute mark. But the second thing I think is a really key consideration with research in humanitarian crises is the risk. The benefits of research must justify the risk of harm, which in conflict situations in particular is often a very real risk. So I've put here the physical safety, including travel to from research sites, but I think the bigger questions are with regards to how the research is perceived by political, religious or social groups. So very often you're going to be in situations where you may be conducting sensitive research, particularly if it's anything to do with gender, or I mean, we've heard a few examples already, but of a nature that is very likely to be not approved of by all the different groups, including armed actors. There's also the question of how the researchers are perceived, again, particularly in conflict environments. The 2017 Aid Worker Security Report said that aid agencies are seen as associated with the government in nearly every contested environment. And they had this quote from Al-Shabaab in Somalia saying that all NGOs work for spying agencies. So if you think that all NGOs are perceived by non-state armed actors as working with the government, then what are the implications of that for the people who are seen to be providing information to that organisation? Clearly they're going to be seen as providing information to spies, which has very significant security implications for the people who participate in our research. And finally, there's the risk of the research inflaming social tensions, which I think has also been mentioned a couple of times already. So I think I just want to highlight 3 specific ways in which I think the process can be improved. And again, I'm talking really from the perspective of NGOs and people who are not working with the research institution and not really going through the ERB process, but who are sort of trying to do the best that they can in the field with sort of a lack of procedures and structures around them. The first is to pay attention to vulnerability and the nature of vulnerability. People affected by crises, I think we've talked about this a lot, are very likely to be vulnerable, very likely to be susceptible to exploitation and abuse. And research strategies, even if it's not sort of a specific research project, should at a very least articulate the way in which the researchers will be sure not to exacerbate vulnerabilities. And I have to say, honestly, from my experience, this is not something that I have done properly in the past, and nor have I been called upon to do it, nor has it really even come up for discussion in the research projects that I've been involved with. So that requires an analysis of vulnerability, which is not by you as a researcher, it's by the national staff who understand the community and have worked with the community. Requires consideration of specialised expertise, and it requires an analysis of the cost of participation. So the cost in terms of potential psychological harm, financial cost, how far are people travelling. I've had many experiences where I've come in as sort of the external researcher and engaged in focus group discussions, which the national staff have organised for me, and been shocked by how far people have travelled to attend the focus group discussion. I'm sure lots of other people have had this experience too. But it just hasn't been discussed with me as a researcher, the effort that people are going to get to that focus group discussion. The second thing, we've talked a lot, I think, about the issue of confidentiality and informed consent. It's required, obviously, by the principle of respect, which includes respect for the privacy of the individual and respect for informed choice to participate, which we've discussed. I just wanted to say something on confidentiality, which means the right to remain anonymous. In my experience, it's something that's very often interpreted by just not using people's names, and I myself have interpreted it like this as well. But if I look back through my own reports, I can see, a woman from X caste in X village in Nepal, and this quote, and it's a small village. There's not many people from that caste. It's not too hard, wouldn't be too hard for anyone to work out who that woman was. And I think this is a mistake that researchers, particularly researchers who haven't really been trained in ethics, which is the case for many researchers with NGOs, a mistake that researchers can easily make. We've talked a lot about informed consent, very often not properly obtained. In my experience, we've very often not had consent forms at all. If we had the forms, honestly, we haven't really explained properly the nature of the research process and the nature of people's involvement, and ensured that people really understood what they were participating in. And I've just put a note there for But the ACFID is the Australian Council for International Development. I put the guidelines up earlier, and also MSF. The MSF guidelines have a very useful list I have found useful in the field of information to be provided to participants in the course of providing consent. And the final thing I wanted to touch on is the issue of feedback to research participants. Part of the principle of research merit and integrity, also part of the principle of respect. If people are giving up their time to participate in the research, it's not unreasonable to expect that they would, the research should be disseminated and shared with them. It's something that is very frequently neglected. I can say that in my own experience, I've generally gone in. My assignment has been to conduct the research, so I've spent 2 or 3 weeks in a country asking questions, speaking to people. I go back to Australia, I write out the report. I've actually never, in any of my research projects, personally been the person who has gone back to the community that I initially did the research in and explained the research to them and disseminated the research to them. I'd like to think that the national staff that I've been working with have done that work, but if I'm very honest, I think in many cases, the national staff may not be particularly engaged with the research process at all, or not particularly invested in it because they're not the ones who have done it. Some external consultants come and done it, and they come and do it, and then it's done. Reports, in my experience, are almost always only in English. I think I've been involved with one research project in Afghanistan where the report was translated. All the other research projects I've been involved in have only had English reports, regardless of the language of the research participants, often very low literacy levels. The research results may be sensitive. There may be reasons for not wanting to share the research. Save the Children, for example, did a very sensitive research project on the experiences of children in the Rohingya crisis. They interviewed a bunch of children in Bangladesh. I think for them to really disseminate the results of that report in the refugee camp in Bangladesh would have been quite problematic. And I think probably the two main ones are that many staff are simply unaware of their ethical obligations. There's very little training on ethics amongst NGOs, and there's also very little time. There's often no staff whose job it is to go back to the community and disseminate or discuss the results of research once it's been done. So just wanted to finish by putting up these 3 sets of guidelines which I have found to be useful in the field for NGOs, again in the context of not having a set of ethical procedures, not having your own internal sort of review process to guide you through the process. Save the Children, I think, has been really leading the way in many respects in developing ethical guidelines for consultation with children. And I think that these guidelines are very useful for children, but also very useful for other vulnerable groups. The Australian Council for International Development has a very useful set of guidelines for research and evaluation in development. It is development, not humanitarian crises specifically, but much of it is useful in humanitarian crises as well. And I think probably the most useful of all is this MSF research ethics framework, which is a very useful and practical guidance documents for practitioners in the field. And I think sort of amongst the NGO community, it's probably MSF really that has been kind of leading the way on ethical research practice in humanitarian crises. That's all from me. Thank you.
Thank you. Thank you very much, Rebecca. And then our last speaker, I would like to welcome
Sudarshan?
Yeah.
Oh.
Sudarshan Piakarel from the Bhutanese community of Central Ohio. Welcome. And he's going to talk to us about representations of minorities in research, a view from the community perspective. And afterwards, we will have coffee. We might not have time for Q&A, and I know that some of you are really keen on having a cup of coffee before our last 2 sessions. So once our final presentation is done, We have coffee and tea, and if you have any questions, please do ask them over coffee and tea. Thank you.
Thank you. Hi, everyone. So it's a kind of a end of the day, and maybe you're feeling sleepy or something like that. It's okay if you want to take a nap, but I'll not let you do that. I'm Sudarshan. So I may want to flip a table here a little bit because you may be listening to researchers and then their point of view, and I'm a kind of a subject for a long time. So I will have a different take on how the research should be done. So bear with me, I will go into that topic later on, but I want to start with saying that I'm Sudarshan Pekral, and I'm a part of the witness community of Central Ohio here in Central Ohio itself, and I started this organization called Arogya Institute. I am involved with mental health. Myself being a victim of mental health and persecution from Bhutan, I had to do something to help my community. And I want to make a note on the earlier discussion with the panel here. They were doing a wonderful discussion here, and one of the panelists says that, researchers should be very humble about not being an advocate. But I would say no, researchers are the engines of advocates. I was an advocate for the last 10 years. 9 out of 10 of my work, the 90% of my work is advocacy, and only 1/10 is my research experience. And without relying on the researchers, we can do nothing. We have to go with the research, we have to go with the data, and then speak there. So we are more like a mouthpiece for the researchers. And researchers are really the big advocates, even if they are not advocating all the time. So with that, I want to talk about, really I want to maybe contend what I'm talking today is, I'm going to talk about my community, quick introduction, how I end up coming to the United States, which I never planned in my life. And then a crisis in our community is still going on today because of the situation in Bhutan. And then community perspectives. I was part of the Witness Committee of Central Ohio for over 2 years. I work as a director there. And then now I'm planning to go to grad school myself. So what I have seen and what I had experienced as being a subject or helping the subject. Okay, looks like this is a full screen. So, all right. Okay. So a quick look. Bhutan is a very tiny little country in South Asia. Some of you know it, and if you know it well, that's good. But it's slightly bigger than Maryland. If you add Maryland and Connecticut, that's how large Bhutan is. And the population in Bhutan was, by the time we were kicked out of Bhutan, was around 700,000 people, which is less than 1 million people. And out of less than 1 million people, 1/6 of the population was kicked out during the 90s ethnic cleansing. This is just to give you a context where Bhutan is between China and India. These are two big giants that literally make decisions for us all the time, even if they are not speaking anything. So I want to move on to the refugee crisis. So in the 90s, quote unquote, there was ethnic cleansing. We cannot even define today because Bhutan considers us as illegal immigrants, although I am a 4th generation Bhutanese. And there are people who moved to Bhutan in 1620s. So this is when actually the migration started. So we were forcefully kicked out of Bhutan, and we spent around 25 years in refugee camp in Nepal. And then finally, we got resettled into United States, Canada, and other Western countries, even if they are in, including Australia and New Zealand. I don't know whether we should call them Western countries. That was my confusion in my mind, since they are in the East. Anyways, they are considered as Western countries, and I have to say they are Western countries. So this is a long crisis. It is still a crisis going on, unfolding crisis. There are people in camp today. Over 6,500 people are still in camp, although a large majority of them, out of 120,000, were resettled in the United States. So we consider we have 90,000 people in the United States, according to the resettlement agency data. And out of those 90,000, 40,000 are here in Central Ohio, and then around 25,000 in Columbus itself. So it's quite a large population, relatively speaking, out of 110,000 people in total, and then less than 1 million in the total population. we tend to be a very close-knit, tight community with hierarchy, and then the class system and the caste system, you may know it, is still prevalent and is a majority Hindu community. We were a Hindu Nepali ethnic living in southern part of the Bhutan, and that's one of the reasons why we were kicked out of the country. Because of all this crisis, we have seen a high surge of mental health in our community. So mental health is a crisis, is still going on today, and there has been many research in this area, and researchers haven't really found out the cause or even haven't identified some of the mental health symptoms in our community. But some of the research that we had done or we have been part of or have been in the publication tend to say that mental health, anxiety, depression, PTSD, those sort of things are common, and other physical and somatic pain manifestations is also considered part of the mental health because they could not be categorized as physical pain. And then people are going through the post-migration adjustment issue, which means having difficulty adjusting with the environment. Maybe it is too cold, maybe it is something, altitude-wise they cannot adjust. So they talk about body pain all the time, but oftentimes they don't know what the pain itself is. Even doctors have a hard time figuring out what the pain is. And a doctor in Philadelphia, I guess, said that Bhutanese Nepali syndrome to a pain that they were talking about. They don't know what it is. They talk about a pain specific. So that may not sound good to us when somebody says the Bhutanese Nepali pain, but it is a reality. And with this new community, there is a cultural and linguistic barrier. Majority of people had never had a formal education, and they don't speak English well, most of them. Only new or younger generation tend to speak English. And there is a fear towards people of authority, right? Because people were prosecuted. And sometimes it is great to talk to researchers, but when I go for advocacy region and I talk, people have this hard time understanding when I say people have fear towards authority figure, even school teachers and principal, right? Because people who come from a refugee background, people who have mental health issues like trauma. So in a traumatic situation, your mind is sort of locked position. And until and unless you get an appropriate therapies, the mind do not open. So if your mind was locked in the 90s, when Bhutan was kicking out, when the armies were burning down your houses and things like that, since then, think about is almost 30 years, people's mind is still locked there, which means in a highly traumatized mind, no new information goes in or information comes out. It barely registers in your mind, and then you go back to your own traumatized mind, which is sort of, researchers tend to say, is closed-fist. So it's not yet open. So that's why people, even they say if they see a police officer today, they tend to have the same fear that they had back in Bhutan. So we are coping with all those issues of being refugee, and then although we are, here in the United States, it may not sound that what had happened should have gone by now, but it is still prevalent. And Bhutanese community also have one of the highest suicide rate in the United States among all the ethnic communities, which is twice the national rate in the United States. So from here, I want to jump to, I may be rushing, but I want to be a little slow, right? Okay, so it takes some time for my adrenaline to go down. I'm a runner. I like to run. So presentation of minority in research and a view from the community, what I had seen. So today, if you type in this word, Bhutanese refugee, to be very specific, and then go to Google Scholar, right? And then you'll find how many results? 2,500 results. And they are supposed to be scholarly articles, 2,500 articles. And then when I wanted to dig in, when I want to look inside who the people are writing these articles, maybe a closer look, and I would roughly go through the names And whenever I see a familiar name, maybe sounding like an Indian name or Nepalese name, and then I would look inside the article and see if that is a Bhutanese person. Because if someone is a professor or a psychiatric doctor or a MD, I would know because we have very handful of people in our community. And I didn't go literally through 2,500 articles. That's not possible. I don't want to tell you a lie. But I went through a lot, maybe 70, 80. Majority of the time what I've seen was all unfamiliar name, right? Means someone is writing on our behalf. Someone is trying to understand us. So what happens if someone from outside is trying to understand that community, where people are not involved? I want to give you an example. And I want to give you an example, even when some people are involved within the community, there is a high chance that you can make an error. So as a researcher, I think we have to be mindful. I'm a very small part of being a researcher. I was an advocate. And sometimes I was tired of being an advocate and jump into some of the, researchers' wagon and then did some research as well. Here I want to give you one example. I don't want to talk about what is inside this, this research itself, but just I want to quickly remind you, this was one of the research done in 2014, and it says, epidemiology of mental health, suicide, post-traumatic stress disorder among the Bhutanese refugee. Right? It was done in 2017. And I was literally picking, this was my handbook, going everywhere and talking about, to people when I was doing advocacy work then. And one day I went to Ohio State University to talk with my own fellow community members. We have a student organization. Actually, I started a student organization when I was at OSU in 2014-15. And then in 2017, when I go back there to talk to the students from our community, I literally handed them, look, this is the research and what it says. You have to really study and figure out what is inside. And one of the students, and there was a movement that nobody was talking. It was like shock. And I said, what happened? After a while, somebody said, who did this research? And I said, there are names, you can read about them. And is that person aware of who we are? And I said, must be, because I see some familiar name there. But what is this picture about? The picture, right? And this is on the front page. And I had seen it, but I already ignored, because I was more interested in what is inside, not on the cover of the page, right? There's an old saying, don't judge a book by the cover of the page. So I was that kind of guy, but these students who are in high school or who have just been to college, they want to know what is inside, what is outside, how we are represented. They are studying here in the United States. They are more aware of the ethical questions and ethical values. And so they asked me, and then I had to Google it where this picture came from. And it is nowhere a Bhutanese refugee camp. This is not Bhutan. And I don't think it is United States. So somebody very blindly, I don't think it is intentional, but very blindly put this picture assuming this is a refugee camp in Bhutan, Nepal. Now it raises a question. Even some students who are now in graduate school deny to read this article. They think it's offensive. So, I have 5 minutes, right? So this is what refugee camp look like. These are the refugee camps. Someone who is interested may want to research about that is smoke. That's not a fire. That's a cooking time. Anyways, so going to the time, I don't have a lot of time. That's I'm rushing. I want to share a lot, but so what is the take-home message today? I want to say three things. Three things that, as a researcher, you have to be mindful, and that is involvement of the community in the process. If we want to do research, that could be any community. It doesn't have to be Bhutanese Nepali. It could be Native Americans or someone in Russia or Moscow or China, anywhere. Could be somebody living. Make them the owner of the process. Let them be the owner. Let them be part of the research, right? And having them in a review committee is very important before we jump into research. Even if we have an idea, if I have an idea I want to study Bhutanese community, get that idea from the folks itself, what they wanted to study. Not what's something I want to study, not something that I have to save my tenure in the college. You know, there are things that we do sometimes. So we have to be mindful, and if people are really interested in doing those research, if they wanted to, somebody pointed out research fatigue. In our community today, people are literally feeling research fatigue. Don't talk about research. They will give you $5 and then ask tons of questions for 2 hours. But we have to research. It's very important. We have to know. We have to find out. There are so many causes. Already I told you, there is a Bhutanese Nepali syndrome for mental health. That's not going to help us. So we can involve community in maybe data collection, even in writing and review. That's the one way we can help the community in the writing process, in the research process. Second, which should be our first question, is why and what we want to research, right? It should be very clear to the community why we want to research and what we want to research and how the community is going to benefit out of that research. It's very important to explain to them, because what happened is in 2014, there was no one to ask a question about this. By 2017, the kids who were in high school were in college, now they begin to ask this question. Once it was a Bible in our community, for me at least, a holy book to go around and talk about mental health and cite this report. Today, I want to bring this as an example that something is wrong in it. So this is how the coin will flip pretty quickly. 5 years, 10 years, we don't imagine that. But that could bring a question. Now it becomes an ethical question now. Somebody misrepresented us. Anyways, I'm an advocate. That's why you can hear that my advocacy side. So the last point, the last take-home message is, how do you, okay, something is missing there. How do you want to support the community research, post-research responsibility and ethics? Maybe I was doing it at the middle of the night. So this is important because, sometimes I help a researcher from Australia. She said, no offense to any Australian here. And then she was a professor in Australia, and then her research assistant was based in New York. She approached me. At that time, I was a director at the Bhutanese Community Center, and then she made a couple of requests, and I sort of gave a waiver. Listening to her story, she said, I've been to camp, I was in Nepal, I know refugee crisis, I know, Falana was, some person was such a name and this, and I'm like, oh, she's so close, I know, right? And also the question about the power dynamics. See, not so much. She is an Australian. She is a white woman, right? How much I can resist not saying no to her? She wanted to research. So in the power dynamics, I let her do the research. She had extensive research. She had I don't want to go into the details. It has been almost 2 years. I haven't heard back from her. I don't know. I'm thinking I'm still positive she maybe is still writing. And she wants to publish it. So those kind of situations really puts community back into the burner. So as a researcher, the ethical question should be at the forefront, even before we wanted to do research. And with this, I want to conclude. And if you have further questions, I would be more than happy to answer those questions as well.
Kim, no, you don't need microphones. So, thank you very much for all of So we really thank you for everything you have done, and Haley has had to leave early because she has another boss who's expecting her to get other stuff done before tonight, but I'll make sure she gets some flowers as well. So, yeah, we really appreciate all you did. And Kelly has asked as well that there's one more task she needs to complete, which is about the taxis. So if you put your name down, make sure that there's one booked for the right time for you, so check in with her. And if you didn't put down your name for a taxi this evening to the airport, this is the last chance to get to do it, because Kelly and Kim need to get home early tonight as well. So, okay, so thank you. So let's come back in about 10 minutes. No. It's all still here, and I did double check that it has 02 on the bottom.
You did?
Yeah.
Oh, so
but,
that's fine. That should be the one.
Well, do you want to just even...
No, if it's fine, then it's fine. Should we transform it?
Yeah. What did I do? That's weird. Okay, so I
do have a copy here, so.
Yeah, no, I'm sorry, I don't know. Okay, so let me just copy over the other three ones first. So who have we left? I must have just opened it up and checked it and then forgot to actually put it on the stick. So.
So shall I?
Yeah, please. Are you going to the airport? You're not going to the airport tonight, are you? No, that's just for the airport taxi tonight. Yes.
This is not.
No, this is.
Yeah, mine.
Yeah, for the one after the session.
All right. So this is fine. Yeah. Okay. And this goes here. And how do I?
It's the second symbol there.
This one?
Yeah, just click on it. Yeah, and then click eject. Oh, okay, great. Well,
thank you, Donald.
Yep, thank you. Yeah, it was great. Good. Yeah, good. Yeah, well, keep in touch. Right.
Portland. Portland, can we open? Oh, sorry. Can we open Portland? Robinson.
Yeah, we're just cleaning things up as we go along.
Yeah. This one can all.
So Cortland is first.
And then Martina. And then Jamie.
So when we close out of these PowerPoints, we need to make sure we hit escape. Because if we don't, two of them will be running at the same time. That's where we run into the issue.
Okay.
Oh, I didn't see. Okay.
Well,
so
would it?
Escape, yeah?
Will I just leave the other two? Will I close the other two first? That'd be better.
No.
It doesn't matter. Just when we're in presenter mode.
Okay.
If two of them are in presenter mode at the same time, it can mess.
Okay.
So this is the presenter mode.
Yeah.
Yeah.
Yeah. So when the person's done with this, if you just hit escape, it'll close this out. So if you hit that,
Yeah.
you go to
So
this.
you minimize it back to the normal view. Okay, so that's what you're saying. Just go back to this normal view. Okay. I think we can open the others just to.
Okay. Yeah, they're still opened, not in presenter mode.
Oh
So
yeah.
they're-
Okay.
Yeah, they're just
okay.
in regular
I thought
mode.
you exit all the others.
No, I thought about it, but then you said not to. So great. Okay.
Hello, everyone. So we're about 3 minutes away from 3 o'clock, where we will proceed with our fifth oral presentation. So if everyone could sort of start settling down so that we can really start on time, so you've got 2 more minutes to kind of grab your coffee, go to the loo, and do whatever you need to do before I call our next presenter. Okay, sorry to be the party pooper, but we do have to settle down now. So if everyone could come in, settle down. Yeah. The later we start, the later we go home. It's reality. So I know some of you need to really run quickly after to catch your flight, so you don't want to miss that or any of these presentations. So come on. Okay. So just to give a quick recap, we have 3 presenters, and each presenter is allowed 15 minutes. Let's try to abide by that. Okay, so Cortland here is ready, and everyone else is ready too. So everyone, please welcome Cortland Robinson from the Johns Hopkins Bloomberg School of Public Health.
Thank you very much. I was going to say, please no standing ovation, but oh, it's too late. I used to do a lot of community theater. I would have killed for a standing ovation back then, and I'm thinking of asking my students after every lecture to give me a standing ovation, but that would be coercive and therefore unethical. So I have a lot of material to try to cover in a short time to do it, so let me proceed. So first of all, this is a study that we conducted with R2HC funding of ethical decision-making in situations of extreme violence using a case study of Syria. So this is flipping things around again. We're not talking about the ethical conduct of research, although there are issues that came up. I'm happy to talk about those. But really, how do we bring ethics as a research question that we're studying in terms of not ethical conduct of research, but the ethical conduct of programs in the context of extreme violence? We don't have a precise definition of extreme violence, but in Syria, it is the high-level, persistent, chronic violence practiced against medical practitioners and facilities. And how do people deal with that when essentially all of the conventions, Geneva and otherwise, are flouted? How do we process that? And so we took that as a research question. Fortunately, R2HC gave us money, so I give acknowledgement to them for their support, and also to our partners, two practitioners, International Rescue Committee, IRC, and the Syrian American Medical Society, SAMS. We did our research primarily in Jordan and in Amman, Jordan, and in Gaziantep, Turkey, with a few small calls to people who were working inside Syria. Had to get some special protocols for IRB to make sure those were safe lines, that the communication was vetted with proper informed consent, and that people knew if there were risks, that they knew what they were running. And fortunately, we have no reports of unanticipated problems or adverse events. So let me go through the project. Then we'll talk about the elements of the project, which were primarily literature review, key informant interviews, and in-depth interviews with practitioners, medical practitioners, both managers and frontline staff, health workers, and then a practitioner workshop, 2 of them in Turkey and Jordan, and now a development of a handbook, which is kind of an organizational handbook for implementing ethical decision-making training, documentation, evaluation, follow-up, and dissemination. And we'll be piloting that handbook in a workshop in Amman probably next month. So what are the objectives? What is the role of ethics and ethical obligations and humanitarian principles in organizational decision-making? This isn't about individual ethics per se. It's about how an organization processes this work. What's the literature tell us about that? What do interviews with people who are experiencing these decisions, making these decisions, living with the outcomes of these decisions, what do they have to say about what's going on and how to process what they're doing? And then how to process those results, mapping the lit review, the results from the qualitative research together, and presenting along with a couple of very useful tools that came before us, which I will give proper acknowledgement of, one co-author of which is sitting right here in the room, to see what existing tools can bring to this question of how does an organization deal with the processing of ethical decision-making in the context of persistent threats of violence and persistent violations of all of the basic humanitarian principles and maybe all of the many core ethical obligations. We did have an IRB both at Hopkins, in Gaziantep, in Jordan. We also reached out to the Aleppo Health Directorate because some interviews were done inside Syria. An interesting question, how do you do research? Who's the IRB of record inside a country that is essentially blowing up all the time? Who has agency? Who can speak to those issues? We felt we did sort of the best we can to get consultative status with the Aleppo Health Directorate. They were, of course, themselves trying to manage just to stay alive in their own way. I won't get into the full sort of meat and potatoes of the process, but we did a PubMed Embase Scopus search. We did not do a systematic review of gray literature. We did a sort of what we call a manual or hand search. Partly that was sort of time, but we felt we wanted to focus on peer review articles that might have been in error I am in awe of the people who are doing 676 articles and qualitative assessment. I think we felt we couldn't really manage that, but we felt we have a reasonably good sense of the literature, at least as a peer review results. About 2,000 we reviewed with inclusion-exclusion criteria, 2 independent coders, a third coder making decisions where you had discordant, and ended up with 66, which we mapped or analyzed qualitatively using a sort of emergent thematic analysis approach. Just an example of how this might look. So here's an example from one article. So a few physicians dared serving rural and urban poor. Doing so marked them as guerrilla sympathizers, right? So impartiality, neutrality is in question, as is also an obligation to protect workers. You don't want to harm your workers, sending them out where they could be at risk of being attacked as a guerrilla sympathizer, rightly or wrongly. And of course, how do you distribute resources fairly? You can't not go, or should you not go into those areas where you might be accused of being a guerrilla sympathizer, therefore denying aid to one group or one population, but providing another where your workers may be arguably safer. So this is where these two issues kind of converge, and we ended up doing a kind of a mapping of that from the literature. Where does, across the 8 ethical obligations that came out of the literature, and the 4, or might add 5 with solidarity, humanitarian principles, how do these map in the context of the literature? Not in the context of Syria here, but in the literature. And as you can see, sort of the darker boxes show where higher densities of overlap existed. So of course, neutrality, humanity, and providing the highest attainable quality of care and services seems to be where these issues converge. But there's no null sets. There's smaller convergences, but we felt this might be an interesting way to think about these two, and we use this matrix as a tool when we're doing some of the processing in the workshops, taking all of the, emptying the cells out and saying, how would you map, in your context, these principles with these ethical obligations? Does this work? And how might you operationalize that as a training tool and analysis of the kinds of decisions you have to make? We did 41 key informant interviews. Notice the male-female distribution. Also, in hindsight, I think we could have done better to stratify and maybe oversample, but it probably does give us a reasonable, if you will, real distribution of how males sort by hierarchy in terms of who is the manager, who might be speaking on behalf of an organization, and likewise also health workers. There was something of a bias toward hospital-based facilities, but that's partly where the attacks were concentrated. So we were kind of deliberate, in a sense, in that kind of a bias. But it's a real bias, and the question is, what does that tell us or not tell us, maybe, about how female workers or administrators might view these same issues similarly or differently. Sorry to be rushing, but I know time is short, and I want to get through all the material. Similarly with the IDIs, interviewed both in Gaziantep, coming into the northwest aid sector, and out of Amman into the southern sector. There were many threats inside. Our team was safe from that, and the people we interviewed were essentially safe from that because they were outside. And the few instances where we were able to negotiate a call, we were very careful to make sure that the person in question was not involved in any direct aid intervention at that time, but was, in a sense, either on some sort of standby or in a position or time and place where they could talk freely and safely. But as I said, 39 of these 58 were hospital-based. About half, just under half, were physicians, but we did have some nurses, managers, pharmacists, lab techs, and so forth. We developed a code book, also using iterator reliability among 3 coders with memo, journaling, writing, exploring these coded texts and identifying major themes and relationships. We have a paper coming out on lit review. We have a paper coming out on the qualitative. Again, I'll just give you some of the highlights. Not surprisingly, targeted attacks on health facilities came up time and time and time again. And questions about how do you make the environment safer by reducing length of stay on the part of patients, decreasing the number of health workers, going literally underground, building bunkers, hospital bunkers. How do you maintain access to care despite many of these restrictions. One very interesting challenge that came up to us was people from the community saying, this hospital has been bombed so much, please don't rebuild it. Please do not rebuild it. We will just be bombed again. Now, in public health, we think about getting care to populations as a benefit. Distance from health facilities is often a risk factor. And here they're saying, keep us safe by building this farther away or not building at all, going mobile, going underground, placing facilities near the border where maybe we can go farther distances but safer from keeping our communities safe. Many resource limitations. That question of where do you allocate resources? You can't do it all. And if you give to certain life-saving interventions, surgical interventions, what's the cost? Protective services, gender-based violence, and so forth. 5 minutes. Oh, my gosh. Here we go. Several quotes. I won't read them all. We should, but a few key points. Every day someone dies. I feel guilty that I killed him because I could not help. Not just moral distress. We talked about with somebody moral injury, a feeling that one has caused harm by virtue of not being able to help or help sufficiently. A flu outbreak, not being able to follow proper protocols. Reality makes our decisions. I have decisions I should make, but I cannot make them because reality forces me to do something otherwise. Toll on mental health came up constantly to the point where one of our recommendations is everybody who does this work should provide psychosocial mental health services for your team. Period. Full stop. Don't get in and find out that that's happening. Know before you go. It is going to happen. It's built in. It's baked in. Get it, make it available. Again, how that fear of harm and risk, of ongoing risk, may confuse people to the point where they may work, as this person said, sort of incorrectly. I will do the wrong thing, or I will do the right thing, but not well. What kind of harm does that bring to a patient? What kind of psychological harm does that bring to a care provider? The practitioner workshop, this is where I got a few minutes to get this. We processed two very useful tools. One is the Clarenval Ethical Framework, and the other is the HEAT tool, courtesy of our colleague here. I have cards. Clarenval Adorno provide an ethical framework for processing ethical decision-making. HEAT does the same thing, simpler. They've got nice cards. Come pick them up. They're free. Very useful tools. What we did is take these and say, how do you as practitioners, as a sort of empirical question, what kind of structures do these tools provide? Would they help you? And generally the answer was yes. What they felt was missing, it was not a deficiency, but rather that the context where they were working required them to make this an organizational commitment in an ongoing way because of the threats being persistent and not just sort of ad hoc, periodic. These are persistent, chronic, organizational threats that if you don't take an organizational commitment to do this work, you cannot rely on one individual either picking up the tool, using it, or not. There should not be, it should not be discretionary. So the ideas, first of all, out of the workshops came, first of all, commit to making organizational decision processes, and build the structures and support mechanisms to do that. Articulate your values. What's your mission statement? How does that map to ethical obligations, humanitarian principles? How do you promote and train the use of these tools, either as is or adapted? Am I going for minutes? 1 more minute? 2 minutes. How do you deal with these cross-cutting issues? What's happening in the community? How do you make sure the community is involved in your decision-making process? And then provide psychosocial support. So this last recommendation is sort of different, I think, by category. It's the one sort of operational recommendation we make is have psychosocial support. So out of this came a sort of 7-step approach to build upon, incorporate in Clarenval and Adorno HEAT into a decision-making process that says basically, first of all, to an organization, establish these structures, commit your resources, get the headquarters and the field leaders to say, yes, we will do this on an ongoing basis. 2, articulate your values. Where do you stand? What are your duties of care? What are your ethical obligations? What is priority for you as a mission for your program? Train your folks on this stuff. Don't assume they'll learn it by reading some humanitarian principles manual or something. Get it into their heads and hands. Make it interactive. Repeat. Rinse, cycle, repeat. Keep this message going forward. Make decisions, you will, and document what you did, particularly those that involve an ethical dilemma or challenge. Process and evaluate. And our handbook will lay out some of the steps to actually do this. What are the impacts, positive or negative? How do you know? What are your metrics for success or failure? Make recommendations for future action. Make a repository for that. Document your work over time. Look at how you're doing over time, and then share your results within the organization and beyond. So we have a record, an empirical record of how organizations are processing this work, and hopefully we can build over time to not just strengthen those commitments, but review through these documents of events and what decision was made, who made it, on what basis did they make those decisions, what was at stake, what harms were caused or maybe prevented. And we will build an empirical base and an organizational repository so that the next time somebody's in the field and says, this is happening, there's a soldier with a gun telling me to treat his wounded comrade and leave the patient dying on the table, I've got to make a decision. What do I do? They can hopefully flash quickly onto, aha, we have a record of what worked and didn't work. And you might say, treat the buddy, but meet with them and say, if you do this again, we will go on strike. This cannot happen. You have your own work, we have our work. We must respect each other's differences, but not necessarily yield to entirely to the power of the barrel of the gun, but also not set that aside, I don't care, and risk being shot, and then you're not able to treat anybody further. So processing these things, building a structure of decision-making, documentation, evaluation, and sharing, we think will help build upon the tools that are existing and reinforce, one, that these principles matter, and two, that organizations have to commit to honoring them, but understanding them in context. And how it works for Syria isn't exactly how it will work for Yemen, but that's another conversation. Anyway, thank you very much. Sorry for being out of breath. Come pick up your heat tools. Thank you for your time.
Thank you very much, Portland. Okay, can I invite our next presenter, Martina Gustafsson from the Karolinska Institute? This one?
Yes, hello everyone. I will talk to you about moral distress, sort of linking up to the presentation before here. Very interesting. Can you hear me now? Yes. So my name is Martina Gustafsson and I come from Karolinska Institutet in Stockholm. And I will talk to you about moral distress among disaster responders. And about our project that we have at Karolinska Institutet. So I will start to talk about the overview of the project and the aim of the project and the project plan, and then move ahead to the findings from a scoping review that we have conducted. And my background is in nursing, and I have a master in global health, and I have worked with MSF. And I work at the Center for Research on Healthcare in Disasters at Karolinska. So the project is a combination of disaster medicine and psychotraumatology and ethics. So all these three areas come together here. So it's a collaboration with the National Center for Disaster Psychiatry at Uppsala University, and the Department for Ethics at KI also. And the project is funded by the National Board of Health and Welfare. So why do we have this project then? It was after the Haiti earthquake in 2010 and the Ebola outbreak 2014 and 15, that it became even more evident that disaster responders might be negatively affected by the moral challenges they were facing during their work. They had to take make impossible priorities and to take difficult decisions within their professional role. And these negative consequences affect not only the disaster responders, it affects also the quality of care that is given, and it affects also the organization with high dropout rates and high sick leaves. So this highlights that disaster responders must be well trained and supported and also better prepared to manage morally challenging situations. But to do so, we need to know more about the moral challenges that they face, how they deal with them, and what consequences that they will cause, sort of. And also the linkage between moral distress and psychological consequences is not really clear in the literature and in the current research. So the project plan here, we first wanted to do a scoping review to sort of clarify the definition, to actually know what moral distress is within disaster responders, or within disaster response. And then we have done focus group discussions to explore the experiences of dealing and managing moral distress among disaster responders. And here we have a collaboration with the Swedish Red Cross and MSF, and also the Swedish Civil Contingency Agency. And based on these, the results from the focus group discussions, we are developing a questionnaire that, together with these 3 psychological instruments that measure level of burnout and level of empathic concern and work satisfaction also. Together with those, we will do a survey among a larger population of Swedish disaster responders to assess the level of their experiences. And the main goal with this is to develop a preparatory training for disaster responders to sort of reduce the negative consequences of moral distress. So moving into moral distress then. This is a research area that started in the 70s, as some of you may know already. It was Andrew Jameson who started this research, and it started within the nursing profession. But today it has evolved and involves a lot of different professions that works with people or meeting vulnerable people in vulnerable situations. And also the different definitions has evolved. As you see here, the first one is from Andrew Jameson, and the second one is a newer one, which is a bit broader also, by Kjellve. So let's go to, the research of moral distress is currently more related or centered on normal healthcare in high-resource settings, and not so much within low-income settings, and especially not within disaster response. And there are a lot of different definitions now, and there is there's unclarity among these definitions. So that's what we wanted to do, to clarify the definitions, to actually know what is it. So the aim here was to elucidate how the concept of moral distress in disaster response is defined and explained in the literature. So through this scoping review, we searched academic databases, but also relevant organizations and networks. with the inclusion criteria that they should contain moral stress, moral distress, ethical stress, or ethical distress, and should be related to disaster response, disaster responders, and humanitarian workers. And we found that moral distress can actually be summarized as a stressful reaction developed when the responder cannot, due to different reasons, follow inner moral values in various situations within disaster response. And we also found that these different terms describe the same type of phenomenon, but they use different concepts. And we also found that 3 different types of definitions were used among the literature. And based on the result, we developed a conceptual model to sort of describe the linkage between the terms, to give an overview of it. So these are the 3 different types of definitions that we found, where the first one is when you're being hindered to do what you perceive to be the right course of action in the situation. And that could be due to external obstacles, such as lack of resources. But it can also be that you're associated with another person's or the organization's decision or action. And the second one here is when the individual cannot live up to own ideals, that moral values are trespassed, irrespective of action taken, such in a moral dilemma, also described as a moral injury. And the third one is more related to Wilkinson's definition, where you fail to act on a moral decision, even if it's possible, which is more related to weakness of will. And here it was number 1 and 2 that was most commonly described among the literature. And here is the conceptual model that we developed. And here we wanted to describe and highlight in blue color here. I don't know if you can see it really well, but that should be stated as that moral stress is sort of the normative response within a morally challenging situation. It should be highlighted as a healthy response to a moral conflict. And depending on the intensity, the duration, and the frequency of this situation, it may give rise or may develop into moral distress. And then, depending on how, if you're supported or other risk factors, it may develop into secondary psychological consequences. And you can also do like an arrow outside this box from long-term psychological consequences, which sort of form a feedback loop into to future moral challenges. That if you have long-term psychological consequences, then you will have problems to face when you face future moral challenges. And the risk and protective factors either hamper or support the development in each step here. So this is sort of a repetition that moral stress is a common and normal reaction that includes feelings of frustration and powerlessness developed during morally challenging situations, when individuals are prevented from acting in accordance with their values. And moral distress is the negative stress reaction that may develop if the responder cannot find constructive solutions. And the secondary consequences are such as moral residue and other more general psychological consequences, such as burnout. And here we summarized the areas of moral challenges within disaster response, which we divided into contextual, organizational, professional, and also related to resources and to teamwork. I don't think I have time to go into detail into these different boxes, but as far as we have seen, it seems like the box with teamwork, witnessing abuse of power towards colleagues or towards patients within the team seems to be the most devastating factor for disaster responders. So how can it be alleviated then, the protective factors? Formal support and social support, but also preparedness and training, and also something that seems to be really important, a culture of openness for ethical reflection and discussion, and also, of course, trust in team members. And also that you have a realistic motivation. Many humanitarian workers go into this field with a big altruistic motivation, which makes them a bit vulnerable for when they realize that they can't actually do the difference that they intended to do when they face the reality. And also work satisfaction. And capacity for stress management. And also moral courage. And of course, experience of earlier resolved moral challenges. Yes, I think I was quite in time, actually. Yeah?
Thank you. The good news to being on time is that we will have time for Q&A later. So that's what we would want, because we've missed that for the past sessions. So thank you very much, Cortland and Martina, for keeping time. So can I please now invite Jamie Tagley from University of Liberia Atlantic Center for Research and Evaluation Africa, IRB. I can't. It's kind of. I see.
Good afternoon. All right. So I will be going through the experience from a research ethics perspective in terms of some of the procedure or the challenges that were faced by the IRBs during the unprecedented Ebola outbreak in Liberia. So, as we all know, let me use my. Okay, so as so there are critical questions when it comes to humanitarian crises that involve research where best practices has to be followed in terms of what are the important stakeholders that should be involved during these kinds of outbreak, whether it's an outbreak or whether it's in normal situation. And we all know that with the Ebola or other infectious diseases, there is one thing that usually sprout out that researchers want to investigate and document and see how they could help provide scientific information to the global community in terms of conducting clinical trials. And so that was the case of the Ebola outbreak. And so just to give you some background, most of you may know, there was an outbreak that occurred in a single case in Guinea, happens to cross the border into Liberia to seek medical care, and that was the start of disease or virus unknown that led to close to 5,000 deaths alone in Liberia. And this spread quickly to, Sierra Leone also. So there were 3 countries involved in this massive scourge. And this was now, because that Guinea case was in 2013 December, and the Liberian first case was in, I think, April 2014. So you can see the period that this virus spread. And then there was a big international concern from the WHO and other big players in public health, the CDC. It was like everyone being caught unaware when it was actually realized that it was a disease that no one in that part of Africa ever, knew of. So everyone was in a complete state of confusion, fear, and apprehension. And what happened then was that the government of Liberia, or the Ministry of Health, had to contact the CDC and the NIH and sought, immediate help or assistance in mitigating the deaths, because what happened was that the country was shut down, so there was complete shutdown. However, in the midst of this death and this confusion, researchers or local Liberian scientists and IRB members knew in the long term that there was something coming, and whether they were prepared, to help researchers or people that were going to get involved in conducting clinical trials. And so the ethics member wanted to make themselves known by alerting the Minister of Health then about keeping them abreast of unfolding events. But those information were hard to come by. And so by August 2014, there was a state of emergency. So the entire country was locked down. So everybody stay home. Nobody go to work, no school. So the only sound you hear is the sound of ambulances. And when you hear the sound of ambulance, it means that they are taking bodies for burial. So those are the only sounds you could hear. You couldn't even hear the sounds of pets. So it seems to be that the dogs even knew that they were Ebola. And so, so there was a lot of discussion now around this scourge that the WHO and other groups declare it, a disease of, an international emergency, which means that there have to be means through which some level of help from the scientific standpoint could be brought in helping to find solution to this scourge. And so the governments of Liberia and the other countries were all involved in these, the regulators, including the public and other stakeholders. And so there were a lot of different meetings taking place. And so by this time, the National Institute of Health had already, already in contact with the government of Liberia to start a clinical trial to test vaccines that could possibly help to cure, or whether to cure or whether to help stop the spread of the virus. But by this time of the year, towards the latter part of 2014, the peak of the Ebola had dipped a bit, so it's like it was taking down a nosedive gradually. And so the response was very slow, and so at this point, there were a lot of heated, debated arguments in Geneva and other places, in South Africa and other places, in terms of whether, in fact, the time was ripe to do an intervention, particularly using certain designs in the conduct of clinical trials. For example, the quote-unquote the gold standard, which is the randomized controlled trials. When in the midst of that, there were people dying in the streets in Conakry and other places. Why not give these poor people the vaccine? Why should you go and, while people are dying, why will you put the life of people at risk when there's a possibility that they can survive? So there were debates on what design to use in the region. And while this was going on, accessing the local capacity in terms of what were the structures that were in place in these countries in terms of reviewing the many highly rated scientific protocols that were being prepared. And so the local scientists in country were also very concerned, and the good thing about it is that they were part of the process in Liberia. And so these protocols that came in, there were a lot of critical issues or concerns that the National Research Ethics Board and the University of Liberia IRB, these were two groups that had to merge. That is, bring in some of the members from the University of IRB to beef up the National Research Ethics Board in the review of some of the protocols. And so these were critical issues that the boards were concerned about. The first and foremost was safety of the vaccine. That vaccine is the one currently that is being used in DRC. It's called the VSV. And so from the get-go, the NREP said, hey, we cannot review any protocol where we don't have any preclinical data. And so there were a lot of discussion, because at the time, even getting preclinical data from the study, from the NIH, was still in process. So there were a lot of back and forth, because the NREP said they weren't going to approve any vaccine trial until they can have a result from a preclinical trial that have taken place with the vaccines that were being used. And there were a lot of issues in the public, even in the national legislature. concerning the safety of the vaccine. In fact, for the first time in Liberia, people did not know what clinical trial was. In fact, there is something called the social mobilization and communication and engagement. So if you went to a market woman, and told her about clinical trial, she didn't know what you're talking about. So the name trial had to be changed to study in order for the public to understand what they were going into in terms of volunteering themselves through the consent process, enrolling to the study. And so between 2014 and 2016, there were several trials that were reviewed and approved by the boards, including many observational and anthropological studies around Ebola. And the both entities, as I said, the both boards, combine knowledge in terms of, reviewing these protocols that came through. And there were a lot of things in the public, even in the political system, about Ebola, how did it come? There were a lot of myths that it was brought in by Westerners, and just dropped in a forest in Guinea, that it was a man-made disease. So there were a lot of rumors and conspiracy about it, that it was for money-making. So it had to take political will from the presidency to the legislature, a lot of engagement, where there were a lot of presentations to tell them what the virus all about. And even the board, the National Research Board, were also called to provide, from their standpoint, in terms of what their thought process was, whether this trial should go on or not. So there were a lot that happened, whether it was for the good of Liberia, and why, and how. So there were a lot of questions around this. And so that trial started anyway. It was approved and started 2015 February, and it's still ongoing in terms of follow-ups. So this is one of the angles when it comes to conducting trials in developing countries. So social mobilization and communication advocacy was one aspect that the research boards always requested, because doing clinical trial in an illiterate, highly poverty-ridden communities raises a lot of concern. What was it? So there had to be a lot of engagement through flyers, through radio jingles, and a lot of things that an illiterate person will understand what, so it was like a collective approach through the guidance of researchers and research ethicists during this process. So in conclusion, there were about 7 protocols that were approved that had to do with trials from different groups, but most of these studies are being conducted by the National Institute of Health through the NIAID division. MSF also did some work there, and also a group called Clinical RM, they're based here in the US, that also did some work around Ebola. So in conclusion, there were a lot of things like, expediting protocols. That's one thing that was highly debatable in the board, that, hey, we're not going to be rushed into approving protocols. No, we need to understand every detail before we can. So a lot of things happened. There was some unconventional means. Other people flew in and ran in communities, and conducted some studies by circumventing the IRB process. There are some case studies that were documented. And so there was still a need to further debate on what design should be when it comes to conducting clinical trial. But from the NRAB experience, the board really thought that with you can do it. It can be done anywhere. Conducting clinical trials during an emergency is possible. Only if you have the right team of people, you have a stakeholder engagement, and that everyone is on the same page, and that is for the better good of communities and not just for the PIs. And so shared learning have been one of the huge contributing factor within the 3 countries. So Guinea, Sierra Leone, Liberia today have a strong collaboration through what you call the West African Research Consortium that meet every year and discuss progress within the research community and the trials that are taking place in the 3 countries. And so we think that the region is well placed in terms of prepare for any future outbreak, whether it's Ebola or any other infectious disease. So these are just some of the reflections from during those very scaring days. It was like a zombie time, you know. So this was what you call community engagement, where you had to explain in detail what it was all about. These photos also of community engagement. And so thank you for listening.
Okay, stay there because we have time for Q&A. Yay, finally. So may I invite please Cortland, Jamie, would you like to kind of stay in front for questions? Martina? We have time probably for 2 questions. Please keep your question because you can always go up to the speakers to make comments, and try and keep it as succinct as you can because we want to get the most out of these speakers. So any question?
Jamie, this is a question for Jamie, and I apologize, I had to miss the beginning of the talk, so you may have preempted this. Apologies. In Liberia, the vaccine trial that took place, that started and was never completed because the outbreak was stopped in Liberia by that time, was a placebo-controlled trial. It was individually randomized. If you're familiar with that case, I was wondering at the time why they didn't use active control, for example, a Hep B vaccination that might have given some benefit to the individuals and might have not undermined the science in any significant way.
Okay. Yeah. So again, as I stated, there were a lot of debates on why RCT, when people were dying, but the intention then from the researchers were to enroll 27,000 participants. But by the end of 2014, the epidemic, the level of death have dropped tremendously. And so getting that amount of persons, the endpoint became, not it couldn't answer the, the scientific questions. And so because of that, the PIs decided to reduce that total enrollment to, I think, about 1,500, into an intervention in a placebo arm. So that question about why, everyone couldn't be equally, given treatment, is that what you're saying? Yeah. Yes, that's so.
The controls got Hep C vaccination.
Yes.
That might have not undermined the validity.
Yeah.
Sorry, Hep B vaccination.
Okay.
Thank you. Well, I'll direct my question to Cortland and Martina. Thinking you've identified ethical challenges, ethical distress, and I'm wondering if in your research you identified features or factors that were in some way particularly salient for helping people be better able to cope with distress, better able to orient for ethical challenges. You've both identified some ways forward in thinking about that, but from the literature and from the experiences, these workshops and these interviews, are there things that people identify as particularly valuable? I know, Martina, you identified teamwork as being a particular challenge. I've seen in some instances that actually teamwork is one of the most important protective factors as well, for example. So curious your thoughts on those.
Does this work? Yes. Yeah, as you said, teamwork is really a sort of a protective factor, but when it doesn't work, then it becomes a sort of a risk factor instead. So that was sort of, as far as we have seen, the most supportive thing, especially in these situations and in these contexts where you are really vulnerable and alone with your decision. Then you have these ethical discussions or informal discussions over a beer during night, and that was like their support. But they had to find that support on their own, and they had to sort of look for that support on their own. And if they didn't find it, then they were even more at risk, sort of.
Yeah, I would reiterate that. I think many of the respondents, both in Jordan and in Turkey, talked about the feeling of being alone in their decisions, of not knowing whether it was the right thing or the wrong thing, having to do it kind of on the spur of the moment, not being able to sort of even reflect on what was done before, not knowing what was done before. And I would say that's not just lateral, it's sort of hierarchical. So people talked about headquarters they've told us, go do your work, can't monitor us, can't even cross the border to do the usual sort of accounting processes. So I think the situation left them very much isolated. The conflict left them isolated. The disconnect because of all the difficulties getting back and forth across the border. And I suspect also the inability for headquarters to really clearly articulate what was exactly proper protocols in certain instances. And many people said if we only had a clear understanding of what our organization sort of stood for, would allow, would accept or not, we would have felt stronger in our decisions or known where the sort of lines were. So I think it is very much about teamwork, and I think maybe that builds a sense of sort of organizational solidarity as well as solidarity with other partners. It doesn't take away the risk, but it won't alleviate the harm that comes with this continuous feeling of how to work in these horrific environments. Most people said the best way to alleviate moral distress is end the war. Well, okay, short of that, what could we do? And I think organizational training, capacity building, building commitments, and clarifying what those guidelines are, people were saying would help give them a sense of, if you will, relief that they're at least going to be supported in their decision and that there's a process through which they can evaluate and perhaps make either better decisions or continually good decisions if those were in fact proven over time to be the best under the circumstances.
Thank you.
All right, congratulations, everybody. We are almost there. You guys are doing an amazing job. And we're going to end with a really exciting keynote with Dr. Nir Eyal. And we're going to switch it up just a little bit. It's going to be another conversation. So Dr. Eyal is going to be speaking and giving the keynote address. And then Dr. Kevin Pacino from OSU is going to give his response. And so let me just give you some introductions. So Nirayal is about to join Rutgers as the inaugural Henry Rutgers Professor of Bioethics at the School of Public Health and director of the new Rutgers Center for Population-Level Bioethics. He will also have an appointment in the philosophy department there. He is an expert in population-level bioethics as well as clinical bioethics. He's coming to Rutgers from the Harvard T.H. Chan School of Public Health. His main research foci are health inequalities, health promotion, and research ethics, and his work engages in a broad range of bioethical issues, including healthcare rationing in resource-poor settings, critical health worker shortages, personal responsibility for health and nudging for health promotions, disaster response, and ethics in infectious disease research, especially in HIV cure trials, HIV treatment as prevention trials, and vaccine efficacy trials in emerging infections. And then afterwards, Kevin Pacino is a professor in electrical and computer engineering here at Ohio State, and also in the Department of Evolution, Ecology, and Organismal Biology. He's also the founding director of Humanitarian Engineering Center at OSU. His research is on social networks, including thinking about how there's a cooperative management of community technology and sort of sustainable community development. He's also the author of Humanitarian Engineering, Advancing Technology for Sustainable Development, and he's involved in a number of humanitarian engineering work in Guatemala, in the US, in Colombia, in Paraguay, and Honduras. He's also involved in a number of really exciting educational humanitarian projects, both in Columbus and abroad. So thank you so much, and enjoy.
Thank you very much, Dana. Thank you very much, Donald, and everybody who organized this great event. I'm going to zoom right into it. It's going to be more provocative than other papers you've heard, so I might not get the same standing ovation once this ends, but always a first. Okay, so what I'll do today is there will be a short intro on the nature of what we're going to discuss, nature of the problem, characterizing further the notion of limits on or caps on the risks that can be legitimate in a humanitarian research study for study participants. And I'll give some arguments that I have against the existence of such limits. I believe, to give you the short of it, there are no limits to how much a study in a humanitarian crisis may be risky. There are various constraints on how risky it can be in relation to the benefits for the participants, for society, etc. But there is no specific limit. We will flesh out this notion a little more, and I'll also address arguments that others have given for the existence of such caps. So clinical research ethics requires, among other things, a favorable balance between the risks to a study's participants and the expected social value of the study. Yet some authors and guidelines on research ethics warn that certain risks are just too high, such that even the most socially valuable studies, say urgent humanitarian research during disaster, not just every humanitarian study, even in the most special cases, you might be tempted to ask volunteers to come and join a very, very risky study indeed. If the study is risky enough, it just can't be justified, they say. Even tremendous social benefits, even informed consent, etc., cannot exonerate such a study. It's just unethical. In their view, a cap exists on how much the social value of a study can justify risk to participants. Some say, for example, that when a high probability of death or severe injury to a study participant from an experiment is predicted in advance, that experiment cannot be ethical. any such experiment is, they say, illegitimate, and it remains illegitimate even if society stands to gain tremendously from conducting it, and even if in terms of the quality of consent, independent review, community engagement, if that's part of your list of requirements, you've minimized as much as you could the risks within the bounds of validity, you've maximized the benefits within bounds. Still, if you want to do something that fundamentally is very, very risky, if you do it, then can't do it. What they claim rules such a study out what they claim rules such a study out is an alleged cap or limitation on how much individual participants' health and welfare can ever be compromised on the path to scientific, medical, and humanitarian progress. So this is the view that we're going to grapple with. What should we make of this view? Is there such a cap or not? This is what this view says, but this talk will argue against the existence of such a cap. The bottom line is that when the research is important enough, there is no upper limit on the risks that humanitarian studies may legitimately visit upon their participants. Let me start by presenting the notion of caps on risk to participants. A decade ago, Franklin Miller and Stephen Joffe raised an excellent question, I think. I'm quoting them. They say, they're asked, is there a maximum level of net risks to consenting research subjects that can be justified by the potential social benefits from a particular scientific investigation? As they point out, the Nuremberg Code, for example, promulgated in the wake of Nazi abuses, stipulates a limit on the permissible research risks when it decrees that, and I'm quoting from the Nuremberg Code, no experiment should be conducted where there is an a priori reason to believe that death or disabling injury will occur. Other leading bioethicists endorse caps on research risk to participants even more definitely than these authors do. For example, Alex London urges researchers and oversight bodies, and I'm quoting, to ensure that the incremental risks to the basic interests of research participants that are associated with purely research-related elements of an investigation are not greater than the incremental risks to the basic interest of others in the community who work on a routine basis to advance the common good. For example, he gives the example of firefighters. And elsewhere in the same article, he gives another standard which is even more restrictive on how bad the net risks can be. Not so important for our purpose today to discuss whether the particular standards that he should have been more restrictive than that threshold or that. The point is that he has thresholds, and that it means that he endorses some cap on how risky things can be. Annette Reed and Dave Wendler, a third example, are also clearly committed to the existence of caps. They write, there are levels of net risks to individual participants that cannot be justified by even tremendous social value. If the cumulative net risks in the study clearly exceed the general limits of acceptable research risk, the study should be rejected. David Resnick, same view. He actually gives a particular number for where the cap is in terms of the chance of death. It is at 1% or more. Can't justify it no matter what. There is a little room for wiggling above the 1% number. Never mind, it's complex, but it's basically around 1%. And Annette Reed also conducted, I'm not expecting you to read all of these small letters there, but she conducted a very thorough, very impressive review of existing regulations and guidelines, and she shows so many of them endorse such caps. Furthermore, she adds, when there are questions about the validity of the consent, it's on children, it's on people who, for this or for that reason, we are doubtful about their ability to give on their own valid consent. The caps go, in the guidelines, go way below, so it's becoming no more than minimal risk or very demanding standards that say can't do it if it's very risky. Furthermore, all this is about when some benefits are expected, many would nonetheless condemn some studies of tremendous social value when they are unbalanced, too risky for participants. So we should probably add to this list even more guidelines. And I might add that for some ethicists, I think I've heard that view mentioned at least at one point today, the cap is very low indeed. It is basically at 0. So if somebody today said, if we're not expecting it to be net beneficial to a participant, we shouldn't enroll them, especially not in a humanitarian, precarious humanitarian situation when they're so vulnerable, etc. So that's a very low cap indeed. We are not haggling over the numbers. We are discussing now whether there is a cap, whether it's a 0, it's close to death. Is there such a cap? Is there something beyond which we cannot legitimately go? Many authors and guidelines indeed endorse such caps. They say that there is a level or a kind of risk that is visiting upon study participants for study purposes alone, even in a humanitarian situation, or you might say, especially in a humanitarian crisis situation, is never permitted, no matter how socially important the study is. I'm going to further characterize this position before turning to its critique. So just so that we are understanding what exactly this entails. Even if you don't endorse any caps on how bad the risks can be for study participants, you can endorse this picture in which for very risky, so imagine this is no risk at all, or no net risk, whatever the variant you're going for. Sorry, can you not hear me? And on the right is the maximal risk. I don't know what the most, 100% chance of dying a torturous death very soon, or something like that. I don't know. Everybody agrees that you can't subject people to very bad risks if the social value is minor. You could even have a picture which still doesn't involve caps. Yeah, so on that picture, basically you can only legitimately do things in the gray area. And we haven't endorsed any cap here. We just said, when you're considering how much risk you can expose people to, you can't just do it for a trivial social benefit. You need to have a serious social benefit. Say, we need to scale up and roll out this vaccine to help a lot of disaster victims. You can also have such a picture without strict caps, which says basically, and the worse the risk becomes for the individual, it's not just linear. We are going to demand even more by way of social value. So to take a 50% chance on making me sneeze for a month for the sake of sparing in the foreseeable future the equivalent of sparing 500 people from sneezing for a month might be okay, even if to take a 50% chance on killing me now wouldn't be okay, even for in the foreseeable future, sparing 500 people from dying. Because when it comes to death, we are more restrictive in the left side picture than when it comes to sneezing. But neither of these pictures is a picture of a cap. That's not what we're talking about yet. Here's what we're talking about. A cap says, at some point, the risks become bad enough that I'm not interested to hear anymore about the social benefits. I'm not approving this study. End of story. This is the view that we are going to examine now. Does this view make sense? This is the view that Alex London, Annette Reed, Dave Wendler, David Resnick, Frank Miller, and Steve Joffe are endorsing, and many, many guidelines endorse. I'm going to present arguments against this view. I think I'm going to have time just for some of these. Let me... Okay, these revolve around what I should call anti-absolutism, CAP's initial intuitive, the importance of imagining concrete cases before we make declarations in this area. I think I'll skip the third point, and fourth fourth point would be issues around consent. So let me start with anti-absolutism. The overwhelming majority, so I'm a philosopher by training, and I can tell you that the overwhelming majority of contemporary philosophical ethicists rejects what we call absolutism about unconditional moral rules. So philosophers don't believe that there is any kind of action, nefarious as it might be, that you might do to somebody else that wouldn't be justified in these highly hypothetical, you never meet those contexts, etc., settings in which you could save 1 billion lives by just doing this thing. It's just hard. It sounds great in principle. It works in everyday life, of course, because in everyday life you do not, encounter situations where you can save 1 billion people. But it's hard to support that fundamentally if you're really, really serious about that. It used to be that the last example of a philosopher who endorsed absolutism was Elizabeth Anscombe in the 1950s. And then in recent years, there were actually 2 books supporting absolutism, but they're the only 2 books. Everybody else, and it's not just utilitarians. Everybody, also the anti-utilitarians, both consequentialists and the vast majority of non-consequentialists oppose absolute rules. The non-consequentialists or the non-utilitarians would specify that small gains in overall value do not justify infringement of moral thresholds, as they call them, but they would agree with consequentialists, with utilitarians, that extreme gains justify the infringement of these thresholds. Ironically, the standard example that they all give for these extreme situations where it might be justified overall, on balance, to transgress the thresholds are public health emergencies, where indeed you might have so many lives to save. So both consequentialists and the vast majority of contemporary anti-consequentialists would need to reject caps, I believe, on risk to participants, given these caps' unconditional and absolutist nature. Certainly to reject these caps does not commit one to a crude utilitarian approach to research ethics. So remember this picture. At least the variant on the left is anti-utilitarian. So you don't need to be utilitarian like potentially the president on the right in order to still reject caps. Let me move to the second point. As another strike against caps on risk to study participants, I want to point out that these caps have usually been preferred without picturing the extreme scenarios that lend at least initial appeal, initial support to high-risk studies. If you picture these scenarios, these caps start looking less appealing. For example, want to imagine an outbreak of a highly infectious and extremely lethal strain of MERS, Middle East Respiratory Syndrome, a kind of perfect storm of infectiousness and lethality. I want you to imagine an especially infectious, so a more infectious strain than we are used to, which starts at a civil war zone. Either standard containment strategies or investigating the efficacy of a safety-tested vaccine candidate in the field are impossible in that dangerous zone. Grant me that, if you're willing. I'm trying to give you a worst-case scenario, and I'm imagining it. So don't tell me this never happened because, I'm imagining it, okay? I'm saying we shouldn't have rules that wouldn't work in some conceivable situations. If this is simply couldn't happen, okay, tell me that. But if it hasn't happened yet, that's not good enough when we're preparing for many years to come, as disaster preparedness experts know. And people flee that zone to many international destinations. So this arguably realistic scenario creates a dilemma. Either defer vaccine efficacy testing until the outbreak reaches other areas where it's easier to do an efficacy study of a standard kind, but that risks millions of lives, because by the time it gets there, it will have gotten to many, 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 many areas elsewhere in the world. Very hard to contain that pandemic strain by then. Or you have the following choice of a very, very risky study indeed. Ask volunteers if they would be willing to come and join a challenge study for that MERS strain. Challenge studies where we deliberately expose people or deliberately infect people by some bad stuff, and see this way, for example, whether the vaccine candidate that we have given them before, or half of them before, works. We expose healthy volunteers to that. Can't be good for their health. A very hard study to justify for such bad stuff. It would be extremely risky because the strain is so lethal. And the candidate vaccine is only experimental. We're not sure it's going to save them. May save some of them, not others. And besides, in this design, there is a placebo arm. So for some of them, there isn't even the candidate vaccination. Very good for science, horrific medically for the participants. What should we make of this? The study would have accelerated crucially effective response and therefore have extreme societal value, at least if you are willing to assume, and I think sometimes we can assume, it's realistic that something will happen, somebody will transmit the results of the study. The vaccine manufacturer is ready to scale up production and roll it out, and this could happen if we do this study. I want to maybe also let me clarify one more detail. Often we prefer in such situations to first go do whatever we can in animals in this situation for a variety of reasons. If you're willing to grant that, that's not going to work well. So we really have that very, very, very painful dilemma that I described, and now we need to make a decision. I want to say that, so for me, this intuition, I'm not saying that I have a clear intuition that this is unproblematic, it should go ahead, but also I lose, when I think of this concrete case, this triumphant, oh, we will never do this thing, which is very easy to do when you're not imagining the concrete, very hard situation to be in. This is all I wanted this example to achieve. Let's move to I'll skip actually this argument and move to a final point about consent. You know, when philosophers tell you there are classical counterexamples that we give against utilitarianism, where you could save more lives by doing something terribly abusive to one individual, killing an innocent to save 5, or things of that sort. It's always a non-consenting innocent whom you're actively killing to prevent the death of others. I'm talking here about volunteers who are consenting. So the idea is it's a small study. We're going to try to find if there are enough people for whom, the appeal of being a part of a network, the appeal of heroically participating in studies. I actually met one of those Westerner participants of the toxicity trials for the Ebola vaccinations in Geneva. He was an effective altruist, a medical student who participated in that study because sheer altruism. He was healthy. He didn't need it for himself. Maybe we could find around the world people who are way braver than that individual, because that was some risk, but this is great risk, who would consent. You might argue the sheer fact that somebody is volunteering to almost die for us shows that they are cuckoo, and this consent could never be valid. I would challenge that. I would say, so in contemporary theories of what is rational, people say, so Derek Parfit, the great philosopher who died a year or 2 years ago now, said there are two things that can be rational, either the thing that maximizes your good or the thing that maximizes the good in the world. But maximizes the good in the world can be rational enough. So it can be rational to sacrifice yourself, even greatly, to achieve the greatest good in the world, and what is, people sacrifice themselves for so much more minor things than the stakes here. I want to argue it can be rational to be part of a toxicity study, like the persons who volunteered for these studies, who volunteer regularly for toxicity studies for a variety of treatments and vaccinations that we are developing, even though they're healthy and they don't need it for their health. They may have psychosocial benefits. These are probably not going to be enough to compensate fully for the medical risks, but they can also just do it because they want to do the right thing ethically, and that can be rational. I'm sorry, to be ethical can be rational. That's all I need to say in order to show that an informed person can voluntarily, with full capacity, volunteer for such a study, so the consent can be valid. These are very rare people to come by, but we're only looking for a small number of volunteers. Where I calculated here for the study, it was 75 volunteers. That's maybe a realistic prospect. So I've basically said all this. Let us move to the next point. I want to address some arguments that have been given in favor of caps and against the position that I take. Prohibitions on high-risk studies are typically stipulated and rarely defended with a fully fledged argument. As we shall see, a few existing or conceivable attempts to shore up these caps also fall flat. So Jaffe and Miller tried to motivate a cap on legitimate risk to participants through the thought that in real-life examples, the social value of studies is never certain. And they're right. It is never certain. That's why we have a study. But that's not enough to show that the social value is always so dubious that no great risks for individuals can ever justify it, because basically, in other words, the prospect of a social value always remains very low according to that position. I want to say, no, the prospect can remain very high if what is at stake is tremendous enough. So I'll give you, this is the listing of the arguments. So jumping to argument one, I think they're right that there is uncertainty, but here is a back of the envelope calculation that may convince you that the social value of the study that we mentioned can be high enough despite the uncertainty. So the Spanish flu of 1918 infected an estimated 500 million people worldwide. Part of the reason for the enormous number of infections was the lack of technological advances like vaccines. Efforts to prevent the spread of disease were limited to promotion of good personal hygiene, isolation, quarantine, closures of schools, theaters, and the like. The pandemic worst case that I propose was meant as a realistic worst-case scenario. So it is conservative, I think, to suppose that in our more populous and more connected world, absent a vaccine that is relying merely on same things, therapies, good personal hygiene, isolation, quarantine, closures, there would be a tenth of that number of infections, namely 50 million. If on the other hand, a safe and efficacious vaccine is approved, produced and rolled out on time, some of these infections would be prevented. A conservative estimate, again, I'm trying to be conservative when I'm describing the side of the social value, is that it would prevent only a tenth, namely 5 million infections. Now, because so far, according to WHO, approximately 35% of reported patients with MERS have died, to prevent those 5 million infections would prevent approximately 1.75 million deaths. Oops, where am I? Okay, where's this 20 coming from? Oh, okay, I added the 20 will come in a minute. How much would the challenge study being considered facilitate preventing these deaths? Challenge studies rarely suffice for vaccine approval, but they can substantially accelerate them. Everything, it's from a paper, there's kind of a site for everything. I hope that you'll believe me. While conventional efficacy studies regularly lead to approval, only a half or two-thirds of vaccine candidates that undergo efficacy trials reach approval. After all, efficacy trials can reveal insufficient efficacy. And notwithstanding the special efforts that the dire situation would require, a vaccine found to be safe and efficacious need not be approved on time, and an approved vaccine need not be produced and rolled out on time to make the big difference. Taking all that into account, let us conservatively assume that the acceleration spurred by this challenge study would contribute to global population health at the margin only 1/20th. Here is where the 20th is coming from, 1/20th as much as finding a vaccine candidate safe and efficacious and then approving and rolling it out widely and expediently. Since we estimated the latter as equivalent to preventing 1.75 million deaths, the marginal contribution to global population health of this Merck's vaccine efficacy challenge study in the circumstances would be preventing 1.75 million divided by 20, which is 87,500 deaths. Does that justify the acute risk to study volunteers? Well, challenge studies only involve a few dozen volunteers, assuming, and let us assume 75 volunteers. I think this time I'm trying to be liberal. So 75 is a lot of people for a challenge study that we're putting at risk. A full half of whom, let us assume, are placebo controls. In a pessimistic scenario in which this safety-tested vaccine turns out to be inefficacious, such a study would take around 26 volunteer lives, which is the 35% mortality that we have with MERS. But optimistic scenarios in which the vaccine candidate is found to be efficacious and the study takes fewer volunteer lives, let's assume 13 volunteers in the placebo arm and 5, say, in the active arm, so 18 overall, are equally or perhaps even more likely to turn out to materialize. So I'm going to do the average of these two, 26 and 18, because we're assuming, I think, again, not too optimistically, that they are equally likely. We shall put the probability of each of these scenarios at half and then say that while risking volunteer deaths from active investigation and intervention remains daunting, the extreme circumstances invite an extreme response. And this averaging 22 deaths compared to the 87,500 deaths that we have on the value side is an extremely high ratio. It is almost 4,000 times. It is at worst the equivalent of preventing 4,000 or 39,777 innocent deaths by killing one innocent. And later on we shall see that the moral infringement in this case is far less severe than that of killing a non-consenting innocent. By comparison, if we look for a minute at the philosophical literature about these thresholds, people are toying with numbers. So in a famous example for Bernard Williams, he says, I'm not sure if killing one is worth saving 20. There's an introductory book to ethics that says the numbers surely flipped by 100. We're not talking about anywhere near 4,000 times. So while these authors probably meant that just to be illustrative, I think we can glean from that what people have in mind. And I think it's fair to say that the intuition is that even if this was without consent, etc., it would have been acceptable from the point of view of the non-absolutist ethics that most everybody agrees with. This is 100 or 200 times these prevalent thresholds in the literature. Alex London grounds caps on risk to participants in a principle of equality, according to which, and I'm going to quote, as a necessary condition for ethical permissibility, research with human subjects must be designed and carried out so as not to undermine the standing of research participants as the moral and political equals of their compatriots by either knowingly compromising their basic interests, and I want to emphasize this because that's the relevant point, or doing other things. Now, London is surely right that this study would compromise the basic interests of participants, but as an objection to extreme risk trials, the principle, I think, would rule out too much. It would rule out many widely accepted studies that also put basic health at risk. For example, many toxicity trials that we do on healthy volunteers all the time. They compromise basic health interests. I'm going to skip some of the discussions here, but there are some further complications regarding London's view, but I'm going to skip those and move to a final, to another argument by London. London points out also that caps on risks to participants are concerning because very risky research may undermine public trust, he says, in public health or in researchers at a time of crisis when public cooperation is indeed direly needed. Risky research jeopardizes, he writes, the willingness of community members to believe the information that they receive from basic social and governmental institutions, to rely and comply with their instructions, and to provide various forms of cooperation and support for their efforts. All that may be true, but highly valuable experiments can also promote trust, for example, by showing the competence of medical and public health institutions which are managing to do things which lead to the discovery of vaccines and some hope, some response, some reason to come to the clinic. Such experiments may also make so much headway against the disease as to warrant, on balance, some risk of decline in public trust. So I'm very aware of the importance of public trust, but we shouldn't be absolutist about it and assume that there is no other maximizandum during an outbreak. We need to do things and can sometimes afford some limited compromise in public trust. One should generalize, not rule out, certainly not by regulation, otherwise permissible public health interventions that would have helped thwart disaster, yet would upset some members of pluralistic publics. Consider such disparate examples as safe burials, somewhat invasive contact tracing, careful quarantine, refusing compassionate use that would invalidate a promising vaccine study. These measures stand some chance of aggravating some stakeholders, but that does not mean that we should simply avoid them. We ought to at least try to educate the public about their importance in the right ways, using people from the community, etc. But we don't just treat them as there would be some risk to public trust. Therefore, even if something is very, very important and critical for fighting the outbreak, we're not going to do it. Same goes for emergency research that posits high risk to participants and may aggravate a subset of the population. Okay. Some of the support for caps on study risk, I assume, probably stems from the prevalence of very risky study among the most abusive studies in the history of medical research. We should therefore make a point of simple logic. The fact that many highly abusive studies contain a certain element, say, very high risk to participants, does not show that every study containing that element is abusive. Likewise, logically, all abusive studies were studies, yet not all studies were unethical. I can leave that point there. A final reason for the attraction of caps on risk to participants is, I think, very legitimate concern about potential future abuse or perceived abuse in the future. You take a risk when you allow these bad people who govern our societies, etc., or these, commercially compromised researchers, put people at great risk. That's basically the argument. Regulatory permission to expose participants to high risks in extremely valuable humanitarian studies increases the likelihood that participants would abusively be subjected to very high risk, even in modest value studies as well. It may at least increase the likelihood that potential funders and participants, worried that this might happen, would refrain from funding or from joining studies. Since extremely valuable studies are rare, this increased likelihood of abuse and stifled research matters more than being able to respond optimally in these highly, highly extreme philosophers kind of cases that I've charted before. My answer is that potential abuse and the perception of abuse are real concerns, but we should not throw the baby out with the bathwater. Guidelines can demand added independent review for approval of especially risky studies. They can they can define more painstakingly what circumstances would justify high risk to participants. They can set severe penalties for overreach. That should provide the necessary assurances that we need. There's no need to undermine our ability to respond to pandemics and to other major diseases by banning risky research that is otherwise highly justified on balance. Again, this is pandemic stuff. This is, don't try this at home. This is not for your everyday disaster. This is for very special circumstances, and we're talking about that. So in conclusion, this talk both characterized and argued against caps on risk in humanitarian research, caps on risk to study participants, which forbid even humanitarian studies of the greatest social value and urgency whenever their participants would face high enough risks, may initially appeal, but they break, I believe, under the pressure of sustained analytical scrutiny. If we want to be able to fight MERS and other threats to public health as effectively and expediently as we can, research ethicists should forego caps on risks in research, at least in disaster circumstances. Study participants should instead be protected by other requirements, especially for informed consent, independent review, within the constraints of the study, minimizing risks, maximizing benefits, permission to expose them only to the net risks that are warranted by the social value of the humanitarian study, but not by this, not by a crude cap. We can give them other protections. Thank you very much.
And now Dr. Passimo is going to come.
I'm left with a lot of questions rather than a position statement, so I'm going to do that. To the speaker, my first question is, so imagine a scenario where, imagine a scenario where we had some type of humanitarian crisis. Let's pick a country, let's say it's the Democratic Republic of Congo, and there's a major international organization that's going there to help, and they bring along a research team that's going to do some research projects. So are you saying that your ideas would provide the guidelines for the operation of the process of, let's say, research approval for that case?
Yes.
Okay. So let's switch to Ohio State University. We have the IRB here, and this would be unacceptable, absolutely unacceptable. And I can think of no organization in the United States or process in the United States where it would be acceptable to have no limit on risk. So I'm having a problem here with reconciling those two cases. Is that on, or?
Do you want to give me?
It seems to me that if we have caps on acceptable risk in the United States in all our processes for research approval, why wouldn't we in the cases in the international humanitarian crisis?
What I'm saying would apply in the U.S. as well. So it's just that the particular scenario I've described was imagined in a war, not in the U.S. Maybe there could be an imaginable scenario in the U.S. as well. We would need to think about whether it could happen in the U.S. that we would have high enough prospect of social value in circumstances here.
Can you give me an example for the United States? I mean, we ought to be able to name one.
I didn't think about it. I'm not, suppose an example could not be found, so what?
Well, to me it matters because if we will not admit possibility of having no cops on acceptable risk for a variety of reasons in the United States, I don't know why we would when we're in another country in a humanitarian crisis.
Do you want us to engage in dialogue, or? So sure. I guess two kinds of responses. One is, remember, so it might be prudent from a regulatory point of view. If we think that it could never happen, we reviewed the possible cases, and it couldn't happen that this would serve a good cause in the US. And we know that there is always some possibility of abuse. Yeah, heaven forbid, a crazy redhead would become president, and who knows what the crazy person would do. Better not even allow that in the regs. So in the US, we wouldn't have permission to do that, and elsewhere I said the circumstance could arise where it would be functional. I wouldn't conclude too much from that, because we know why we didn't include it in the regulations in the US, namely that we thought that it's not functional in the US, and elsewhere it may serve a function.
That's my concern. I don't understand why it would serve a function somewhere else and not here.
Look, there are a lot of things that apply in disaster and don't apply elsewhere. For example, it was mentioned today that doctors can act outside the scope of their regular service, right? A pediatrician would help in something which is not pediatric care in a disaster, not in other circumstances. This is a familiar notion.
I'm okay with that part. I'm not okay with I'm having trouble. I guess the first problem I have is focusing on a cop, because to me, number one, all these are random variables, and by implying a cop, it starts to sense there's a view that this is deterministic to some extent, and it's certainly not. And then there's more than just one variable that's entering into the decision-making process for risk. And when these are random variables, I think there would be quite a bit of concern about the expected level of risk beyond what you thought there would be in the first place. There's a lot of uncertainty in the decision-making here. So some of the cops, in my perception of cops in the United States, are such that they're set conservatively, so there would rarely be a problem. So, but if you have no cop, then really anything goes.
There are many other regulations that prevent anything from going.
Yeah, I guess that's just a function too then of having a short amount of time to discuss it, right? Because when I look at this, I think of the other variables that are relevant, like culture. I think that does matter. The full context, socioeconomic, political, everything. And so I'm having difficulty not discussing some of the other relevant issues, and not. I guess I would, if you're going to come up with any kind of cop or a decision not to have a cop, I think the first people to talk to is the people where you are working. I mean, the people that are being helped and the people in that country. To me, that's essential. Or in my work, that's essential. We do not operate from Ohio State, where we have to be on the ground. So I'm not sensing that role of the voice of the people here.
I did mention in passing, actually, if you want to add a further requirement of, say, community engagement, I think nothing in this discussion, neither my opponents nor me are committed to denying that you could require that as well, and many, many other requirements. So the discussion is strictly about whether there is a cap, and the cap could actually take different forms. So I think that the critique that says, your critique that says, I don't even know, should the cap really be a simple number? Shouldn't it be more complex than that? If anything, that's a further challenge for my opponents. But I also don't think that it's a challenge that they couldn't cope with. They could make further specifications, but then stick to the basic notion of It's a matter of how high the risk and not how high the risk compared to the social value is. And this is what our debate is about.
I see. So in this, I'm not familiar with literature on comparative analysis of acceptable risk across international boundaries. Is there a large literature on that?
In cost effectiveness analysis, for example, sometimes, so the risks that people are willing to take regarding their health, for example, in some societies do differ than the ones in other societies. So that's an interesting point. It's an interesting question whether that difference should come into the calculation of the local cap or not. I reject all of these caps, so for me, life is easier than for my opponents.
Yeah.
So if maybe it makes sense now to open the discussion up to questions from the audience, if that makes sense. And Dr. Pacino, if you want to sit down.
Oh, sure.
Yeah. Any questions?
So do you see this as we have no cap on the amount of risk people go to for their country for war? So do you make that comparison? Would that help your argument?
I did not. Julian Savulescu, an ethicist from Oxford University, has kind of exactly that argument for a similar conclusion. So he says, suppose in the course of a war, you can actually approach soldiers who are at high risk from participating in the war effort and tell them, you can switch that for doing something really good. Instead of killing people, you could come and help save people, taking a similar risk to yourself. And he thinks that for that, because on the assumption that we were permitted to do that to people in the first place, namely send them to die at war, it follows. My argument hopes to be free from that dubious assumption, or to me somewhat dubious assumption that it's okay to send people to die at war in most circumstances.
So it is, I do see it as actually a really important parallel that people volunteer to die for their country in many cultural contexts.
Sure, and and to volunteer for fire.
I don't like your argument, but it's, I gotta say, like, it's
people take risks all the time, sometimes for the public good. So you could run an argument on that, right? They donate organs, they volunteer. It's not exactly a risk to your health, but it's supposed to be unpleasant to give money. When I donate voluntarily money, I lose money. So and firefighting and others, war is complex. I mean, who knows why? Maybe war is not. Basically, wars happen, and people are volunteered to go to war. But I'm not sure that this human practice is the most defensible one. So that's why I'm trying to stay away from that
one. I guess I'm looking for clarification on kind of the practical implication of your argument, and I think part of me reacts or has struggles with the idea that there is no cap, but I'm wondering if what you're not really saying though is that risk should not be taken into consideration, but that you would still say that given a very risky study, concerns about consent, concerns about the vulnerability of the population, there could still be a place where a committee or a research team would say, no, overall, we are opposed to the ethics of this study. But you're simply saying that in and of itself, the risk factor alone is not enough for you to say no-go on that study.
Totally.
Okay, thanks.
So I've had some reactions that are rather, what's going on here? But I think that's intentional. I think you're obviously trying to sort of spark some thinking. But I do like Elise's analogy to war. So we think about a draft, right? I was nearly drafted for the Vietnam War. My number was high. I thought about going to Canada, but I stayed in because another person would go and possibly die in my place. So I took that choice, took that chance, didn't get drafted. Now we have volunteer army. Who's volunteering for the army? They're not doing it for free. So your heroic volunteer may need compensation. You offer them $1 million, what's their life worth? Then you have undue inducement, and then you get poorer people signing up more likely, and that is the IRB problem. And that's the problem with our military. Who's fighting our wars? They're not children of college professors. They're not children of the wealthy. They're working class and people of color, predominantly, right? That's the distribution. That's who goes. Not because they're probably more heroic, because it's a career. And it's a good career. Gets you into, you get GI Bill, you get compensation for this risk. So do firefighters. Yes, there is some sense of duty, whether it's love of country or love of simply houses that don't burn down with people that you might love or think about wanting to save in them. But my problem with your heroic volunteer is either you pay them nothing. What a cheapskate! Who would presume to pay somebody nothing to put their life on the line to save millions? But if you compensate, then I think IRBs have a right to say and a duty to say who would then sign up, and that's why we protect people from undue inducement. That's why we don't pay $500 to enroll in a study, unless they're, well, we might pay that, but it has to be properly vetted so that you don't end up with poorer people taking the risk that a wealthier person, a more affluent person would not. And I do think there is a social cost to this that we have to factor in. You can run your numbers, but much of this is sort of unknown. We think of what the Spanish flu did. What would we have not risked to have prevented, you know, in a sense, one of the worst demographic hits on the world ever? We might have risked a lot more than we were prepared to do at the time, but who makes those calls? What are the societal impacts? Who presses that button? You know, that is sort of the trolley experiment, right? Sort of, nobody gets to make those choices. Throw yourself in front of the car and maybe you have something, but to say, I choose this life over saving these 10, that is in a sense tantamount to a kind of killing, and maybe even not murder, but some sort of notional sacrifice that somebody else makes. You're right to say it should be a heroic volunteer and somebody should consent, but do you compensate? And if you don't compensate, then really, for all of that incredible contribution, nothing? But if you start to compensate, how much? How much is that worth? And then you start going into who might be more likely to volunteer given the monetary compensation, not wealthy people. And then if not wealthy people, poor people, disadvantaged people, they're going to take that risk. It's an undue burden on them, and we have IRB protocols that says that cannot happen. Even if there is immense benefit down the road, we must protect ourselves from imposing those burdens on people unduly who are disadvantaged and vulnerable.
I would just, the only people who would be permitted to volunteer in the U.S. would be graduates of expensive medical schools like Johns Hopkins who need debt relief. The problem arises, you're totally right that the problem arises, you know, about how much to pay, but it arises in any case, it arises already for, say, toxicity trials already, so I don't think that it's fair to use it against this particular option, but I'm sorry.
The undue inducements issue is pretty big because it connects to what we're talking about. And I think it's right that you bring this up. I mean, and then the problem is that what we perceive as outsiders, as an inducement, a fair inducement, not undue, I don't think most people could come up with that. I mean, if you're on the ground working in a country, you know, low-income country, you may be able to give 0 as an inducement. And the reason is because they want to work with you because they think there might be something later. So you can exploit to the max. You can create all kind of risks for those folks, even if you pay them a penny. They're making $1 a day. Okay, so you got to think entirely different about this realm, and the risk that they're subjected to daily because of making $1 a day is incredible. They're on the edge, man. And then if you add onto that a humanitarian crisis, oh my goodness. So you can get them to do anything except any risk. That's, for me, when you see people like this, But I really feel like this would be unfair.
Thanks. Thank you. I had a sort of linked point, which I was thinking about in your slide about consent, where you were talking about people wishing to sacrifice themselves, the idea of heroism. And I think one can make an argument about the desire to sacrifice yourself. I think it becomes a very different kind of argument when you think about it from the responsibility of the researcher who is inviting somebody else to sacrifice themselves. So there are things that we can choose to do ourselves, but the actual idea that you're particularly in what's potentially a fiduciary relationship between a researcher and an individual, inviting someone is a very different kind of question. And my slightly flippant thought as you were speaking was, would the only acceptable participants in this study be the PIs of the study? Those who are actually, not just researchers within the study, because there are questions of influence and coercion there, but actually those who are leading the study. And I think that was the only place I felt where you could make that claim, that one could choose to sacrifice in that way. Thank you.
It's an interesting point about so I think in general the ethics of research, of medical research, is much more about indeed because people are volunteering, the ethics is much more about what is an indecent invitation to take a risk than it is about the way it's usually construed as the ethics of what is an unacceptable risk to impose on people, because we don't impose. We are hopefully doing it with informed consent. And my inclination on that complex issue is to say, I want to side, I guess, maybe I'm committed to the side that says, look, if the cause is important enough, I'm not doing it just for my career as a researcher. I'm doing it for a very important cause that you understand, we have verified that through the informed consent, and means a lot to you too. Then it's not just plain chutzpah to tell you, hey, would you be willing to help humanity and me and everybody else except yourself by dying for us? You may, even if it's chutzpah, it's just, the stakes are so high. I feel that, as an ethicist, I feel that something in me tickles. I feel that it's a little bit not okay, but for that ethical tickle, I'm not willing to sacrifice, response to pandemics.
Very much. And
Thank you.
Just stay standing. This won't take long.
I will send you.
Okay.
I'll send you an email. Okay?
I'm Ryan Nash. I'm the director for the. I'm the director for the Center for Bioethics here at Ohio State, and we're one of the co-sponsors with PREA. It's a joy to have help convene this. I'm sorry that I was in and out. I had issues, but from the parts of the conference I heard, it was a very great success. Congratulations to Donal Umhuna and Dana Howard, who put this together, and thank you so much to Donal for bringing not only his expertise and his passion for these questions, but also the opportunity to host such events. We hope the OSU Center for Bioethics was only formed in 2013. We're growing rapidly. I remember just 3.5 years ago, we were celebrating our first course that had 12 students enroll, and now we're teaching in an undergraduate program that Dan is helping or is leading. We're now seeing almost 1,000 students a year. We were excited that we were seeing clinical ethics consults when we went from about 10 a year in 2012 to after we formed the program to about 50 a year. Now we're seeing around 300 a year. So the program's growing, and it's expanding beyond clinical ethics and education to hopefully research ethics and questions beyond. And my hope soon is that faculty, such as the faculty you heard from here, and especially Donal and Dana, will have more and more impact on a broad range of ethics issues. I'm just going to share a small bit of insight. I can't help it. I do ethics, right? I have to give advice. Anyway, the talks I heard were everything from very practical, pragmatic, to more controversial and theoretical. I love the controversy and theoretical myself. I'm a physician by training. I do a lot of clinical ethics, and I like dealing with the controversy. You know, we've done those basic ethics, but I can tell you, I broke my neck in May. I was thrown from my horse, and I got to experience my own medical system as a patient. I thought if you would have asked me before May 7th of last year, I would have said that informed consent was done properly at my medical center. It wasn't. If you would have asked me before May 7th if people would always show kindness and compassion and humility and speak to me like a person, I would have said, yes, we teach these things. We have been teaching this for years. But that was far from universal. And it brought home a lesson that, though I like dealing with the provocative, I want to deal with the foundational, I want to deal with the great disagreements in society, one of the main reasons that this group of zealous people are here is they see something that's wrong, but once they grapple with that wrong, it's kind of annoying or frustrating that these the simple wrong things keep coming up. And I'm just giving you, we have to keep addressing the simple. We have to keep, there's time, in the clinical scenario, there's room for us to say again and again and again what a good informed consent process is. What actually communicating with your patient, sitting down and the basic give a damn principle. Many of you are doing what you do because you saw something or became aware of something that you think is wrong. Keep pursuing those things. But always remember that the person that's in front of you doesn't know that, doesn't have that experience, and keep sending the same, the basic message. Don't lose the basic message for the more complex or the ideal, because you can make a great impact with simple things. Anyway, I'll stop there and just say thank you for what I think is a very successful conference, and I'll let this whole, our involvement here is only because of Donal, and I'll let him officially close, as this is really his doing. Thank you.
Thank you, Ryan, and thank you, all of you. So why don't you give yourselves a standing ovation and a round of applause. It really has been a great opportunity to meet you, to engage with you. And I think we've had a lot of discussions about, well, what's next? How do we keep this going? You know, are we all coming back here next year? So some of those questions I don't know yet. But I have been talking with a publisher of a book publisher about their interest in taking the presentations here and developing them into a book. And so I got an email yesterday saying that they would like to see a proposal on what it is that we could do. They said the one thing they don't like about conferences is that there's a whole pile of lots of bits and pieces that are kind of very loosely organized. But I think we have a very clear theme here in what we've been hearing about, that there are these ethical issues that are unified around the theme of the dilemmas in humanitarian settings, and people trying to do both research and innovation and whatever else you want to call it, but it involves collecting data and trying to analyze it. So I will be in communication very soon with you about how we would move that forward. It's not something that anybody will be committed to. You may already have plans to publish your talk somewhere else. But for anybody who's interested in that, think about it, and we'll start working on that once I get a night's sleep somewhere in the next few days and do that. So I hope you have safe travels home whenever you are traveling home. If you get to kind of hang around the U.S. for a little while. I hope you enjoy a little time off. And I look forward to staying in contact and having more to do with you. So thank you very much.
No, that was great. I would have liked more. So anyway, thank you. That was great.
Thank you.